outcomes in so many things. But of course, medical errors can occur. Oh, by the way, this is that Innovator Health Company. I mentioned Dr. Summers, who's one of our community members here. This is his company. Literally, I mean, he's saving lives across the world. As far as Guam, where he has these experts that couldn't necessarily be in these rural locations, providing expert healthcare to these places and all sorts of different specialties, including pediatrics and PICU and things like that. The interesting thing is, hypertension management is there. I'm sure many of you probably have seen and probably work with patients with congestive heart failure with the Wi-Fi scales. The hospitals send out the Wi-Fi scales, and when the weight gain goes up more than a couple of pounds a day, and then somebody from the hospital calls out, and the nurse practitioner says take some more Lasix today because your weight scales go up. It really has changed things, and I can tell you that it's actually changed the dynamic in many ways. Eric Topol, for those that you don't know him, he's like this world-class physician based out of Scripps Institute in California. One of my favorite books over the last 10 years is The Patient Will See You Now. And it was a little bit controversial at the time, but he predicted all of this, the emergence of telehealth, how we're going to change healthcare by really empowering the patient. So like right now, I mean, I can sit there and text and call my primary care doc, basically anytime I want. I pay $100 a month for telehealth. She gives me VIP care anytime I want. I mean, it's incredible, right? I mean, this is very different than patient experiences were, say, 10, 20 years ago. And it's only going to fast forward from now. And of course, that brings us into the whole topic of electronic health records. And I think, many of us in the room, have gone through that phase where, we were on paper charts. I remember I used to have to bring my ballpoint pen, and then I would also bring a ballpoint pen refill in case my pen ran out of ink during the day as a hospitalist, because I'd be writing so much. And, of course, fast forward to today. And by the way, people don't really know what caused the implementation of electronic health records, but believe it or not, it was actually the recession, the Great Recession, 2008. It caused Congress to pass the American Recovery and Reinvestment Act, which included what's called the High Tech Act, which was part of one of its provisions. And that actually made this huge financial incentive for physicians, healthcare providers to implement health records. And so, of course, you can make the argument, was the technology really ready for widespread implementation? And are we still doing catch up right now because it wasn't, fully baked at the time? That's certainly a possibility, but, here we are, right? And I can't imagine in 2024 ever going back to a life without electronic health records. It's so much better now. When I'm practicing on Epic, taking care of patients, seeing, patient data in real time in all these different places, there's no way I could ever take a safe care of a patient without EHRs. But of course, there's unintended consequences to this. Look at the time spent on the electronic health record. This is a primary care doc study. And basically, the data shows that primary care docs, this came from the internal medicine literature, twice as much time on the EHR as they do with direct patient care. They have this thing called pajama time, if you guys are familiar with it. The CMIOs, if there's any CMIOs in the room, common term pajama time. So it's how much time that your docs are going home in their pajamas at night completing their EHR. And it's fascinating data. I'll never forget this hospital system CMO went over his data with me one time. And he happened to be a pediatrician, so he knew all the pediatricians there. He says, okay, and they were all his friends. He said, okay, look at him. He's our number one pediatrician in the entire system. He has 0 pajama time, and he's the most productive, highest RVU of all the pediatricians. Look at his colleague, and she was on there till 1 a.m. every night, spending hours and hours a day. So and the quality metrics were excellent for both the two. So obviously there's things that we can do to decrease our pajama time, but as a hospitalist, when this study came out, I was really kind of perplexed. This was a mature electronic health record system. And they actually looked at time that the hospitalist would spend on electronic health records versus time they spent on direct patient care. You can make the argument that EHR is indirect patient care because you're reviewing labs and putting in orders and documenting the notes and stuff like that. But look at that, it's 5 times as much time on the EHR as you do direct patient care. So of course, the unintended consequences, you see these patient reviews sometimes about, our colleagues, and they're like, the doctor's like always looking down at their computer. All I see is the back of them because their computer's over there on the shelf somewhere, and their back's to me the whole time. And or the patient's been going to the same doc for 40 years, saying, hey, doc used to spend all this time with me. Now they just spend time with the computer and all this other stuff. So these are part of the unintended consequences. But of course, any technology that's introduced always has unintended consequences. And, years ago, you talk about prevention of medical errors and they talk about your bad handwriting and stuff like that. But there's actually pretty good data that EHRs have the potential of causing, errors as well. Incorrect information on the chart. How about the one, pre-populating template? It's, with the hospitals group, that I was practicing earlier this year, it was templated, right? So we do have these dot phrases in Epic, right? I think everybody knows these dot phrases, right? So we'd have the dot phrase for the group that we would use. And of course, the dot phrase had something about, patient ambulating well and stuff like that. And then you walk in the room and the patient's like a bilateral amputee, and like, okay, did you, was this just a dot phrase, or did you really, pay attention to what you were putting in the system? And who knows, it could have been just like the hospitalist that just happened to be doing a locums there that week. And somebody says, use dot HP for your dot phrase, and, and they didn't even really know what was going on in it. So, but yeah, so all these things are concerns, incompatible systems, yeah, this is one I'm guilty of sometimes, EHR related user error. I think that's the one I get in trouble with. Tabbed patient. So, if you use Epic out of the box, it automatically comes with 3 tabs, right? So the last 3 patients that you looked at, including the one that you're currently looking at, and it's so easy. I mean, how many times have somebody called you up or whatever, or you're talking to a nurse or whatever, or a patient's asking a question, or a family member walks up to you when you're, at the computer station, and then you turn around and all of a sudden you put the orders in on the wrong patient. It's just so incredibly easy. In the old days, we didn't, this wasn't really a thing, right? I mean, it rarely was. But, you could just kind of tell, that patient that's been in your practice for like 30 years, the chart's like, this thick, and it says, volume 6 of 6 or whatever, right? As opposed to that patient that you're seeing the first time for a strep throat, it's skinny chart. I mean, it just, there was a lot of other, visuals and cues otherwise, but we don't have them anymore. It's amazing. So, okay, so I'm going to change notes a little bit. So I've actually determined, so if, Disney's like, the Disneyland, I guess, is the happiest place. Disney World's the most magical place. If those are like the happiest places, the Physician's Lounge is probably like the unhappiest place in the world. And the reason why I bring this up is that burnout is associated with medical errors. And I think we probably have all seen the data, right? Burnout's like, a major problem. And, a lot of times, a lot of docs, have some burnout going on. I can tell you, so I'm like, I'm a medical school dean. I can tell you, I talk to docs all the time, and they're always looking for a escape valve. And, it's like, and I feel like so, empathetic to them, right? I mean, it's amazing how many of our colleagues, are experiencing burnout. And, of course, sometimes, changing careers can make a difference. Although, I mean, it's the sad part is that academic medicine has about the same amount of burnout as, traditional, non, clinical practice. I'm not quite sure why. I think intuitively we would think that academic medicine would have less burnout, but of course, burnout equates to medical errors. And so at some point when the burnout gets pretty bad, patients, get harmed. So, all right, so I'm going to ask you guys a question. How many people in this room have had a friend a colleague, a physician that you guys know, or a friend of yours that died from suicide? Right. So here's my story. This is Jacob Neufeld. So Jacob, we would go out to dinner. I've gone to dinner with this guy probably like 40 times, right? Good friend of mine. He was up in Idaho. He was such a friend of mine and a colleague. And, he told me one day, he was like, oh yeah, I'm going through some burnout. And, and I think a lot of times, we almost get into kind of autonomous mode. Of course, empathetically, you respond to them. So sorry to hear, and, glad that you're going to take some time off, and, those type of things. And, I kind of went on, right? We like many of us, we have those conversations, we move on. Had I known the week after that, his wife was going to find him with a dog collar to the fan in his home hung, I would have done a lot of stuff different, right? I mean, who would have known, right? But of course, there's a lot more under the surface, right? It's like a glacier sometimes, right? You only see like at the top third, and what a great. And I went to his funeral. His patients were in there. He was a pediatric PM&R, and all these patients coming up to the podium saying how he saved their life and changed their life in these miraculous ways and stuff like that. And it was just so sad. And of course, every suicide leaves victims, right? But of course, at least according to his own claim, it was related to, or at least the evidence suggests it was related to burnout. So doctors' suicide rate is the highest of any profession, right? Remember when we were kids, they always used to say that like the dentist always had the highest suicide, right? It was like urban legend and stuff, and maybe it was true at the time, but we're actually the highest rate of anybody. So we're like triple, the national average if you compare us to the general population. And here we're like the smartest, right? At least we're supposed to be like the smartest, right? And it's amazing. And a lot of reasons why, right? I mean, we have a lot of pressures. We have high socioeconomic pressures. We have patient expectations. We have financial expectations from third-party payers and hospital systems and employers, and now we're more employed than ever. And of course, we're not immune, right? The whole country and the whole world, I mean, much more depression than ever. You would think in this world of connectiveness and social media that, we're social creatures and maybe we'd be happier, right? But it's actually not true, right? I mean, we're like, the least amount of happiness ever. Some people blame it on the technology. There was a correlation because we've had this increase in technology, but how do you explain all those people that have had an increase in depression and things like that over the last 10 or 15 years? Some people said maybe it's the smartphones. Some people said maybe it's the social media, all these other, things, but there's something going on in our society that we have it more. And of course, you can tell pretty quickly. I can, when a doc comes up to me, and a lot of times, they're talking about, medical education opportunities, which I love, right? I mean, I want everybody to be involved with medical education. But it's like, you can usually tell pretty quick, they're emotionally exhausted. They've been through so much, right? They, patient encounters and stuff that they can't take it anymore, right? Depersonalization. You're just a number, right? You're that Epic number that you type in the Epic system with your big healthcare system. You're not even a physician anymore. You're not even the doc anymore. You're a number, right? Depersonalization. They talk about that, where they talk about decreased sense of personal accomplishment. I just didn't accomplish as much in my career as possible. So when they have that, that's like the classic triad of burnout. And so you could always tell pretty quickly that I mean, this is a colleague that we need to help support and, be there for. You answer, if they call you at 11 o'clock at night, you answer the phone because they need a friend, and you want to always make sure your phone's on for them. And of course, the triple aim, was the classic thing about, improving healthcare, societal, public health, cost, access, quality. But now there's the quadruple aim. So it's physician and staff wellness, right? If we're not around to take care of patients, we're not doing service for anybody, right? Or if you get burnt out and then you're causing errors, I mean, that's a problem as well. And believe it or not, the statistics go, that's the equivalent of a fully built medical school, fully at capacity medical school, people, physicians in America dying each year due to suicide. So this is like, super big problem. And so it's very pertinent to medical errors, but it's also just pertinent to all of us just being good human beings. And And you know, I'll say personally, I took a deep dive in this, right? A few years ago, and I was actually after, you know, my friend Dr. Neufeld died, you know, I really kind of reflected again. So if like, you know, depression, burnout's like on one side of the spectrum, you know, happiness is on the other. So I went through and I read, you know, Neil Parisha's, work. I don't know if you guys have ever heard Neil Parisha. He's like the happiness guru or whatever. And so, yeah, I attended his talk, and he just wrote a book called The Happiness Equation. It's a great book if you guys are ever interested in this. But I took a deep dive with that and then some other literature and stuff. But he actually, you know, presented the data at this, you know, talk. It was like one of these hospital association talks, and he was really good, by the way. And he said 3 things have been proven. He says, number 1, exercise outdoors 20 minutes a day. You know, something about being outdoors and also exercising statistically, like, you make you more happy. Number 2, you want to do random acts of kindness. I think this is the hardest of all of them. And number 3 is you want to do positive journaling. And it could be, you know, the iPhone now has that like journal app that you could do it in there at the time. So, you know, my daughter, you know, she's 13 now, but she was, you know, littler. We started this thing, and I would ask, you know, we would ask whoever's around the table, if you ever have dinner with me and my daughter, she'll ask you, what's the best part of your day? And by focusing on what's the best part of your day, it causes your brain to focus on that. And, you know, as opposed to just always focusing on the negative, because our brain constantly wants to go to the negative stuff, right? You know, that's us. That's part of our differential diagnosis of physicians. You know, we always go to the worst case scenario. You know, could this be cancer? Could this be, you know, MI? Could it be something really bad? But by doing these 3 things, I can tell you, I'm like the happiest I've ever been. So I ride my bicycle, you know, 20 minutes a day. We do the positive journaling as a family. I try to do the random acts of kindness as much as you can. And again, that's the hardest one for me to do sometimes, because, you know, finding opportunities. But I give that to you just as a gift, as a friend, if that can help with any of your happinesses. But I also discuss empathy during medical school. So we actually start off as like super empathetic human beings, right, before medical school. And then there's this, and by the way, this literature comes from, you know, Jefferson Medical School up in, you know, Pennsylvania. And, you know, so medical students are like super empathetic. And then once they hit the 3rd year, and maybe, you know, and maybe some of this is historic a little bit, you know, when hospitals and the ERs were like super cynical and stuff. And now that we have, I think, more positive environments overall, but the empathy goes way down. And so, you know, the question is, you know, how can we improve empathy? And it's actually been shown, you know, even if you have this intrinsic empathy, which I think most people that go to medical school have that intrinsic empathy. And by the way, you know, people always want to talk about, you know, next generations going to the dogs. You know, if you ever saw, you know, It's a Wonderful Life, right? You know, around the holidays, I watch it every year. It's like one of my favorite movies. You know, if you ever see Old Man Potter, you know, he says, you know, the next generation, it's going to the dogs, right? And of course, the next generation he was talking about was the you know the greatest generation, right? I mean, it was just incredible that that folks would you know, have always kind of thought that the next generation is going. The current generation of folks going into medical school, this Gen Z, I mean, they're like the most focused on service I've ever seen. If you look at service projects that are going on, I was just talking to one of our attendees here today. He's a pediatrician that does the free health clinic, you know, teaches medical students. They are so enamored with serving others and helping out humankind. It's amazing. And so I'm actually thinking that the current generation, they're going to be the best generation of physicians ever. So I'm like super excited about that. But of course, the challenge is, how do you, us in general, you know, even if we have high intrinsic empathy and we somehow go down, you know, when we're around these patient encounters and get cynical and everything, how do we have really high, and the answer is intrinsic empathy. When you can actually have empathetic skills, right? There's functional empathy, right? So we start off with intrinsic, but to have functional empathy, being able to use empathetic skills to improve patient outcomes. And by the way, does everybody know the nurse mnemonic for empathy? Oh, this is going to be great, right? So this is going to change your life, right? So about 10 years ago, I was at Campbell University, North Carolina, And, you talk about, don't look under the emperor's clothes and stuff like that. So I was an associate dean, and, it's a new medical school at the time. And, it's like all hands on deck. So I had to like kind of help out teach a course. So my friend, Vicky Caprillion, who's another associate dean, was running the course. She said, okay, tomorrow we're going to teach empathy to medical students. And I'm like, okay, great. I'll, tell them to care. Yeah, it's all good. But she said, yeah, there's this new study, the nurse mnemonic. And it's actually been proven from the literature to improve empathy outcomes if you use this nurse mnemonic. I said, well, why wasn't doctor mnemonic? She's, I don't know, but just try it out. So anyway, so I went home and I studied this thing that night. And the next day I taught the students, they actually asked me, and I said, yeah, I just learned this last night. I haven't tried it at all, but you name the emotion. And this is how you deal with patients that are going through a lot, right? And you can actually use this in real life. Somebody that's, very, very, struggling with some type of, empathetic challenges or whatever, they're, really upset patient. But you start off with the N for name the emotion. And like, you don't really, you want to kind of de-escalate a little bit. So just kind of de-escalate a little bit. Name. U stands for you understand what they're going through, et cetera. R stands for respect, respect and give reassurance to that patient, respect the patient. S stands for support, you want to support them. And E is you want to explore from there. So, I told the medical students this, and, I left and I said, yeah, this is pretty good. It sounds good. I think I'll try it, right? I was in the ER the next day, a little place called Lumberton, North Carolina, Southeastern Health, 300-bed hospital. We took care of the largest Native American tribe in North Carolina called the Lumbee Indians. Patient was in room 3. The ER doc comes out. He hands me the chart for room 3, a little paper clipboard he had. He says, yeah, good luck in room 3. I'm like, what do you mean? He says, yeah, good luck. He said, it was the daughter who was extraordinarily upset. Her dad had lung cancer, stage 4. He was cachectic as all, hemoptysis, COPD, had to be intubated. He was dying. ER doc obviously felt that, probably shouldn't be intubated, probably should be focusing on hospice and stuff like that. And he says, yeah, have fun, and then, and of course, it's like, it's not what you want to hear when you're admitting a patient, right? And then, the nurse comes in, she says, you're going to room 3. She says, I'm going to go with you. I'll bring the popcorn, right? So, she wants to go in. So I go in the room and I take a history and physical, on the patient, with the daughter there. And, of course, she was, very upset. She was upset at the previous physician. She was upset with the hospital. She was upset with everything. So I said, well, maybe I'll try this nurse mnemonic, right? So I said, okay, it sounds like you're upset. So I named the emotion N. Well, she was like hysterical, right? I mean, a little bit. I kind of de-escalated. I said, she's upset. U stands for understand. And I said, I think I understand what you're going through. I mean, for me, if this was my father going through this, I'd feel the same way. And I really understand this. R, respect. I respect you for being there for your dad. He's so lucky to have a daughter that really cares for him like you do. S is support. And I said, you know what? Whatever you decide, intubate or whatever, I'll be there for you 100%, and I'll support you, and we'll do it. And the E is explore. Let's see what's next. So I kind of, said, what are your thoughts? And she said, Doc, what would you do? And I said, well, if this was my dad, I would focus on his comfort. I probably wouldn't put him on the breathing machine. I'd be focusing on his dignity and all these things like that. And she said, I'm going to do that. So she signed the DNR, puts him in hospice. I get the hospice involved and everything. I'm walking out of the room with the nurse, and she was the one that was coming in with popcorn. She was like, oh, I got to see this, right? She was like, that was like magical. And I'm like, it really wasn't. I'm like, I just learned this nurse mnemonic thing. And okay, nurse. So she takes paper towel, right? And she writes it down. Okay, what the N stands for what? The U stands, and I just have this vision. This nurse has this little paper towel somewhere that she gets out and uses it once in a while. But it's great in life. I remember my director of IT at ICOM, he was struggling with a faculty member that was like stressed out about, computers or whatever, and, empathetically approaching him. So I told him the story. He wrote it on his little whiteboard. And so even to this day, like when he has faculty and staff that are grumpy about IT, he goes through that empathetically. So anyway, that's, my small gift to you. So, it's going to change your life next time you're in one of those situations. try it, and it's functional empathy. So I think that there are ways that we can overcome this empathy and empathetically care for patients. So let's talk about handoffs. As we talked about, we have all these different specialties and things like that. So there's something called iPass. It's a way to hand off patients to other docs. It's actually been shown to decrease preventable errors by 30%. And this is another thing, like if you haven't done this in your practice, this is another thing that can change your life, right? And I guess it's probably almost any specialty. Maybe you're a cardiologist, this is actually a handoff function inside of Epic. And I think Cerner has something very similar. Meditech, I'm not quite sure. It's been a while since I used it. But it's really just this function. And I was with one group. I mean, they were awesome. But they would do this as an always behavior. Every single time they started the patient, they would have this little summary in there of the handoff. And it was great. So like I'd come in, the patient been there 5 days, ready for discharge. I just copy and paste the summary. Man, half my my discharge summary was like done. So I did a little my dot phrase. I copy and paste this in. I was like pretty much done. But more importantly, when I was going to that patient and they were like, hey, this patient's respiratory distress, I could look really quickly, figure exactly what's going on with the patient and communicate. And so you talk about something that can improve your patient safety immediately. Think about this iPass. And even if you're a solo doc, think about having that in your chart. In the old days, you'd see this mentor that would write off, these little social cues on the chart. And he says, oh yeah, cousin's a gold miner, right, on the front of the chart. And so, they would instantly know, and that would trigger a whole bunch of things like that. I mean, you can do the same thing by just having some of those relevant, details on the chart. So again, think about something like that. So, little things like, we have daylight savings time coming up soon. These little things actually have been shown to, affect mortality. And of course, you as a physician, when we do have daylight savings times, you have to regulate your clock, and, these type of small little interventions make a difference. Now, if any of you have taken your boards, and I know that we're going to continuous certification, so I think this is more relevant to the people taking their boards nowadays, but most of the boards actually have heuristics on the boards. More importantly, they have heuristic errors, and they ask you what type of heuristic errors have been involved. And really, heuristic errors are really these heuristics are cognitive shortcuts. To get through any patient encounter day, you have these things in your brain. Like, if you walk in the room, the patient has right upper quadrant pain after meal, and you pause the Murphy sign, you instantly know this is cholecystitis. You don't have to go through the whole pathophysiology sequence, right? I mean, you just have those shortcuts in your brain. And the cognitive shortcuts are great. That's how we function. That's why you got in your car today. If you drove here, put your foot on the brake before you went in reverse. You didn't even think about that, but that was just part of your heuristic thinking. It was one of your cognitive shortcuts that you had to do. And part of that was trained into you because it was a forced function, because the car won't go in reverse if you don't put your foot on the brake. And so the challenge with these is that some of them cause problems. The first one is confirmation bias. So this is when you're stuck on confirming a diagnosis. I'll never forget, I was in the ER one day, and the triage nurse wrote in the chart, bilateral leg pain, stroke rule out. ER doc saw the patient. It was a busy day. I mean, this was a great ER doc. I don't know. I think he maybe just didn't have enough caffeine that day. He put it in a stroke suspect, bilateral lower extremity weakness, stroke suspect, for us did a CT scan. And I'm like picking up, this thing, and I'm like, bilateral leg pain, stroke suspect. I mean, that makes like zero sense, right? And so I talked to the patient. She just had influenza about a week or two ago, and she had some bilateral lower leg weakness that was ascending. And I'm like, yeah, this is, GBS until proven otherwise, right? Ascending paralysis after study of influenza. But, you could see how that triage nurse, by writing right stroke suspect, it just kind of got propagated throughout the system. And of course, it's always uncomfortable, right? Go up to your buddy and say, hey, come on, bilateral lower extremity. You don't want to be like that person that's telling like their flies open, but sometimes you should, right? So this is another one, availability bias, right? So remember, I'll never forget H1N1. Remember when H1N1 came through, and I guess the same thing with COVID when it came through, everything was H1N1 or everything was COVID, just because it's so readily available. That's the availability bias. Yeah, you think about what's around you, and we do this all the time, right? I mean, I see people just because it's readily available, they think about that, and not only in medicine but in everyday life. Anchoring heuristic. This is something when somebody gets just stuck on that diagnosis, it has a, and some of these kind of are very, very closely related, but, people get premature closure. So I'll never forget, I had this patient one time with chronic, quote unquote, chronic chlamydia. And all this patient had was like adult onset asthma. But because chronic chlamydia was such a, sexy diagnosis, everybody wanted to call this patient chronic chlamydia. And so, so I see this patient and, I mean, she had kind of classic adult onset asthma, and they'd given all this Zithromax and stuff, all this other stuff, right? But it was just adult onset asthma. Framing effects. I'll never forget this. I was in the ER at Broward Health in Broward County, Florida, and Broward Health, Broward General is a, it's the place where they take, the jail patients. I mean, we had like the super rich, but we also had the super poor sometimes, and it was closest to the Broward County Jail, so they would bring in all these handcuffed patients, right? So this guy was handcuffed, so he was sitting there. The residents came and saw the patient. All these patients got IV drug use. I'm like, well, they have infective endocarditis. I'm like, well, why do you think they have infective endocarditis? Well, they got a fever, and I saw track marks, and they were so impressed that they like picked up track marks on physical exam. I'm like, oh, okay, sounding good. I walk in the room and I'm like, hey, hi, sir. And, the cop was there in the room and stuff like that. And the guy was handcuffed and he's like coughing and stuff. And I'm like, oh, tell me about that. He's like, I suddenly came on with a sudden onset fever, respiratory symptoms. I feel like, train hit me, all this other thing. I mean, the guy just had influenza. I said, okay, swab this patient. And they'd already ordered like TEE and all this other stuff, right? And it was just, I just swabbed them and it came back influenza. So anyway, but yeah, so it's framing effects. They had those things, they really got excited about that. The blind obedience, right? I mean, we've seen this before. You have this great consultant, somebody you really trust, and every time she's told you something in the past, she was always 100% on. Well, sometimes we have to always double check everybody's work, right? Gambler's fallacy. So I had a neighbor one time. So he had like 5 daughters, right? And he was like, I'll never forget, he was about ready to have his 5th child, and they were all girls. And I said, what are the chances? And he thought, oh, well, heck, I'm gonna have a girl again. And he was right. But what's the chance of having if you flip a coin 10 times and it's always heads, what's the chance of 11th time being heads? 50-50, right? But the gambler says, oh, well, whatever, right? It's going to be heads again, right? And but anyway, false belief that past occurrences influence the frequency of future occurrences. And of course, this is the base rate neglect. And this is like, those wise old attendings always told you to do it. People get stuck on these rare diagnoses when they know they hear the hoof beats and they smell the horse manure. Sometimes it's a horse, right? Not a zebra. And this is classic wisdom that sometimes we forget. So I'm going to talk briefly about black box warnings too. It's something when we talk about medical errors that we sometimes leave off. So black box warnings, it's the highest of the 5 warning categories of that. Now, so this is another one that kind of blows me away. People are still given promethazine IV, and I get it, right? You have that patient, and it's always that person that, it's the only thing that works with my IV Dilaudid to stop me from itching, right? Or something like that. But but if you do like that YouTube, there was like that woman that like lost her arm. She was like a guitar player and stuff. So you can really cause limb necrosis, and you're really supposed to be very careful. And so I never get promethazine IV. But it's a tough argument, right? If they're one of those people that they're sold on promethazine IV, I mean, it's I don't care how charismatic or your bedside manner is like through the roof, right? I mean, it's tough to talk them out of it, right? Codeine after TNA. So I know there's some pediatricians in the room. That's a black box warning. All these kids were dying after getting codeine for a tonsillectomy. opioids and serotonin, right? I mean, this is one of those things, we went through the whole opioid epidemic and stuff, and, and all these years, right? It's like, I think they first started using like codeine and heroin like over 100 years ago, medically. And it just took us till 2016 to figure out you can get serotonin syndrome from opioids, right? Of course, serotonin syndrome is like another one of those syndromes where I have to like go back and like look up, because I had it memorized when I was a resident, right? But you kind of have to go back and look through the symptoms again. So this is another reason why we have so many challenges. This is the number of medications that the average internist needed to master. And it was a study from 2011 from Bob Wachter. He's a famous physician at University of California, San Francisco. And in 1960, it was 15 medications. In 2011, it was 400. So in the course of one lifetime, you had like almost a 30-fold increase in the number of medications the internist needed to master, right? Which is kind of crazy, right? And think about it now, right? It's like every time I turn on TV, it's like some like ad with like a jingle, and I'm like, what the heck is that, right? Of course, you put your game face on the family members, and look up Hippocrates real quick. Oh, of course. Well, this is the new psoriasis medication or something like that, But yeah, it's incredible. All right, so I think everybody in here, so I'm under OCC. I know there's probably people under MOC, the high frequency, low stakes assessment. Years ago, we probably all had questions about the board recertification, right? And of course, the people that are grandfathered in, they're like, yeah, I'm grandfathered in, they're like, pretty happy right now. But the idea was that you would get recertified every, 6 to 10 years, depending on which certifying board you were. And, I can tell you, when I recertified in 2013, man, I'd spent all this time studying and all these review books, and I was top of my freaking game, right? Yeah. And so for that first year after, I knew every zebra, I was good, but after a couple of years, you kind of forget some of those things, right? But then it's, for my boards, it was 10 years, right? Till I had to go through one of these big exams again. And so it was really the wisdom of some of these certifying boards to switch over to basically high frequency, maybe annual, low stakes assessment. And so now I have to do these modules every year that improves my medical knowledge, which makes a heck of a lot more sense. I'm always continually to improve my skills ongoing. And so that kind of makes a lot of sense. I can tell you, so if you read this book, and I know Dr. K back there, he's probably smiling, right? This is like his favorite book. He's a former dean at PCOM. If you read this book, you'll know more than most academic folks ever. And I don't care if it's academic physicians or other things. This is the compendium of higher education evidence basis for learning. It's called Make It Stick. It's these Harvard folks that go through, and it's just incredible. But it also makes sense that we have this plasticity, and if you go more than a certain period of time, you lose it. Even with the ACLS, if you look at the literature for the American Heart Association, their own literature says after like 3 to 6 months, you actually forget how many compressions a minute. And I'm just happy I remember that that Night Fever song, or what's it called with the Bee Gees, right? Yeah, Staying Alive. Yeah, Staying Alive, right? That's the only way I remember. It's like, was it 100 to 120 or something, right? So, but of course, they change it every time you do it. It's like one time you're supposed to give rescue breaths, and one time you don't, and all this other stuff. But yeah, Make It Stick, incredible book. And think about how far we've along. So this was a painting up in the Philadelphia area. I forget which hospital. They call it the Agnew Clinic, the name of this painting. But it's a medical school. So they're giving this woman a partial mastectomy. And of course, this was actually painted. I have the year on there somewhere, but I think it's like 1880 or something like that. They actually knew about pathogens, but they weren't wearing masks. I don't see any gloves. Yeah, the surgeon, I assume this is the surgeon back there just like pontificating or something like that. No modesty for this patient. This woman was getting a partial mastectomy in this room full of men. And look, 54% of all DO students are women right now. There was like no women in the class, right? I mean, it's just incredible how far we've come along, and thank goodness, right? But I mean, it looked cool, but it was not so good. And that's one of the reasons why I love the osteopathic profession. So if you actually go back and you look at the charter written by A.T. Still in 1892 of the American School of Osteopathy, he says the design of which is to improve our present system of surgery, obstetrics, and treatment generally, and place the same on a more rational and scientific basis. He was saying in 1892 evidence-based medicine. And back then they were giving like arsenic to patients. They were doing partial mastectomies in front of a group without any hygienic measures and all this other stuff. I mean, it's just incredible that he really foresaw it. And of course, it's one of the many reasons why I'm so proud of our profession, right? I mean, we were evidence-based before evidence-based was sexy, right? But of course, some of the challenges, and one of the things we're supposed to talk about is the use of non-approved FDA treatments, like the snake oils of the world. And they call it snake oil for a reason, because literally that was like one of the first way before the FDA, but they were trying to peddle their wares and make some money off people, and the snake oil was supposed to cure everything. And now we every time you turn around, somebody's trying to hawk the modern day snake oils, and obviously it can cause patient harm with some of these things. We're also supposed to talk about the inappropriate prescribing of controlled substances during this. And I know that you have that separate session on, prescribing controlled substances, but I'm also required to talk about the prevention of medical errors. I've got a friend, she's a medical school dean. She carries around Narcan in her purse. I'm like, are you on opioids? Do you have any family members? No, but she does it. She buys it like, one of these grocery stores. I saw it at Publix the other day. I think it was like $35 or something like that. You can just buy it right next to the pharmacist, right? But she just carries around. She says, you never know, especially this kid fentanyl, and my kid takes a piece of candy they're not supposed to, and it turns out to be fentanyl or whatever, and I can save somebody else's life by just giving Narcan, and it's pretty amazing. And so we still have all these challenges with opioids. And so everybody always, when they think about an opioid patient, they always think about that person that actually is, well, I'll get to that in a second, but, so examples of controlled substances is not just opioids, it's benzos, tramadol, testosterone, methamphetamine. Oh, by the way, this is Barry Schultz, MD. He was from Delray. He was that guy that got busted down in Delray doing all the opioids. And, 60 Minutes, it's a fascinating 60 Minutes segment. And he's made the mistakes so many people have in the history of 60 Minutes, right? They think they're going to save their name by going on 60 Minutes. Usually not a good idea, right? So 60 Minutes is in the room with them. They were like, Dr. Schultz, why did you give all these lethal dosages? And tell us about the pregnant woman who was 9 months pregnant that you gave, 300 Oxycontins to, or whatever it was. And, he just got upset and tore off his microphone and did the walk out of the room. And so I don't think that was an effective strategy going on 60 Minutes for Dr. Schultz, but I think he's probably still in jail right now, convicted felon. But anyway, so opioid withdrawal. People always think about the meiosis and everything. Somebody's in acute opioid effect, but sometimes we forget these people that are just they come into you like binging for drugs, right? They have the mydriasis, the pupils are blown, yawning. They're yawning a lot. Increased bowel sounds, piloerection. You guys know what piloerection is? Yeah, goosebumps, right? Yeah, irritability. Diarrhea, they're like in the bathroom, they're like mean to like medical assistants and everything. They have the tremor, right? So, because they're withdrawing, and lacrimation, they're like crying and upset and stuff like that. These are signs of opioid withdrawal. By the way, everybody knows how you can tell when an opioid addict is lying. Their mouth is moving, right? So you just have to be extremely vigilant of these type of things. So anyway, so that's my opioid discussion that's required for this talk. Prevention of pressure ulcers. I can tell you, this is another area that we've dramatically improved care over the last 25 years. When I was in training, I remember, you go to the nursing homes, like so many of them had, decubitus ulcers, right? I mean, it was just so common and stuff, and, people coming home. But, of course, we've done a really great job. We do the risk assessment. We have the, specialty mattresses if they're increased risk. We, do the interventions, rotating them Q2 hours, keep them clean and dry, focus on nutrition. I mean, making sure they have the Ensure boost or whatever, if they're, cachectic, all these different things. And we've really made a difference. And I can tell you, It took me a little while because I mean, there were docs that would say, "Oh, it's just an inevitable part of patient care." Well, it's not anymore, right? I mean, we know better nowadays, and I can tell you, I've taken care of so many um, patients that had special needs, that they were, you know, immobile at home. You know, the family would come in, and you've seen these family members. They love this family member so much. They're always bathing them. You know, if the skin's dry, they're moisturizing them. They're rotating every 2 hours. They don't come in with decubitus ulcers, right? So it is a preventable condition, and we can make a difference. And we have, right? I mean, it's just amazing what we've done over the years. And how about fall prevention, right? I mean, I remember one time it made headlines that this hospital had no falls in an entire month. And now there's hospitals that have no falls over the entire year because all these bed alarms and, you know, avoiding sedative hypnotics. You know, I remember when I was first in practice, you know, somebody said, "Oh, you know, I can't sleep in the hospital." It's like, "Oh, no problem. Here's the Ambien," right? You know, we'd much rather have the Ambien instead of the Restoril. But you know, of course, nowadays we know that, you know, the Ambien is also associated with falls and, you know, things that we just didn't really appreciate back then. You know, nurse call button, always make sure it's next to the patient. You know, those rugs at home, right? You know, making sure that those little slip rugs or whatever they, you know, I think they call them slip rugs for a reason, right? You know, so you want to try to avoid those in the home setting. So failure to monitor the safety of prescribed medications. And, you know, these are some of the common culprits, right? The anticoagulants, the QT prolongation, polypharmacy. You know, as a hospitalist, it's always amazed me, right? You know, I send patients home, and like 2 years later, I readmit the same patient. And I saw that I'd started them on Protonics just for GI prophylaxis, that somebody accidentally discharged them on GI prophylaxis. They come back 2 years later, they're still on the PPIs. And of course, you know, that's been associated with, you know, they maybe have some osteoporosis or hypomagnesemia and cramps and all this other stuff. I'm like, yeah, you got to, you know, watch these things, right? Compliance of missed dosage, monitoring common side effects, all those are important. You know, I briefly mentioned before about routine foreign objects in surgery and wrong site patient surgery. You know, I can tell you this is one of those things that we you just can't have happen anymore. You know, you really can't. I mean, this is something that everybody takes, you know, extraordinarily seriously. You know, it's a big deal. It's a sentinel event when it happens. And, you know, we require the timeout for every procedure, and just, you know, always double checking. We have to have a culture that we're always trying to prevent these things. And of course, you know, Morgan and Morgan, they love these cases, right? You know, so we talked about communication being the #1 cause of medical errors in America, right? In terms of the root cause of the most serious things. But, you know, things like checklists, and this is pertinent to the surgeons in the room, you know, wrong site, wrong patient surgery. Checklists have been proven to be effective. You know, if you ever want a great read, Checklist Manifesto by Atul Gawande is an amazing book. You're gonna end up having checklists for everything in your life, right? But it has been shown to, you know, decrease errors in surgery. You know, limiting distractions. You know, you always see in like the Hollywood movies, like they're always listening to music. Well, it's actually been studied. If you're listening to music, it is you know, it is a slight increased risk of errors. You know, teamwork, right? You know, just working together as a team. I mean, let's face it, you know, your colleagues, you know, on the team can save you, right? You know, and if you're cool with them, you know, and that's sometimes it's good to have these good relationships, right? Relationships makes the world go around. And they'll say, "Hey, doc, you know, are you sure you want to do that?" Right? That's like your best friend. That person just saved your license or saved somebody's life. You know, and obviously you want to try to prevent super high stress environments. You know, you want to, you know, have a friendly environment as much as possible, and, you know, try to be cool as much as you can. And then of course checkbacks, you know, check in on PO. How are you doing? How are things? Yeah, let's hear it. You know, checkbacks. Team steps is, so the federal government has AHRQ. This is basically the safety division for healthcare for the US federal government. And they have this free program that anybody can go on to ahrq.gov's website and download this team steps, and has a whole curriculum on there. And it's a matter of, you know, team performance centered around some of these principles: performance, knowledge, attitude. The military loves it. So like anybody that's ever done any military work has gone through team steps. Most of the medical schools nowadays have that incorporated in there. Here's some of those checklists I talked about that you can download. They're, you know, everything's an app nowadays. So also required to talk about is the failure to accurately diagnose the cause of back and leg pain. So if you look at the differential diagnosis of back pain, things like disc herniation, muscle strain, infection, but you also have things like, aortic aneurysm, aortic dissection, you can have the referred pain, fracture, cord compression, discitis. I'll never forget one time I was I was the only DO in this hospitalist group, the first one they've ever had. And so I'm sitting there, this is down at Lee Memorial, and, they were kind of struggling, they kept calling it fever of unknown origin. And it was a lady with opioid addict. And she was like requesting Dilaudid all the time and stuff like that. And I was like, okay, well, where's your pain? She was like, hey, this is not opioid. I have like 10 out of 10 back pain at like T10. Of course, I MRI'd it. It came back, discitis or epidural. Actually, it was epidural infection. And anyway, of course, probably saved her life. Differential diagnosis of leg pain. You always have to think about DVT, malignancy, fractures, all these type of things. Failure to diagnose sepsis. I can't tell you how many times I've seen people just get fooled by, good old fashioned bread and butter sepsis. Typical presentation of sepsis: hypotension, tachycardia, fever, leukocytosis, but it can be all these little subtle things, right? The hypotension, the temperature, tachycardia, tachypnea, tachycardia over 90, right? I mean, sometimes when you're just going up the stairs, you can get up to 90. Laboratory signs, white count, white count can actually be low, and it could be, from sepsis, all these things. And I have them in the handout as well. So obviously correcting hypoxemia and establishing venous access for early administration of fluids, antibiotics are priority in patients with sepsis. And let's talk about some of the required neurological errors that we should talk about. So Guillain-Barré syndrome, we talked a little bit about, ascending paralysis, classically after influenza infection. It could be after a lot of vaccines, including influenza vaccine, infectious mononucleosis. The boards always ask about Campylobacter. Somebody just had a GI illness, Campylobacter, and all of a sudden has, ascending paralysis of the legs. These are the folks that you want to put in there. You want to, do like, hourly tidal volumes and stuff, and, administer treatment as early as possible. All right. So we all seen strokes. The most commonly missed stroke in America is cerebellar stroke. So the triad: vertigo, headache, gait imbalance. And I can tell you, this is one that's super tough, right? You have the, I don't know if it's, appropriate to say, but, I guess in the house of God, they would call it the LOL, right? It's not laughing out loud. A little old lady or whatever, comes in and she says, I'm a little giddy, which like took me forever to figure out giddy means like dizzy, right? And, had a little bit of headache, and their gait was off when you walked them. And maybe the first time you're seeing them, you're not sure if their gait was off. And, the family member says, we haven't seen grandma for a while. But, having a low suspicion to get an MRI on these patients with especially with this triad, super, super important. You guys remember Wallenberg syndrome, probably from like first year neuroanatomy or something, right? It's like one of those things you probably had it like cold memorized for the exam, and now you've forgotten it. But it's but this is the classic syndrome associated with cerebellar stroke: dysphagia, hoarseness, dizziness, nausea, vomiting, nystagmus, gait coordination, lack of pain and temperature sensation, unilateral face, uncontrollable singultus. What's singultus? Hiccups. Right. So that's a Wallenberg syndrome, and classically associated with cerebellar stroke. So another reason, if patients have some of these symptoms, have a very low threshold to getting that MRI. CT of left cerebellar infarction. Here's an MRI of the acute cerebellar infarction. So I'm going to switch over to talk about cancer misdiagnosis. So, cancer misdiagnosis is actually relatively common. In fact, if you look at all, cancer, it's like 28% of the time it's initially misdiagnosed. And if you look at the breakdown, and this has been studied over and over again, number one is breast cancer, number two is colorectal cancer. Arguably preventable, at least by secondary prevention measures, right? Colonoscopies, mammograms, et cetera. If you look at the number one cause of lung cancer in America, it's lung cancer. But lung cancer, it's like not up there. It's like number 6 on the closed malpractice claims. But here's what they're suing the docs on: breast and colorectal. So, again, a low threshold. They get a lump, breast surgeon, they, get that colonoscopy. 1% of colonoscopies are missed. And, by the way, and I'm sure that, many of you probably know this evidence. You want a very, very slow gastroenterologist, right? The person that takes out the scope super quick increases the risk of missed cancer polyps. And of course, it drives the gastroenterologist nuts because, some of them are very efficient and they can actually look very quickly and stuff. But of course, the hospital, like the CMOs and everything, figured that, when the studies came out and, made that quality metric. So, they can, withdrawal time, look at withdrawal time on gastroenterologists. So, all right. So this is another thing. I can tell you that we actually have evidence-based communication improvement over the last 10, 15 years. So in the old days, we'd say things to the family members, there's nothing more to do for your dad. What we should have been saying is, I wish there was something that we could do to cure his illness. Right? Whole different communication. Where in the old days, we'd say, would you like us to do everything possible? I mean, of course, people are going to say yes. What we should have said is, how are you hoping we can help you? I mean, sometimes the patient just wants to die with dignity, or they just want to go home their own bed when they die, or they just, they don't want to sit in their own feces. I mean, they're usually not very rarely, if patients are fully in the know, they're saying, I want you to be administering the chemo until that coffin lid lowers, right? I mean, patients don't say that, right? But if you look at physicians versus patients, we are actually less likely to get chemotherapy in advanced stages of cancer. We're also more likely to be do not resuscitates at advanced stages of cancer. We know, we've seen it. So to me, it tells me that there's a communication gap between us and the patients with this end-of-life care. And these are things that we can make a difference with just by, our words that we say. In the old days, we'd say, oh, we're going to stop the machines, right? Well, that's super scary, right? It's you're going to kill, abuelo or, I mean, what we should have been saying is we want to stop the breathing machines and use medicines that would make his breathing more comfortable. So subtle little communication things can make a world of difference to your patients. And those patients that probably would like to have, a little bit of dignity and probably not, spend the rest of, the remaining 37 days of their life on tubes and ventilators and, that would probably rather be surrounded by family and be comfortable. Sometimes we take that away just through the communications. So we can do things better. So, so I'm the dean of, Florida's 11th medical school, OCOM. And this is a topic that, I spend most of my life focusing on, which is, training the next generation of safe physicians. And, if you haven't seen a medical school lately, do. I mean, what we're doing in terms of, there's the OSCEs, which are standardized patient scenarios. We put them through things like, delivering bad news or dealing with a quote unquote difficult patient and all these different things, or the simulation scenarios. We actually just got our simulation equipment delivered this week. I mean, they breathe, they blink, they vomit, they, everything. They have this fecal spray that you can actually spray. Something smells just like C. diff and everything. I mean, it's just amazing, the technology. And you can actually combine it with patients. You can have scenarios where, okay, the patient's hypoglycemic, doc. Well, what do you want to do? Well, give an AMPA D50. All right, here you go, doc. And it's clearly labeled insulin. And they're sitting there pushing the insulin. What'd you just do? You just gave insulin. You just, the patient died, right? And you have the standard of patient. They don't die, right? It's it's a mannequin, right? But you can give them lessons that they would never ever do ever again. So it's just incredible. You teach them electronic health record charting. The technology that's just emerging is just incredible. And we talked about that. All right, so take home points. Okay, so we're going to do this the old fashioned way. We're going to call out just like family style, right? When you go to the family restaurant. Okay, so what's the most missed stroke in America? Cerebellar. Excellent. What's the profession with the highest rate of suicide, unfortunately? Physicians. What's ascending paralysis after influenza? GBS, Guillain-Barré syndrome. And what's the common root cause of medical errors most commonly in America? Communication. And okay, what's the ocular finding you see in a patient with opioid withdrawal? Mydriasis, it's blown. You guys are awesome. So thank you so much. It's been a pleasure and honor. Hey, I'm here if you guys have any questions afterwards. Thank you. God bless. Thank you. Thanks. Thanks. And we have, if anybody wants to have any questions here, happy to answer any questions in front of the group. Otherwise, be happy to answer one-on-one afterwards. All right. Thanks, guys. Doc, did you have something? Yeah.
Oops, is this on? There we go. Just want to thank you for all the work you've done around the country, starting medical schools, educating our next generation of physicians. That's great. I've been in practice now, I said in Melbourne, 41 years, and I was a sniffus before that term ever came out. But when we were students, this is why you teach students, we sort of got tired of them saying, do the H&P, do the H&P. And you're the doctor, you make the diagnosis. The tests only confirm what your diagnosis was. And part of that was your lecture. My father, unfortunately, was up in Pensacola, and he was living up there for a while, lived with me for a while, then he moved up by my brother. And we went to see him in the hospital on a Saturday morning. It was 11 o'clock. I'll never forget it. And he was having to urinate literally, I'm not kidding, by the watch every 5 minutes. He said his foot was killing him. So I pulled back the cover. It's red and it's hot. So it looks like gout. So I wanted to compare it to the other side. And his other leg was twice as big as the one that had the gout. And so I went out to the desk and showed the nurse my credentials. And I said, has the doctor seen him today? She said, oh yeah, the hospitalist was here 1 hour ago, 10 o'clock. And he said everything was fine. And I said, well, do you think I could talk to him? She says, well, let me call him for you. And I told him what my findings were. And he says, well, order whatever you want. He said, I'll tell the nurse you can order whatever you want. So of course, ordered a bladder scan, ordered uric acid, ordered a Doppler of the leg. And then they had to take him do some of these things. So she called me about a couple hours later. She says, Doc, you're right on every one. He's got gout, he's got urinary retention, he's got a DVT. Wow. So sometimes the hospitalists maybe get too busy. And that's one of the things, hands-on. When I have students that rotate with me, I tell them all the time, take the history, do the physical, and don't just rely on charts or tests. And that was with my own family. Next day, got congested. I listened to him. And they says, what do you want me to order? I said, chest x-ray. Yeah, he had pneumonia. So it's kind of, some of these things are basic medicine, but I think sometimes because people are in a hurry, and like you said, charting takes twice as long as seeing the patient. So I love to see the patient, sit and talk with them. So I hired someone else so I can dictate to her and she can put in the computer what I find and those kind of things too. So I make less money, but I think I'm still able to provide that one-on-one care and what we were really taught hands-on in osteopathic medicine. And that one slide about the back pain, we forgot to include some of the things like osteopathic, somatic dysfunction. And I find in the elderly, which I do geriatrics, a lot of their back pain is sacroiliac, believe it or not, more common than lumbar pain in the low back. We're talking about that. So it's just great when you love it. Also, when you love your job, it's not a job. And I talked to my pastor 40 years ago, and he says, you're like me, you've got a vocation, not a job. And so I just want to tell people with that, when you're happy with what you do, and even if you're not making as much financially, but you feel you're doing the right job, it makes all the difference in the world. But again, thank you for what you do.
Thank you, Doc. I really appreciate it. Well said. And thanks. And thank you for the 41 years of taking care of patients in Brevard County. Very impressive. Yeah. And by the way, I'll just leave you with, I don't see anybody else up. I'll leave you with one other thought. And, it's something I'll be talking to the medical students about, on their first day of orientation this summer at OCOM. An expert is a master of the basics. So the fact that, doing the history and physical, that makes you the expert. So anyway, well, thanks again, everybody. Really appreciate it. Thank you.
Want to listen ad-free, download music offline, and keep songs playing in the background? Get YouTube Music Premium.
You again for lecture.
Oh, you're welcome.
Totally appreciate it. Get this out. If you need extra water when it's going on, just
Okay.
signal me.
Let's see.
The mic is on. Oh yeah, you gotta time yourself.
Where's the countdown? Yeah.
All right, you ready?
Yeah.
Okay, I think we're gonna get started with our next speaker. So this lecture is Prescribing Controlled Substances by Dr. Joel Rose. Little history on Dr. Rose. He has an extensive experience with the Florida Board of Osteopathic Medicine, having served on the FBOM for 18 years as an appointee of Governor Charlie Crist and Rick Scott. He served as chairman of the FBOM and Osteopathic Medicine's Physician Assistant Council and Anesthesiology Assistant Committee. He also served on the Standing Joint Florida Board of Medicine and Florida Board of Osteopathic Medicine Committees, Medical Marijuana Consent Committee, Pharmacy Formulary Committee, Telemedicine Committee, Wrong Side and Wrong Site Surgery Committee, Office Surgery Rules Revisions Committee. He received his DO from West Virginia School of Osteopathic Medicine, completing an internship at Pontiac Osteopathic Hospital. He is board certified in family medicine by the American Osteopathic Board of Family Physicians and is in private practice. Selected as Physician of the Year by Hillsborough County Osteopathic Association and Florida Osteopathic Medical Association, the FOMA. The Florida Osteopathic Medical Association awarded him the Distinguished Service Award, and he is chosen to be a trustee for the District 10 to the FOMA once again. He served on FOMA Executive Committee and was elected 2002 to 2003 FOMA President. He's a clinical assistant professor in the Department of Family Medicine at Nova Southeastern College of Osteopathic Medicine and adjunct clinical assistant professor in the Department of Family Medicine at Lake Erie College of Osteopathic Medicine in Bradenton. He is a fellow in the Federation of the State Medical Boards and the American Association of Osteopathic Examiners, and has participated in 2013 and 2017 Federation of State Medical Boards development and revision on the state's model opioid policy. So giving a lecture for prescribing controlled substances, please join me in welcoming Dr. Joel Rose.
Good morning. Thank you for having me back. So our topic today, you want to pay attention to, because if you have a DEA registration, which you were going to utilize in the next biennium, the state requires that you have 2 hours of these topics, and we'll talk about the objectives here in 1 second. So this is not any kind of thing I have any financial interest in, nothing really to disclose. My opinions are just that. They're my opinions based on my knowledge and experience. If you have something that's of legal consequence, I would suggest you contact a attorney who's admitted to the Florida bar and part of the healthcare division of that, because you need someone that specializes in these kinds of matters. So the objectives today, this is per the Florida statutes, or talk about the current standards for prescribing controlled substances, in particular opiates. You may have heard there's a big crisis with that, particularly fentanyl overdose deaths. Alternatives to these standards, non-pharmacological therapies, prescribing emergency opioid antagonists, and the risk of opioid addiction following all stages of treatment in the management of acute pain. So this is probably the newest thing that happened legislatively in Florida so far, pending whatever comes out of this current session, is Narcan is now available over the counter. You don't need a prescription to purchase it. These are Narcan available at my local Publix pharmacy. There's 2 in a box. They sell for like $49 in change. And I'm sure there are other distribution points where they are free through law enforcement and other places, maybe even the ER. So very important if you have someone in your family or you know someone suffering with opioid use disorder, it would be helpful to have these available in case of an emergency. It may be the only thing that saves their life and time. Works fast, works rapidly, doesn't replace standard care that you need after you administer this to resuscitate somebody, because you may, if they're further along, you may need CPR and other life-saving supportive measures, and may need repeat dosing of the Narcan as well. So it's there, it's available, and we'll talk about which patients should be advised to purchase this or provide a prescription to them. Their insurance is likely to cover it. And that's an intranasal administration. People dying each day from a prescription opioid, that's something one of us or colleagues may have written for a patient because it's a prescription, 45 people a day in 2021. Now, the statistics go back into 21, 22 because there is a reporting delay, particularly when it comes to deaths from overdoses and what caused it on a national level and also the state level. The Florida Examiner's report of drugs and deceased person, the last updated information I have is the interim report from 2022. It's the 23 information is not yet available. So of about 107,000 drug overdose deaths in 2021, 75% involved in opioid. That's, you know, could be legal or illegal, prescribed or bootlegged or manufactured in the community or somewheres. They believe the biggest source of fentanyl comes from China via Mexico into the United States. Of all the opioid overdoses, most of them were the synthetic ones, 88% fentanyl and its analogs. So it's a big problem. It's an increasing problem. The number of deaths continue to go up annually, national and state level, with not much slowing down. So from 99 in about 20-year period, the opioid overdose deaths went up 8.5 times. So whatever we're doing, I think it could probably be better because we shouldn't have those type of statistics. Something that's relatively new that they're starting to report, although it's not required in the state of Florida, some county medical examiner's office are checking for it, and that's xylazine. It's An animal tranquilizer used primarily for that purpose in the veterinary world. They call it tranq. It sedates and it's analgesic and relaxes muscles. It often gets mixed with other drugs. Some of these others you may have heard of, carfentanil. You know, we have fentanyl, then we have sufentanil, then we have carfentanil, which is, I think, about 100 times more potent than fentanyl. Flocka, you heard of that? The bath salts type of thing. All that's increasing. So when you look at these opioids, we say that it could either be natural or synthetic. Drug poisoning is just a death caused by the drug, whether it's intentional or unintentional. A lot of unintentional deaths if someone buys the medication off the street. It's often mixed with fentanyl. They may or may not know that. One thing that may help with overdose deaths in those situations is the state is considering changing the law such that you can have a test strip where you could test your drug and find out if it has fentanyl in it. Right now, it's illegal to have that. Hopefully something like that will pass because we got to start doing things that make sense to save lives. And that would definitely be one of them if they're readily available and people actually use them. Psychostimulants, things like methamphetamine, amphetamines, Ritalin, and those substances are also increasing. So here we're looking at deaths per 100,000 standard population and drugs deaths that involve xylazine, overdose deaths, yes. You can see it's predominantly more so in male than female, and you can see in the center of the total how that has been rising steadily since 2018. So that has come on the scene and is a problem. Opioids, when it gets mixed with other things, increases the chances of overdose deaths. The bottom is just cocaine by itself. The middle is cocaine and opioids, and then just all deaths involving the cocaine would be putting, merging those two graphs together, two bottom ones. So it's an accelerant when it's mixed with the other kinds of things. Same thing with the psychostimulants. So the opioid crisis, 220 American deaths per day from opioid overdoses, either legal or illegal, from the CDC. Main thing is, how do you recognize somebody that's overdosing? Well, it depends how far gone they are, but their pupils will become pinpoint. They won't be conscious too long. They won't be very arousable. They'll be sleepy and nod off. Their breathing will slow down and become shallow. You'll have what I call like the death rattle when someone is dying, the lungs start gurgling and you can hear that. They may have stopped breathing. Their body is limp. They have no muscle tone. They're pale blue. Skin is clammy, ashen, gray looking because they're not oxygenating very well. Fingernails turn blue or purple. So first thing always do, call 911, get them on the way. Hopefully simultaneously you're shooting the Narcan into their nostrils. If necessary, you may have to initiate CPR. And then, get them an ambulance, get them to hospital and other supportive care, IV fluids, might need a ventilator, ICU care, depending on what the clinical situation is at that point. Hopefully the Narcan did its job and you're continuing that as needed. And Narcan, it's amazing, works very rapidly in most cases. And then the person will wake up, what are you doing, man? What's happening? Why are you doing that to me? Like nothing ever happened. And a minute ago, they would have been dead if something had not intervened. Here's something that's on the scene as a problem. Who knows what drug this is? You should know because it's been in my slides for a while, if you were here last year. That's crystal meth, methamphetamine. You can tell it looks icy, crystal-like substance, and the number of overdose deaths from that has been increasing every year. Here showing the psychostimulants, mostly the methamphetamine, and maybe a couple other things attached to it in there, the bath salts and all, but you can see how the number of cases have gone up to 2018 from 2007, about 1,400 to 13,000 drug poisoning deaths. Almost every graph I show you is going to have an exponential rise because that's the magnitude of the crisis. The only thing that has done better, because there's less use of it, is heroin. And that's likely because all the fentanyl has supplanted it. So what happens? How do you diagnose someone that has an opioid use disorder? You may or may not know it unless you question it or observe them intoxicated or not, because that's pretty much stays hidden unless it gets to the point that the individual is totally deteriorated and disheveled and becomes homeless, and all those sorts of determinants that happen from drug abuse at some point, usually, unless you're wealthy enough to mask all that. So basically these drugs go in the brain, and most of them release dopamine, which is our feel-good neurotransmitter. So that's one reason why it's a problem in different areas of the brain that we'll talk about. Things that happen is they may be intensely intoxicated, and by using the drug, you develop opioid tolerance or drug tolerance that causes you to escalate the doses of what you're taking because you're prior drugs again to ameliorate all the withdrawal signs that can happen. And most of the time it's, total preoccupation with the drug. Where are they going to secure the drug? Where are they going to purchase it from? How are they going to get the money to get it so they can get their fix and stop all the painful and negative side effects of withdrawal with that? And then it becomes the point that they called incentive salience. So that's wanting the drug. You can imagine, it could be like with certain foods, you may not really desire it because you could be oversaturated with it, but for some reason you just want it, which is different. It's not the pleasurable component, and that's the driving force for addiction in the brain. It's like there's an old Richard Pryor album where he's talking about when he did cocaine that he's trying to stop it, and there's cocaine in the room sitting on a desk, and he says, it's calling out to me, say, Richard, I'm over here, so that's this wanting that drives the addiction to it. And even things that can trigger this, that's why they say people, places, and things. Well, if an individual sees a needle and syringe, that might remind them of using, and that could cause this to kick in and then want to use again. Maybe an environment or a place where they would use drugs, either in their own home or some shooting gallery or wherever, if they're by that or see that, that will make them want to use again, or people they know that are users, they have an influence in that. They're triggers to make them use again. In fact, they said they had a poster that had some things in it that they had to stop using for drug use, because individuals would see that and there would be triggers in it. So they had to change that. So it's, a very powerful thing, addiction, no matter what it is, whether it's cigarettes or alcohol or any of these drugs. it's like they have almost no control. So kind of what happens in the brain, it's, starts in the prefrontal cortex where, your executive functions occur and you're thinking about, like I said, where are you going to get the drug, how are you going to afford it, how are you going to get there, how are you going to get back, all that kind of stuff. And in the brain, then, it's binging, intoxication, the incentive salience we just talked about. And deep in the brain, it affects the limbic system, and you got your components there, the amygdala and basal ganglia, so forth, where once the drug is in, it's going to push the buttons, give you relief from withdrawal by hitting the receptors up. And then eventually that's going to wear off, of course. And the same thing's going to happen again. Withdrawal is going to start. You're going to require more drug to satisfy that, unless somewhere you intervene with the substances we have to help the cravings with that. And you can see there are different neurotransmitters that are involved with this, with a lot of projections in different parts of the brain. And there's a lot of overlap between the receptors on different neurons that are responsible for all these different substances. So sometimes if they run out of one drug, they'll try to substitute it with another drug to stimulate the receptors. Some of the things you may see, and depending on the practice setting, you have, patients may ask directly for certain medications. Most of that behavior, I think, has changed because they know the laws and rules have changed, and it's not as easy to get these drugs as it used to be. They may lose the prescription, say it was stolen, less so now that we're using electronic prescribing. With that, it's harder to do that. But they say somebody stole their medicines or so forth, that they can come in intoxicated or falling asleep. Family members may report things, so pay attention to them. And they may have, auto accidents and stuff because they're intoxicated. So look for that, or interactions with police where they were arrested for something, and that kind of stuff. So if they're going through withdrawal, they may have rhinorrhea, they may have a lot of sweating, shortness of breath, start getting some muscle cramps or fatigue, can't sleep, restless, early on, hours to days to weeks, could be more. You get, piloerection of your skin, goose flesh. They get very shaky, you can have diffuse abdominal pain, fever, chills, so forth. And that can continue further. So unfortunately, about 70% of individuals who had an overdose at one point and eventually died had at least one opportunity where there could have been intervention to help treat opioid use disorder or their addiction. So that's a loss. Primarily what we have are medication assisted treatments. We've had since around 1965, the methadone clinics. To be in a methadone clinic, you can't just prescribe methadone and say I'm treating a patient for their addiction. It has to be in a licensed methadone treatment facility by the DEA specifically for that purpose. You're not to use methadone for detoxification and maintenance outside of those facilities because you don't have the license for it. You can, and the confusion arises, you can prescribe methadone for the treatment of pain. There's no restriction on that, but not to have a maintenance clinic. Methadone's important because that's, and buprenorphine are one of the drug or two of the drugs that are used to treat neonatal abstinence syndrome. Subutex, which is just plain buprenorphine, I don't think it's manufactured anymore. I think there's some generic forms that they can use because the Suboxone that has naltrexone in it, they feel is much safer and less chance for abuse, so they don't take it and grind it up and inject it because the naloxone will just block it. So the first time we had treatment available that you could provide through your offices goes back to 2002, where they had this office-based opioid treatment where you can, at that time, register with the DEA after taking 8 hours of education, getting a certificate to have a DEA license to do so for that purpose. We'll talk about that. That's been eliminated now, but the type of things that are used under that program was first the buprenorphine, then the Suboxone. There's other forms of it. There's some implantable forms. There's an injectable form. Vivitrol is another medication, which is basically naltrexone. That's injectable. Once a month, you take that. And then another new medicine just helps fight some of the withdrawal things because it's an alpha-2 agonist is Lucerma. Pretty much what's being used now is clonidine. But this is more specific. However, this slide going through 2016 is showing the number of physicians who had that DEA license to prescribe buprenorphine. Didn't do that well. It was up in 2006 and then it went down. So it'd be better if we had more programs and more education, got physicians to handle some of the more simple cases through their office. So some of the things they looked at, much of the United States lacks access to medication-assisted treatment, particularly more so in the rural areas of the country. A lot of times people have to drive very far to be able to get medication to help block their addiction. Of 1.6 million people in 2019 with opioid use disorder, only 18% received medication-assisted treatment. So that should go up, and that would be helpful in combating overdose deaths. 42% of substance use treatment facilities offer at least one of 3 FDA-approved drugs. For counties have no providers to prescribe buprenorphine. Only 7% of providers in the U.S. have obtained the DEA waiver to prescribe buprenorphine. So, up until this time, not many physicians were interested in managing patients with opioid use disorder. Of course, it could be very challenging, and I can understand that, but I think with more training and experience, it would be helpful if many in primary care were able to do this for their patients and others. And it's more complex than just, of course, giving a medication, but it is very helpful. It should involve other things, counseling, treating any comorbid psychiatric condition that often is piggyback to these issues. This was just looking in Florida, the practitioner by state, in the state by county, the number that are there with I don't think it's the greatest slide because it's hard to read and look at and complicated, but it just shows where Florida is with, of course, the greater the population, the greater the number of providers will be. So this was happened last year where they eliminated the special registration and special DEA number. And DEA was strange too. I had one for a while, but wasn't using it. And so then they took it away. So, well, if you're not going to use it, you shouldn't have one because then we don't have to go to your office and inspect or whatever. Then I talked to another person at one of these meetings from the DEA. Oh, they should have never done that. Well, they did. So, but then I was able to get it back again, just reapply because all the stuff was there. But now you don't need it to do that. You just have a regular DEA license, but you have to have the training. And these 2 hours would count towards that. So, and also have in here, you go online, the FOMA has courses online for the other hours. I think is like less than $100. to complete if you're interested. $899 if that was last time I checked for the other 6 hours. So this was just looking at different groups of practitioners and what they have to do to qualify. Most are probably of us are in group 3, which is what I talked about. You're protected under Florida law under special Good Samaritan sections about administering Narcan. You're immune from any action against your license, any civil action, or any criminal actions for attempting to save someone's life in good faith. And now it's over the counter, so it kind of even supersedes that. Some of the medications used to treat side effects of withdrawal, this I think is the VA, it's a VA protocol. Clonidine for the autonomic symptoms, sweating, tachycardia, myoclonus. You can also use a muscle relaxer, baclofen or gabapentin or tizanidine. For anxiety, it's usually an antihistamine like hydroxyzine or diphenhydramine, that's of course Benadryl. Myalgias, non-steroidals, acetaminophen. There are different, topical preparations that can be used. For the muscles, sleep, trazodone is the big one. And you can see nothing that is controlled. Nausea, promethazine, Zofran, and all those things. Dicyclamine or bentyl for cramping, diarrhea, loperamide, bismuth, subsalicylate. So lots of things that go along with medication-assisted treatment, particularly counseling. There can be, acupuncture, hypnosis. There was a judge in Hillsborough County that used to order acupuncture for individuals who were convicted of certain drug-related offenses. Hospital treatment programs in an outpatient, faith-based things like Salvation Army. That's just flat out, you go in there and you just, after you go through your withdrawal, you're admitted and you don't use anything. Work, they put you to work for your room and board and counseling. Very successful if individuals do it. Of course, they have a lot of dropouts and they get drug tested frequently, and many people, they're kicked out immediately if they violate anything. They're out on the street. They don't mess around. Important thing too, when we talk about this, I just can't just write a prescription for Narcan or tell them, "Oh, go get Narcan because you might need it." Well, you need to make sure the family is educated, their significant others are educated, because it's not going to be, chances are you're not going to administer it to yourself as you're going out of the world from overdosing. So those around them have to be knowledgeable and educated and recognize the signs and symptoms of overdose that we've talked about, and administering the Narcan and doing it right away and calling 911 and all those sorts of things. That's what's important. And chances are if they're coming to your office and they're a patient of yours already, that would be possible. But in the community, I think they need to have outreach and programs about reversing overdoses, because if, they need to be educated, they need to know, and that you just can't throw the Narcan out there and it's going to teach everybody when it should be given and all that. So I think there needs to be public service announcement, news coverage, and interviews with physicians and other clinicians about that. And also some people get in trouble, particularly if they were incarcerated or otherwise not able to seek drugs for whatever reason, because within a week or so, you may have not taken the drug, you may lose the tolerance that you developed. So individuals may start taking back the amount that they took before they stopped. And that's wrong because they're going to overdose. And takes as little as a week to lose all that tolerance you've built up from the opioids. And going back to the same amount is going to create trouble. And I think you see these things sometimes in accidental overdoses, particularly older patients who may have other medical conditions and are using this for pain control or other things that may stop for some reason, and they don't know if they're off a week or two, they can't take the same amount they were taking before. And then they, you know, put a stigma on, oh, they overdosed and blah, blah, blah. Well, it was an unintentional thing because they didn't know that. But and they can restart the medication at a safe level and do that. So there's some statistics that show a lot of people that had an overdose end up back on the drug. Well, in some cases, there's good reason and it's okay to do that with education, because it wasn't a drug abuse problem or opioid use disorder. It's just the fact that they weren't on it and their tolerance got lost. Of course, it's increasing in all populations. Women 4 times more overdose deaths in pregnant women. Of course, pregnant women bring babies, what's now called neonatal opioid withdrawal syndrome. And the individual baby may require opioid use. And you can't use naloxone. We talked about that because it can cause withdrawal. You don't want that for the infant. So it's Subutex or morphine. And the number of babies with neonatal abstinence syndrome is increasing, which is bad for the family, mother, child, and big expensive costs to the healthcare system. So it's important they get the treatment during the pregnancy. Neonatal abstinence syndrome, it could be low birth weight, premature, maternal mortality problems feeding the infant, breathing problems, some of the things that are there. So you can also use methadone. Methadone, I think, is a scary drug because, as we know, the analgesic effects wear off much sooner than the effect of depressing the respiratory system. So a lot of patients who die from methadone die because they have pain, so they take more methadone, but the level of ability to stop your breathing stays there, and you're just making that worse, and you're taking it too frequently because you think it's okay to take it because the analgesic property wore off. But that's, you know, one of the worst things you can do, but there are some people who still prescribe it for pain. Again, the emergency treatment for suspected opioid overdose from the Florida statutes gives you the ability to do that, and the protections you need legally. Again, this had expanded things where the pharmacist, prior to the new over-the-counter thing, the pharmacist could prescribe it or order it. So I think what happened is a good thing. So who in your practice should get this is a matter of course. When you should prescribe it, recommend it, or advise that they have it on hand is if you're taking more than 50 morphine milliequivalents per day or greater. As you may know, that is just the milliequivalents is like equating all the different substances to a certain level to know it as a guideline. Florida doesn't have any restrictions with that. Some states do as part of their prescribing. And when you go to eForce, it'll show you all that, how many milliequivalents has been prescribed. If they have COPD, or sleep apnea, they're a greater chance of having respiratory difficulty caused by these drugs. If they've had benzos, regardless of the opioid dose, they should have that. You know, there's segments, and it is generally a no-no, but a big no-no to have a benzo and an opioid together. And if you do that in your patients, you're going to get some kind of utilization thing from your insurance company or the middle manager about that. You know, and the right doses and length of time, it can, you know, I think can be useful. There's a lot of people who still need to take both of these things, but you need to monitor very carefully and pay a lot of attention to those individuals. If, you know, they have had a problem with alcohol or opioids in the past, they're a greater risk. So they should be advised to purchase this or prescribe it for them. Probably the best thing is just to prescribe it for it, then you've documented a record that you've done that. So if they use other drugs or misuse prescriptions in the past, use other stimulants that we know that can potentiate the dangers of taking opioids. If they're getting treatment for an opioid use disorder, they should have that in case they relapse or start using something. And again, if they were incarcerated in a situation where they were away from drugs in case they start reusing again, now that it's available. Drug overdose deaths, we said the last count for the United States is around 107,000. They don't have any new data since this slide. I looked at it, there's all blank. Nothing there yet. But you can see it leveled off for a little while in 18, 19, and then is going back up. That's just looking at where Florida fits in, about a 21% increase in the United States of drug overdose deaths up until that time frame to 2021. Here's Florida's data, kind of mimics the same time frame as the United States in general, same type of trajectory. We had a little better improvement though in 2019, where in the United States it was flat. We went down and then back up. This is just showing the trajectory for different drugs in the country. You can see where the opioids took off. That's largely due to fentanyl. And you can see synthetic opioids, the second line, and psychostimulants, heroin, cocaine. We'll look at some of the Florida data in a minute. Where most of the drugs come from, well, someone came in another person's house and saw the drugs and took it. So most of it came from a friend or a relative. Some got it from their doctor, about 21%. You used to be able to get some from the internet, a lot less from the drug dealer than I would think, but there's a slice from there. Of course, before we had electronic prescriptions, they could, you know, steal the blanks and forge it. And then, well, where do those people get them? They usually got it from one doctor who was writing it for them. This data goes back to 2015, so I imagine it's a lot different today, because the amount of prescriptions that doctors write for opioids has gone way down, and we have the new guidelines that are required in Florida. How did this get so bad from, you know, the prescribed end? Well, there's, I think, a lot of people involved in big pharma involved, and these companies that are like the wholesalers after the drugs manufactured, it goes usually to one of these companies who then sell them to all the big pharmacy chains and everybody else. So, you know, it starts at the top with the company, the Sackler family. There's been a lot of TV shows and things about them that own Purdue Pharma. And Of course, these companies and even the pharmacies locally are held responsible for that. And that's why a lot of the ability to get these drugs for patients with cancer or chronic arthritis or other things became very difficult, because they get audited if they reach certain thresholds. Nobody likes to be audited. So they, clamp down on who they would sell them to and the amount they would get. So for legitimate use of the drug, it became very difficult. I could not imagine having cancer not be able to get drugs to help alleviate your pain. So the Sacklers are on the outs. They were protected for a while, but the Supreme Court took that away. So they are their fortune is personally responsible for damages. We're all familiar with this, the 3-day, 7-day rule that started in 2018. This is reproduction from a FOMO brochure that I think explains it very well. So we'll go through this to make sure when we're prescribing these drugs, when we feel they're necessary, we're doing it appropriately according to the state of Florida. So generally there's a 3-day limit, and we're talking about for acute pain, and the kind of acute pain we're talking about doesn't include cancer pain, terminal condition, palliative care, or the intensity score that gets assigned at hospitals of 9 or higher. So most of us don't deal with that. It's not for chronic pain patients. If you're treating chronic pain, as we're aware, you have to write on the prescription is acute pain exception for that. If you're going to give the 7-day supply, put that on the prescription. Make sure you have a complete medical record, as you do with any patient. You have a controlled substance agreement and a copy of their driver's license in the record. eForce, everybody knows what eForce is. It's where you can register, get into the system where you can check to see what controlled substance prescriptions individuals have been prescribed, so that you can eliminate doctor shopping. You can make sure you're not duplicating something they got from another doctor they didn't tell you about. Every time you write a prescription for a controlled substance, you should check that, with the exception if it's someone less than 16 years of age. And there are some Schedule 5 non-opioids out there. I forget what they are right now, but you don't have to check it for that. If the PDMP is down, check it again. Maybe you entered something wrong. So always check it 2 or 3 times, and it'll usually pop up. If not, if it really is down and you can't find the patient, then you can give, what was it? I think a 3-day supply only, and record in your chart that it was down. But probably if you check it by the time you're done with the office visit, it'll be back up again. But it's pretty rare in general. So, or, they can leave and you can later in the day enter the prescription, because you're doing it electronically anyway. So it doesn't matter what time, you can check it later, or even the next day if it's not available. Most of the time for acute pain, it's not going to be more than 3 days anyway. There are penalties if you don't do this. I wasn't aware of any that occurred while I was on the board. I don't think it's been a problem for the state of Florida with that, but when you check it, I would put something in your note that PDMP was reviewed, because they don't really like you printing anything out from it, because it shouldn't be re-released to anybody. If a patient wants to see their record, they have to write the PDMP to get access to the data. You can't show them on your computer. That's a no-no. But you can just tell them they can get a hold of eForce, and they will make it available to them. So they don't want inadvertent release. So you can for the day, if you're having a lot of patients coming in, to have your staff print it out. And after you've reviewed it and seen the patient, you should shred it. Don't put it in the chart. I mean, you can, but then if someone wants a copy of their records, you're going to have to individually go through each record or their entire record to make sure you don't have any of this information in it. But there's nothing wrong with putting you check PD&P and you're prescribing blah, 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 or whatever you're doing. That's not a problem. They just don't want the actual data from there re-released. So we have to do this every 2 years in the state of Florida if you have a DEA license. If you don't have a DEA license and you don't want one and you're not going to get one, then you don't have to do this. But I think everybody should know what the extent of the crisis is in the United States and particularly Florida. We already talked about this. So with each visit wherein you prescribe a controlled substance, we would have to give them a pamphlet, remember, that talks about the things that alternatives, other treatment modalities for management of pain. Now, you don't have to have the booklet to give to them. You can give them the link as it's on the web, and that's sufficient because before they made them in all different languages and stuff too, so it became unwieldy. And each time they came in, they're supposed to have it. So if you have someone you're seeing every month for chronic pain medicine evaluation and renewal, they're going to have stacks of them in their house. So, you know, sometimes they make these laws, but they aren't thinking long-term of the consequences or so. And now it's available to them. But hopefully, and when you decided to initiate something in chronic pain management, you went over all these things anyway, and they're usually ending up with medicine as the last resort these days rather than the first resort, because I'm sure you've seen the brochures. They talk about all the kinds of things that can be done via the different professionals that the Department of Health regulates, you know, chiropractic, physical therapy, osteopathic manipulation, pain medication management with, you know, by interventional pain physicians that can do certain procedures. Non-opioid pharmacological stuff. You know, exercises you can do, behavioral health. So that just explains all that to them concisely. So pretty much what we have in Florida mimics what the CDC is recommending for acute pain anyway. This is the CDC guideline. Guiding principles for implementing recommendations, new data to expand content on prescription opioids for acute pain, new guidance on subacute pain, health equity and disparities in the treatment of pain. So finally, someone in writing has recognized the different kinds of pain. You know, acute pain could last up to a month. If it's from a month to 3 months, that generally is subacute pain. And then 3 months or longer, we characterize as chronic pain. We don't have anything in our laws that really recognizes subacute pain. It's just not touched. It's either acute or chronic by law in Florida. But clinically, that's not true. So hopefully you want to manage and treat acute pain well with the minimum use of opioid drugs if needed at all. A lot of people can have acute pain and don't really need an opioid. A non-steroidal will often work. Acetaminophen will often work. Other measures, elevation, ice, these kinds of things should be tried, or if you're using opioids for a short period of time, 3 days or less. You know, chronic pain is its whole thing. Usually by that time, they've had a complete workup to look for anything through MRIs or other differential diagnoses that could be causing their pain. And hopefully you've discovered what it is during the acute pain kind of situation, because if they aren't getting better with what you're doing with the acute pain, then you need to go deeper and look further with either, you know, MRI scanning, CAT scanning, referral to a specialist, get a second opinion, or whatever as to why their pain's not going away, because that's not the usual course of things. Because our aim is to prevent, you know, having someone develop an opioid use disorder and being dependent on these medications. So in Florida, we have our own definitions. The main one I'd pay attention to is acute pain, because remember when we discussed that, and in our rules and laws, it doesn't include terminal conditions, cancer, pain, palliative care, those traumatic injuries with that score, which is usually not that high anyway when if they were in the hospital. Chronic non-malignant pain, that's generally what we're talking about. And again, after 3 months, it's considered chronic. Something pain they have, they could have surgery or something where the pain is still persisting. And then addiction, we need to know the distinguish. It's not the same as a physical dependence or tolerance. You know, I've seen people labeled an addict because they, you know, went through withdrawal or something. They went to the ER and they put that label on them, and may or may not be true. But addiction simply is just a chronic relapsing brain disease that can get better, then it can relapse. It's, you know, this wanting of a substance. Originally started for maybe psychic effects, or it could be just the normal course of treating pain. Someone's in an auto accident, they get injured somewhere, they get started on an opioid, and then in time, no more than a week, they can become addicted to it. So because they have that wanting, and it just escalates, gets worse. Tolerance, we talked about that. We know the longer you use that substance with time, you're going to develop tolerance. It's going to take, you know, more of the drug to get the same effect. Physical dependence, that's just, you know, a matter of science. You stop taking the drug, your body's going to go through withdrawal. That doesn't mean you're addicted to it. You could not be addicted to it, but your body is requiring these substances now. Otherwise, you're going to get side effects when you stop them. Pseudo addiction, this one I know is arguable. It's when you think patients are having substance use problems because they need more medication, and it mimics addiction. It's just being inadequately treated. Substance abuse is taking something for the purpose not for which it was intended, taking something to get a psychic high from it. So we know physical dependence is going to happen when you abruptly stop something, because then you're going to trigger withdrawal. Addiction is that wanting, it's the craving. Compulsive use despite harm. And it is a brain disease because there are changes in the way the neurotransmitters work. There's a structural change in these receptors in the brain and the connections that are made. So it's a natural structural situation. Then in the state, we define certain specialties for purposes of the laws and rules. Certain things, if you're board certified, you don't have to follow. And then how do you determine if someone is board eligible, or because board eligibility can expire after a while, and the different specialties have different time frames. So we just defined our own for our purposes of enforcing these rules. And, you know, there are different people who certify pain medicine doctors. So we created a list of how we consider someone board certified in pain management. Some of the boards, you don't have to be a physician to be certified in. So we didn't really recognize that. Board eligibility, we set the time. If you finish your residency program, but you didn't get certified, it would go for 6 years, no matter what, for the anesthesia, physiatry, rheumatology, and neurology after finishing your program. So acute pain, I was on the committee where we drafted the rules for this. It's similar to what we do anyway, just a couple of special pieces in here. Again, acute pain, we just went in and redefined what we've talked about a few times already. The PDMP or the system we talked about, what that is whether you prescribe controlled substances or not, you should hook up with the PDMP so you can see what your patients are doing or taking. Substance abuse, you know what that is. So like we do with any patient or any problem, we say you have to do a history and physical examination pertinent to the presentation. Doesn't mean you got to do a GYN exam or DRE or anything like that. That's not what we mean by that. It's specific for the clinical condition that you're treating for. If someone's having shoulder pain, we'd imagine you'd have a good history of everything, including medical conditions and surgeries and allergies that would influence what you can use, not use, or do for their shoulder. And you would take the history regarding the shoulder, the examination of the shoulder, and the associated joints that could cause shoulder pain, the neck, and so forth. And document that, you know, your treatment plan. Probably going to do an x-ray if they haven't had an x-ray, or if it's more significant, you may go ahead and want an MRI scan of that, whatever your treatment plan is, or you may just start them on anti-inflammatories and give them some time and exercises and at-home therapies and see how they do. And then you're going to come back and reassess, and you may give them something for pain that's a controlled substances, because these kinds of things can be very painful for a period of time till other measures take effect. But if you do prescribe something controlled, you got to have a write in the chart that you have an informed consent. And it's things you need to discuss with the patient, that you're going to have an opioid because the pain is so bad, you need something to give you relief while we do these things. And then we think you're going to need it for this long. And, you know, there are dangers with using these medicines in terms of addiction, blah, 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 whatever your routine is. And then, of course, you know, you're always scared when someone has had a substance abuse problem in the past, if you're going to open Pandora's box by putting them on something. I mean, some people have surgery and need it, or have an injury that's significant enough to need it. You need to be careful with that and monitor for that, and have an agreement you're going to use for so long, and you got to stick to it. Or it may be something that you need co-management with someone that's an addiction specialist, depending. But many of the patients who are truly committed to recovery refuse the medicines anyway. You know, they say, doc, I'm an addict. I don't want to take that. I'm going to suffer through it, or I'm going to do something instead. And of course, I know I've talked to dentists as well at some of their meetings, and there's, you know, dentistry is what they use to see the efficacy of analgesic medicines are. So if someone's had a root canal or the extraction, and then they test the medicine as to how well it works in them with pain. So, you know, if that's the standard, they're doing other things with long-term blocks or other things they're able to do to help stop the pain, or them not feel the pain for a prolonged period of time until they heal. Periodic review, you know, this was thrown in there because it's in the chronic pain, but many may not need it. They may have a laceration or something that heals up and the pain is gone. So you just may recheck them and remove sutures or something. But in the recheck, you know, might see them, someone comes back, they still have foot pain that hasn't gone away. You got the x-ray result, it was negative. They have to walk around a 600-bed hospital all day long in maintenance and engineering. And they have the pain. So you may order an MRI scan and find out that they have a stress fracture. That doesn't show up on an x-ray usually. So that's what we mean by periodic review. Go back and see if you need further diagnostics or referrals or whatever is appropriate medically. Get a consultation if you need it. Was really careful about the wording of this, because some of the statutes for the chronic pain say that there was discrepancy in our laws different than the rule, whether or not they have to see a pain management physician if they've had substance use problems or other things in the past. One place said shall, another said may. So, I mean, what do? You can make a referral, but you're not gonna go pick the patient up and drive them to the doctor's office to do their consult. So it's usually not of too much benefit anyway, because a lot of them just send the patient back to me and they don't say what to do about it. It's like, oh, what a total waste. This doctor gave a useless consultation. When you ask the question, do you approve them staying on this medication for their conditions? And all they say, oh, we're going to do nerve blocks. Well, the patient's already had facet blocks and stuff. That wasn't the question. So you got to call them up or you got to write them back and have them address what you ask. So those of you who are specialists who receive referrals from primary care, if they ask you something, please address what they ask you. If you want a continued referral relationship, we're here to take care of patients and we're asking a specific question of a difficult area to give an answer to, and you should be able to answer it. You may not want to, may not like to, but we have to fill out a lot of things that I hate doing every day with disability papers and return to work and how long they can stand, how long they can sit, can they climb? I mean, you really need a functional capacity assessment to do that. Otherwise, you're just guessing and it's useless. And then you have specialists who tell them they should not lift more than 20 pounds because they have a herniated disc. And then they're going to get fired from their job, where they may have already had the herniated disc all these years and they've been doing that job anyway. And there's a lot of people lifting 100 pounds every day that I'm sure have herniated discs they don't even know about. So that's also kind of sticky. So sometimes we have to do things that we aren't comfortable doing because they won't allow us to do a functional capacity assessment. But so, and it's a sticky thing. And many times those that I see in pain management, when the interventional procedures don't work, many are on some kind of chronic pain oral medication anyway. So, interventional procedures are great when they work, but they don't work 100% and they don't work for everybody. But when they do work, it's, it is fantastic. But, now no one wants to be responsible for putting someone on a course of addiction. So you got to keep medical records the way you do anything else. So just as a reminder, in your medical record, if you rely on some information from another physician or a test that's reported to you, make sure you have a copy of it in your record to show what you were able to rely on at that time. Particularly if you're doing things with MRI scans, if you're doing chronic pain, make sure it came directly from the source who did the test. It's very easy to fake results on the computer. You can just copy the letterhead and type on there someone else's results and say, well, here's my report. And they may have none of those things. So most of the things will be short-lived for acute pain, but drug testing, you do not required to do drug testing. That's optional up to the physician. For acute pain, acute situation, we're not talking about chronic. So that's where, made sure you had an option of doing that. There are not enough pain management doctors to see all the patients that would really need to be referred anyway. Again, if you're doing more than 3 days, you got to justify that in your records. There's problems with the PDMP, put that in your record. Periodic reviews, that's just a repeat. And of course, comply with all the other laws and rules. And there are many, many of them. So according to the CDC, of course, these things that are mandated down in Florida, when you're using these drugs for acute pain, you want to use it for the shortest period of time possible. You may need a little bit more because the expected course that they're going to be uncomfortable. You should estimate that. Long-term problems start with short-term acute situations. The thing with the pharmacists, these is from the pharmacy rules. These are their red flags. Patients saying they frequently lost their controlled substance medications. Like I always like to say, they call you and tell you, oh, I had my Xanax in the car and I parked it and someone broke in and stole it. Or they lost something and it's always a controlled substance. They rarely tell you they lost their Lipitor or Norvasc. Is always a controlled substance. So okay, fine. You have a police report? No. Go well to refill it or replace it. You need to report it to the police as lost or stolen. I need a copy of that report. See how many of them are going to do that when they know they're telling you a lie. Because then that's a crime, filling out a false report, unless it really was stolen. Somehow they get different patient names and try to get it filled. If they're going to more than one physician getting the prescription at the same time, they always pay cash, so it doesn't go through or get recorded through some kind of pharmacy system. And brand name products are worth more on the street than generic ones. So that was that. Haven't had too much problems lately with the pharmacists. I think things got a lot better when it went electronic. The patient, I know, sometimes has trouble because their pharmacy may not have it. They're vague about when they're going to get the medication. It can still be difficult for patients to get it. Most of us have an electronic prescription, but make sure everything is on there the way it's supposed to be. At some point, there are glitches in the system. At one time, was Walgreens wouldn't take my electronic prescription for a patient. So I called them up, talked. They go, well, your address isn't on here. I go, well, it's sent electronically. I can't control what's on there. You've never reported that to me before. Use your pharmacy all the time. So I had to write a paper one out and fax it over to them. It made no sense, but that's modern technology. I haven't heard any more from them. I guess it's working for them now. Maybe there must have been a glitch in their computer system because I send them now and they don't call and tell me they don't have my address. The main thing that we had problems with in the state of Florida as a board, when handwritten prescriptions were being used, the doctor would pre-sign prescriptions because he was going on vacation and his medical assistant would hand them out, fill them in, hand them out for patients that came in. Don't do that. It's like writing a blank check. You wouldn't write blank checks and leave it around in your examination rooms. So don't ever do that with a prescription. What you could do, if you had a nurse practitioner or someone who was clinical, you could pre-write and pre-sign and pre-date for the day that they were coming in their prescription. And as long as the exam and stuff was done, it was from you, so that, it could be done. Or now you have telemedicine, or, if the exam was done, you could review it and you could prescribe it over the computer. There's a lot of different ways, as long as an exam was done for the date that is written for and meets the other requirements. All that. So everything can be done electronically. In fact, they want you to do everything electronically. If you can't do it electronically because you don't have that system ability to do that, you need to let the state know. We talked about methadone can use for pain. No chronic maintenance treatment with methadone unless you're licensed by the DEA as a methadone maintenance clinic. Which always reminds me of that song, The Methadone Maintenance Band, remember, from the 60s. Didn't know what that was. I was a teenager then, but now I know it means they're talking about individuals going to these clinics and getting their methadone. However, if someone has to be hospitalized or needs the methadone for 72-hour or 3-day rule, you can give it to them. administer it to them. You can't write a prescription for it. You have to administer. It has to come from you or your facility, and you can give them that for 72 hours. And I did talk to the DA. If someone is in the hospital and has been on methadone and they're hospitalized for medical reasons for prolonged periods of time, you can't administer it to them in the hospital. Here's the Florida data. This is the full actual report for 2021. We just have an interim report from 2022. So we're waiting for all the data to be completed from 2022. There's no 2023 report yet. Not even an interim one. So, you know, a lot of people, when they die of overdoses of all, they have several drugs on board. It's like a smorgasbord of medication that they have. And then there's a drug that, you know, is a cause of death. The most commonly found drug is ethyl alcohol. 6,511 decedents had that in their body. And then fentanyl and benzo and cocaine, cannabinoids. I think it'll be interesting to follow the cannabinoids, as now we have so much marijuana being utilized through the clinics and may become, you know, legal for recreational use soon. Methamphetamine and the fentanyl analogs. So if you put fentanyl together in the fentanyl analogs, it's more than alcohol. The drug that causes the most deaths, the most deadly, is fentanyl. You know, the law enforcement and ambulance, EMS, paramedics have to wear gloves because they get some of that on their skin. They could die. It's readily absorbed through the skin, and they got to watch, you know, the puppies, the canines, because they can die too from sniffing and getting that into their system. This is showing that most everything was more deaths, except for, we got plenty of time. A lot of numbers here. And a lot of other, some other drugs, benzos, carsoprodol, which is soma, meprobamate, which is an old tranquilizer called Milltown. Only had one patient ever all these years that was on that, and I got them off of it. Gabapet, zolpidem, and all opiates excluding heroin, fentanyl analogs, and U47700. Pink heroin accounted for 49% of all drug occurrences when ethyl alcohol is excluded. So a lot of things that are commonly used. That's kind of why, you know, with the pill mills, they had what I used to call the trifecta. They had a benzo, soma, and an opioid. Massive quantities of each prescribed every month, month after month after month. That's what we used to see when we reviewed those cases. You saw the trifecta, you knew there was issues somewhere there. So heroin decreased, that's probably because the fentanyl has gone up. And also there's some issues with measuring the deaths from heroin and morphine, because what is heroin? Diacetylmorphine, 2 morphine units put together, rings put together. So when it's metabolized, it breaks down. Fentanyl went up 10.5%, 611 more people. Deaths caused by fentanyl increased by 9%, or 489 more. Same thing with the analogs. 822 more times it was found in individuals, and the deaths went up by 304, or 36%. And that, so that you can see how deadly that is. So hydrocodone, less popular, oxycodone, decrease. Hydrocodone, decrease in terms of deaths, mostly supplanted by the fentanyl. And of course, there's even abuse of the drugs you use to treat abuse because it has a little agonist effect to it. Cocaine increased. I'd like to say the 80s are back. Your cocaine has been delivered. Reminds me of the Scarface movie days in the 80s. I think they're a little bit more sophisticated now, though. Amphetamine occurrences, 653 more. Deaths, up 13%, 97 more died. And that's also a difficult thing to measure, the methamphetamine, because it's metabolized to just amphetamine. So the bath salts, we all heard stories about that. I don't know if it was really true about someone high on that ate another person's face off down in the Miami area a few years ago. You all probably heard that on the news. The other one that's a big issue is kratom, because it's legal and it can cause deaths. And you can buy that usually in these convenience stores. Gabapentin, they're watching that. Xylazine or Trank. Some places are reporting, some are not. It's not required in Florida yet. So there's always something new on the horizon that people are finding to abuse. This is just showing the frequency in a little graphic way. Makes it a little bit easier to see. The ethanol, fentanyl, cocaine, cannabinoids, methamphetamine, fentanyl analogs, they're just found in the decedents, not the cause of death. That's sure contributed. Here's looking at through the years, or through the years, January through December of 19, 20, 21. And that's the green would be 21. You can see they've gone up, and I've put the total numbers in there. Fentanyl occurrences, the exponential meteoric rise, I would say, in both as present and the cause of death combined. Someone asked me about the analogs. These are the analogs that they have found. Cocaine, you can see it lost its popularity, and now it's back. Never went away, but more popular now than ever. Heroin occurrences, you can see how that's been going down as the fentanyl is going up. Methamphetamine occurrences, we've already talked about that. This is from New Hampshire State Police Forensic Lab. Lethal doses of heroin and fentanyl. So if that's only 3 milligrams of fentanyl compared to 30, so it's 10 times more potent. So if it takes that little to equal a lethal dose of heroin, what do you do when you have sufentanil and carfentanil, which sufentanil is 5 to 10 times as potent as the fentanyl? And carfentanil is 100 times as potent as the same amount of fentanyl. I mean, these are things they used to put elephants down with. A little bit of the pharmacology that we have to include. So here's how natural opioid starts from the poppy, from the bloom there. And we know they work in our body. Our body communicates with other cells of the nervous system through neurotransmitters because there are different opioid receptors, mu, kappa, and delta. They go from the end of one synapse across that and land on receptors and have an affinity for that. All neurotransmitters, and then are recycled again. Each one has a little bit of different property. Most of the drugs are mu. agonists, which produce, of course, analgesia, which is the effect we want. Unfortunately, can cause constipation, sedation, decrease your respiratory drive, make you feel high, cause physical dependence. Less is known about the others, but maybe they have some promise for analgesia with fewer side effects. And of course, they can work peripherally where the damage is, as well as in the spinal cord itself, and transmit signals deep into the midbrain. And of course, this is just a schematic showing that going all the way up to the brain, where you have afferent, efferent pathways to modulate the pain response. So our 3-day rule pretty much comes from this information that shows the chance of being on these medications still at 1 year and 3 years. And you can see how much higher it is at the 1 year, the probabilities and the number of days. So you can see where 10 is, so a little less than that is 7. You can see that, the longer you're on it, the greater the chances you're still going to be on it. But in terms of probabilities, that's why they kind of got the 3-day, 7-day rule. Also, the amount you take, the chance of having an overdose event, the higher the number of morphine milliequivalents per day, the greater the chance, maybe even up to 9 times as great as if you're under 50. So the general rule is just try to stay 50 or under. CDC recommends these things. We do this. State prescribing limits. Well, we kind of have that with the acute pain rule. We don't say you can only prescribe X milligrams a day. But you can, the 3-7-day rule, if you have to use more, you have to justify it in your record. PDMP, we're required to check that. Certainly, we got a lot of laws regarding prescribing we've gone over. Talked about having Narcan for those at risk, and we'll talk a little bit more about this, and the availability of naloxone, which is now over the counter. So as a state, we're doing pretty good in the right direction. We talked a little bit about prescriptions. Anybody here not using electronic prescriptions? Okay, so they're going to be pretty safe. But before, like I said, we had a problem. Doctors who would sign blank checks and leave it in their office for anyone to take. Patients can have it printed out to use if they want to shop the drug. There's variation in prices, and sometimes there's not availability of some of the drugs, particularly the amphetamines for who like it printed out so they can check with the pharmacy. Sometimes there's a shortage of the drug that you use to treat hyperactive patients with an attention deficit disorder. We can be criminally held responsible for what we do. Doctors have spent their retirement in a prison with overprescribing. It's considered manslaughter, involuntary manslaughter. Trying to get these drugs fraudulently, fake names or whatever, as you would expect, are a problem. There was a group of clinics in South Florida during the heyday of the pain clinics owned by the quote unquote George brothers, who had several of these clinics, each probably grossing $5 to $10 million a year, who ended up getting busted. And there were some DOs as well that worked with them that got involved with that. That was problematic. And it's been on TV, and they've done TV shows about it. And the one brother is not remorseful at all. I happened to see him talking on the TikTok and kind of bragging about how easy it was to do that. And he was only like 20 years of age, and he was a multi-millionaire and had all these cars, and how stupid the doctors were for doing this. They were easy to find doctors to work in that. And so I, typed in there, do you ever think about all the families and people who died as a result of your enterprise? And then they blocked me from sending anything else in there, because this guy's bragging and what a hero he was and how smart he was, and he was so young of an age, and many people died as a result of what they did, and it lured doctors in through their frailty of maybe needing money or greed, to do that, and they've lost their ability to practice again, and went to prison, some of them. It was just like, I just thought that was wrong to be boasting about that and not addressing the people who suffered and died as a result of that. But and there is a movie, you can probably find it on Netflix about them. I forgot what they call it, but interesting story. Sad story. Faking an animal, trying to get drugs from the vet. All the things are pretty much outlined here. We talked about only a third of the patients who experience a non-fatal overdose as a form of medication-assisted treatment or prescribed any medication-assisted treatment. So that's the thing that I think needs to be better. There's like a disconnect between someone going into the hospital for an overdose. They survive and then they're released, and they're not attached to any program or anything for detox immediately. I think that's an opportunity that's lost, and I think that's the time that needs to be done, and address any psychiatric problems as well if we're going to be successful in treating this and decrease future deaths from that. It's not an integrated system. The people that get treatment right away are those who end up getting Marchman Acted, which is in Florida, is the law that allows the state to hold you and require so many days in an inpatient facility to get treatment. There's a lot of it, though, if you have a lot of money. You see all these places advertised on TV, Malibu Beach and this place and that place. You're talking about $40,000 to $100,000 for that. 20% of the more than 2 million Americans with an opioid use disorder received addiction treatment. So there's a great opportunity to try to help people. 91% of people who overdose and survive are given another prescription for opioids. Well, that could be something that was accidental and they really do need it and don't have an understanding of how the drug works actually to do that. And this lady, she had been a patient a long time ago and she wanted to come back for some reason to get some advice. So when she told me about that, I made sure she had Narcan and how that worked. So things, that can do better, targeted naloxone distribution, that should be easier now that it's over the counter in Florida. Physicians need to know about medication-assisted treatment. If they don't do that in their office, then they should refer to some place that does. Usually the methadone clinics do that. Of course, there are a lot of private patients, private facilities that will do that now, and they will be able to get the drugs through that way. Some doctors have developed very successful and busy practices by doing that. Academic detailing, probably more information provided to physicians about these products, when to use them, how to use them, now that you don't have to have a special license to do that. If there's an prior authorization request to prescribe buprenorphine, you want to try to eliminate that requirement. Fentanyl screening is probably included now because it's older. Talked about Good Samaritan laws to protect you or other individuals who administer Narcan. More naloxone distribution, medication assisted treatment when patients are released from the criminal justice system, starting buprenorphine treatment in an emergency department. That's a good idea. But, you know, you got to make sure there's a follow-up and follow through after they leave the department for that. And you got to realize it's going to take more than that to be successful with it, because in addition to be able to have all these things, which is wonderful, the individual has to want to do that. If not, they're just going to toss that and go buy some more drugs with that, even though they almost just died. So that's why sometimes I think they need to have an inpatient setting to do that and have a better assessment as to how they can be more successful. But a lot of the deaths I think are accidental. They didn't know they had the fentanyl in the drug that they took. So I don't think they would intentionally want to kill themselves with it. That's why having the ability to test for it before you take the drug, I think, is important. Syringe services programs. I'm not sure where we are with that. Some communities are all for it. Some other places think you're just perpetuating the problem. So, and they say that a lot about buprenorphine too, but that really doesn't bear out statistically. You know, just because somebody is using a substance they shouldn't and harming themselves doesn't mean they shouldn't have the opportunity to quit. Again, they shouldn't have to be able, they shouldn't die instead of getting naloxone to try to save their life and then worry about trying to keep them off of it separately. But I've been in groups where they don't think you should give them that because they're just going to overdose again and be the same problem. Well, someone goes in a diabetic coma, oh, I don't think we should treat them with medicine anymore. They're just going to go in a coma again and die. I mean, I think that's the wrong attitude to have. It's like smoking cessation. How many times has a successful person attempted to quit smoking? You know, something comes up, triggers them, they're sitting around drinking coffee or having a cocktail and they got to have all of a sudden they got to have a cigarette with it. Well, that's incentive salience at work. It's a wanting of that was triggered by the situation because they're used to being in that environment. So the more times you try, the greater chance you're going to be successful, and better therapies and better treatments will come along with time. But you got to use what's available, for now, I think. That's what I had to present. If anybody's interested in these slides, they can email me and I'll send them the typed out version of it because it may not email what the length is. And then there's also have some appendixes to that has some backup information. So I hope somebody learned something new that will help them in their practice and assessing patients when you see them. And keep in mind, we need to try to help these individuals because they can be saved. They have to want to be saved, and it may take many times to do that. But they do turn around, and it's really good to see that. And a lot of this has to be solved politically. They're keeping this argument going about the Border Patrol and the fentanyl coming across it, and I don't hear any solutions. They like to use it as a political weapon against one party against the other, but we're still waiting for a solution for that to stop the flow of drugs into the country. And, I know they've talked to China to try to get them to stop it because most of this illicit fentanyl comes from China through Mexico right now. So if you don't have it, they can't get it. But when there's a pent up demand for some of these drugs, it's going to be hard to stop the flow because of the profitability of it. I've talked long enough. I will take any questions you have. But that's what you need to, yes, sir.
Are people exempt in the methadone program from being on PDMP?
Well, for our purposes, if we're prescribing it for pain, we're not exempt. No, we need to check that. I don't know their procedures at the methadone clinic. I would think that they would check that to see if while they're under their treatment, they're being checked. But according to Florida, I think they'd have to check it every time they dispense that. I don't know how they're doing that because
I'm not sure, but it seems like there's a hole in the bucket.
yeah, they got a lot of people going through there every day. Maybe a couple hundred people every morning. So someone would probably have to check.
It doesn't go to PDMP automatic.
I don't know, but I don't know, their inner workings of that, but that's a good question. John?
Thank you, Joel. Good presentation. I had one question. Did you say that special license that we have, if as long as we take that 8-hour DEA course, then that goes away?
You don't
A
need a special
requirement?
license to prescribe buprenorphine. You have to complete the 8 hours of that. This could count as 2, $99, 6 more online from the FOMA. Not that I'm promoting FOMA, but
I have my shirt.
or
in the
you can
room
get, or you
too.
can get that anywhere else that it's available. It can be done online. And since mine all converted, since I already had this under the old system, I would think you need to tell the DEA that, well, they would know because you've done the courses. So you probably got to turn that into them so they have record of it. And
Right.
now you're okay to
I
do
think
that.
I think it's a requirement. From what I understood, I think anybody that has a DEA license now, I think it's a requirement before your DEA comes up the next time to take that 8-hour course. Isn't that true?
Yes, you have to have the course if you're prescribing controlled
Right.
drugs, which is,
One of the other things, just quick. and
yeah,
it's
because
not-
they have that was part of their requirement was to have, to renew your license to have education.
They would have record of that. That count? X waiver?
The X waiver is gone.
I know, but you did it before.
If you did it before, you're fine.
Before, so
Right.
that counts for that 8 hours.
You're okay.
Got it.
One of the other things I would say that, or the big elephant in the room that society is not looking at, was even when we close those illicit pill mill, clinics, the number of deaths and all from overdoses
worse.
is increasing. So I think even if nobody had a DEA license, we couldn't prescribe. There was continual to do that because
But
if
we
they
got-
can't get them legally, they get them some other way. And I think
Well,
the
yeah.
elephant in the room is we're not treating psychiatric illness because
Well, a big part of the problem, I think, with addiction is that there are unaddressed psychiatric issues and social issues that are not being paying attention to. Just throwing someone on a pill and think that's going to solve it all. No.
right.
They need to treat their comorbid conditions, homelessness, schizophrenia, bipolar disorders. I mean, all those things
Right.
need to be addressed.
And the same thing with these shootings, it's just not guns that cause the shootings. If we have a gun, I'm not going to go into a school if you're normal and shoot children or to a church or something like that. So I think in society, there was a professor from Harvard who came to Brevard a number of years ago. He had a slide and that once since the mental hospital started closing in the 70s, went down here, 2 things shot up. And one of them was overdoses deaths, and the other one was prison population. And they both gone up. And I talked to our sheriff, and he said at least 1/3 of the inmates in our prison have psychiatric illnesses that have not been addressed. So I think society has to look at that whole thing. I think two
Well, the
big
thing that I'm
issues.
grateful for that we were able to do in Florida was at least getting the doctors out of the middle of this and
Right, that was
doctors not being drug dealers in white coats. I think
exactly.
we're able to close all that out because, it's like marijuana and the doctor. You got to go to the doctor to get a marijuana. I mean, at this point in time, really, what's your doctor? If they're going to use it's a drug, if they're going to use it for whatever, then that's what does it have to do with the doctor unless you're doing it for a specific medical thing. But right now, I think some of it is laughable. I mean,
Right.
everybody has all these disorders now, post-traumatic stress. Just look at the numbers that's reported as to why people get that. It's a pandemic, post-traumatic
Yes.
stress disorder
Yeah. Yep,
being
you're right.
diagnosed now. So it's just, don't get doctors in the middle of things that really has nothing to do with medicine.
Right.
You
But I think
know,
psychiatric
until it
illness
gets to the
that needs
point
to
that
be
you have,
addressed,
you know, studies and things showing you can use it for this, that, and other that help. I mean, a pharmaceutical rep can't come into your office and tell you to start using their drug for, well, where's the evidence? Well, it's just anecdotal. They told us that it helped and they felt better. So Dr. Rose, why don't you give it a try and see what kind of results you get in your patients?
Yeah, that's how.
Well,
the-
if it was FDA approved or you had the
Yeah.
data to do it, that it was helpful, scientifically based, yeah, but that's not how I practice, you know, medicine generally. Sometimes you do things for patient comfort that's generally done in your community, or doctors do that. I mean, that you don't have evidence for. I mean, look how long it took to learn how aspirin really worked. As an
Exactly, yeah.
anti-inflammatory, people use it for, because they know it worked, it alleviated pain. But the other
Exactly.
stuff is just kind of anecdotal, and the quality of the studies aren't that good, because we reviewed all that when we came up with the reasons you could use it on that marijuana committee, and it was difficult.
Yeah. Well,
to-
thank you for the work that you've done in those
No,
things.
thanks.
Good talk. Thank you.
I've had two occasions, pharmacists ask me what the diagnosis is in addition to not the non-acute pain. Can they do that?
The pharmacist asked,
For the diagnosis,
oh,
like fibromyalgia or whatever.
that's a good question. I don't know if legally they're entitled to that. I mean, they are kind of a co-partner in managing a patient. So unless the patient objected, I wouldn't have any problem. You know, telling that I don't know if legally they can ask the diagnosis. I mean, they're gonna probably know anyway from, I don't know, having to bill. I'm not sure if, you know, if there's anything in the law that gives them the ability to ask for that, but they're just wanting to cover themselves when they get audited, because they've been fined a lot and been in trouble for just following it. I would ask the patient their permission.
Okay.
I mean, right, the chart patient told me that I could share their diagnosis with the pharmacist or something. Just, this is a backup. Well, thanks for paying attention, and hope you had something useful you can take back to your practice.
With Music Premium, there's no ads, which also means no breaks from your kids' songs. Get YouTube Music Premium.
Mr. Ponton, I believe you have a filter turned on in the video settings. You might want to take-
Yeah, they're flaky, but they're good. No, you got two.
If you're down and out and you hurt real good, come on over to the place I work. In all your loneliness, I'll try to soothe I'll play the blues for you. Don't be afraid. Come on in. You might run across some of your old friends. In all your loneliness, I'll try to soothe. I'll play the blues for you. Ain't no big name, ain't no big star. I'll play the blues for you on my guitar. All your loneliness, I'll try to soothe. I'll play the blues for you.
Oh, wait a second.
Deal or no deal?
No deal!
The game you know and love is back. This time on the Banker's Private Island. It's a whole new game with a lot more money. Welcome to Deal or No Deal Island. This competition is the banker's test to find his ultimate opponent.
I was a model on Deal or No Deal. I know what a good deal is. I know what a bad deal is. For everybody who says I'm too old, I'm here to do it.
And here comes Boston Rob.
I want to figure out a way to control the game. And that's it.
Hidden throughout the island, cases filled with cash. You just need to find them. Win the cases, face the banker. It's an opportunity to make the deal of a lifetime. Now go get those cases.
Put those alligators in here.
I've got to find some place to go. While the way things are happening in love, let me tell you that I'm not miserable. I'm gonna leave in the morning, gonna pack up and shoot. You might think I'm joking when I tell you, man, to no more no. I've got to do.
Yeah, sure.
GX?
Yeah.
You're good.
I've got the blues. I really think I do. Yeah, let me tell you that I got the blues. I want to tell all your working men, you should go home a little before time. Then you'll catch your woman getting down wrong. Like I don't mind. That's what gave me the blues. Oh, that's why I've got the blues. Let me tell you, that's why I've got to move. Yeah, that's why I have the blues.
switch to Google Fi Wireless and get Simply Unlimited. Our most affordable unlimited phone plan is just $80 per month for your family. Google Fi makes it easy to stay connected with great coverage and unlimited data, calls, and texts. You also get 5 gigabytes of high-speed hotspot tethering and a phone on us with every new line you add. Get the Simply Unlimited phone plan from Google Fi Wireless. Switch today.
I wasn't on the avenue. I never thought I'd meet a girl like you. Meet a girl like you. With auburn hair and stormy eyes. The kind of eyes that hypnotize with the road. Hypnotize with the road. And I ran so just I don't know how couldn't get away. A cloud appears above your head. A beam of light comes shining down on you. Shining down on you. The cloud is moving near us now. Aurora borealis comes into you. Aurora comes into you. And I ran so far away. I just ran around the night. I couldn't get away. Reach out a hand, touch your face. Disappearing from my view. Disappearing from my view. Reach out a hand to try again. I'm floating in a beam of light with you. A beam of light with you. And I ran. Just ran. I just ran.
I'm Dr. Tracy Leonard. I'm one of the board members of PCOMS, so welcome. A couple in-house things. The silent auction out there is here today and tomorrow. So if you're interested in any of those items, please bid on them. We have a reception today right after the lectures, so please join us for that. Tomorrow, we have the student resident alumni reception right after the lectures. So if you're one of the alumni or one of our students, please join us for that. And then the president luncheon is going to be Friday at 12. So if you're here Friday, please join us for that. And there is limited seating, so please make sure you let them know if you're going to show up. So right now I'd like to introduce Jason Nguyen. He is a really great resource for you guys. If you have any questions legally, he's amazing in terms of getting you answers. Jason Wins, an Esquire, he's a lawyer. In 1996, he graduated from the University of Maryland and received his Juris Doctorate from Nova University. Shepherd Broad Law in Fort Lauderdale, Florida in 2000, he joined. And Mr. Wynn is admitted to the Florida Bar in 2001. From 2001 to 2004, Mr. Wynn worked for the Assistant Public Defender of the Fifth Judicial Court, where he conducted over 15 jury trials, numerous non-jury trials, and many hearings, including violations of probation, restitution, and early termination motions for defendants in juvenile misdemeanor court. Beginning in 2005, he opened his own practice, Wynn Law, PA, where he is managing partner and continues to focus on administrative, governmental, civil, and legislative consulting. Mr. Wynn currently serves as general counsel for the Florida Osteopathic Medical Association, the Florida Podiatric, if I can speak, Podiatric Medical Association, the Florida Prescription Drug Monitor Program Foundation, the Florida Hearing Society in Gadsden County Sheriff's Office, and the Wakulla County Sheriff's Office. Mr. Wynn lectures throughout Florida on the laws and rules that affect Florida healthcare practitioners, including osteopathic, allopathic, podiatric, and various other licensed healthcare practitioners and providers. He is a member of the Florida Bar in Tallahassee, Legal Services in North Florida. As a member of the Tallahassee Bar, Mr. Wynn volunteers his legal services to the Wakulla County Senior Citizen Center, Legal Services of North Florida. Mr. Wynn is a devoted husband, a father to 3 boys. During his downtime, he enjoys hunting, fishing, golfing, and the great outdoors. Named after my own heart.
All right. Can you hear me okay? All good? Yes. All right. I take it that's a yes. All right. We'll dive right into this 3-hour presentation on Florida laws and rules. Yeah. That's just one of many jokes that'll be coming. All right. There we go. There's the first slide. There's my information. If you have questions, you can certainly ask me afterwards. You can send me an email at jwin@jwinlaw.com. You can call my office, which is the first number, or the second number is a better number. That's my cell phone. I answer my cell phone all of the time, except when I'm on a stage lecturing. My office line, I cannot answer unless I'm sitting at the desk. So if you have a question, you can certainly email me or call me, text me. You can also even call the FOMA office and leave a message there, and they will deliver that to me. I have no financial relationship in regard to the content of this presentation. All right, so the educational objectives for Florida laws, rules, and medical ethics are understanding of the applicable laws and rules for licensed osteopathic physicians, knowledge of the disciplinary process, learning of the rights afforded to physicians in licensure disciplinary cases, the ability to locate applicable statutes and rules through online resources. Then we'll delve into what constitutes medical ethics and why you should be concerned about medical ethics. And the reason we talk about medical ethics now is because of the board rule. A few years ago, there was a course called Florida Laws and Rules and a course called Florida Medical Ethics. The boards, the Board of Osteopathic Medicine, after promulgation of a statewide statute that required you to take the additional hours of continuing education for controlled substance prescribing, the board then took the 1-hour laws and rules and the 1-hour medical ethics and combined them into Florida laws, rules, and medical ethics. So there are still 5 mandatory courses you must take. The medical errors for 2 hours, prescribing controlled substances for 2 hours, and then the 1 hour of Florida laws, rules, and medical ethics. And you were here earlier with Dr. Rose, gave the presentation. Was he presenting controlled substances or medical errors? Nobody knows. Anyone here for that? I'm just kidding. Controlled substances? Okay. So those are the courses that you must have each year. And we'll come back to all of the requirements for licensure for your renewal requirements. All right. So the first question I have, and you can answer. And when you answer, I was prepared to give out 100 grand, but the store didn't have them. So you get a payday. All right. So when prescribing controlled substances to a patient 16 years of age or older, which is not a non-opioid Schedule 5, I do not have to consult E-Force. False. Who said it first? Someone had it. All right, well, you got to answer the next one then to get the real prize. And it is, it's a payday. So everyone loves a payday. All right, raise your hand. When I refer a patient to an entity I am an investor in, the patient doesn't need to know. Well, I mean, that was a collective. All right, we're going to get to a better one. All right, see if you can answer this one for a payday. What Florida statute is the Osteopathic Medicine Practice Act? Did you say, who said C? Oh, back there. All right. And then, look at that. And then you said 459, which is correct. So you get a payday. It's kind of like Oprah. You get a car, everyone gets a car. All right. What Florida rule applies to osteopathic physicians? Who said D? B? D. Yes. I love your jacket too. I can't make that, bro. But you can pack. Well, I'm afraid of the people who's eating a sandwich in front of me. Oh, there it is. All right. Perfect. Okay. We'll come back to those. There's some more paydays if you have a good question. All right. So your license, am I not on? Oh, it's only on this one, huh? What do I need to do? Hit that button? How about now? Can you hear me now? Is that good? Hey, my name is Jason Wynn. So nobody at home heard that, but we were giving out paydays. You weren't eligible. So, all right. So here is the current licenses that you have. They'll expire on March 31st of 2024. That's coming up, right? So to ensure that you have the proper renewal, you must abide by Rule 64B 15-13. And it says that all of your hours, effective at the very bottom here, allows for all hours during the 2020 to 2024 biennial renewal period to be completed through distance learning. So you need 40 total hours every 2 years. The 5 mandatory hours we talked about earlier are inclusive of these 40. So you need the 40. Within those 40, 20 can be general hours, but they must be AOA category 1A. Then you have 15 hours of general, either AMA or AOA. They just don't have to be category 1A. Then you have the other 5 hours that we talked about, the mandatory. Those 40 hours you need every 2 years. There is also the requirement that each hour you take get reported to CE broker on your behalf. When you attend this meeting or attend other meetings within the FOMA family, those hours are automatically reported to CE broker on your behalf. If your hours are not automatically reported by the provider, then you must self-report. Self-reporting for this meeting is pointless, useless, and will do no good. The entity, the provider, will submit those hours on your behalf. Before you go to a continuing education course, you want to make sure that they're an approved provider and that they submit to CE broker. If you go to a course in California or Colorado or the Swiss Alps to take continuing education, you want to get that certificate. You'll come back to Florida. You'll then self-submit that to CE broker. If CE broker does not have the hours you have taken, it's as if you didn't take them. So make sure that each hour you take is reported to CE broker on your behalf, either by the provider or you individually if they don't send those to CE broker. All right. Now, this section is about the new laws that have passed. Does anyone know what's going on in Tallahassee over the next 60 days? The legislative session. And what do they get to do during those 60 days? Destroy the practice. No, just kidding. They take action, sometimes good action, sometimes bad action, sometimes well-intended action that turns out to be bad. Here is a bill that was passed 2 years ago or 3 years ago now. This was about the pelvic examination. And there was a bill that was introduced. And I give the disclaimer at the bottom, I'm not your lawyer. If you want me to be your lawyer, I'm certainly happy to. You just send a check and then we go from there. All right, so I'm not your lawyer. If you have questions about it, you can certainly ask me, but if you have difference of opinions on this direction within your facility, I would abide by the direction of your facility and your general counsel there. So this basically amended the bill to make it a requirement that before performing any sort of pelvic examination on a male or a female in its original language, you had to provide informed consent. And then you had to provide written consent. And there was a question as to whether or not you could do written consent and verbal consent, or if you could do just one of them. I always said that you should do both. This bill evolved during the sessions after its initial passage, because originally people interpreted it to mean that it applied to pelvic examinations of men. It applied to visual assessments and other types of examinations. So over the years following its initial passage, they made it a little more narrowed and specified that it was for women, that it excludes visual assessment and imaging and diagnostic medical or surgical procedures from the definition of pelvic examination. Another one that evolved from its initial creation is the parental consent. This originally passed to say that you could not provide emergency care to a minor without first receiving written parental consent. There was an exception that many people believed would be a viable option if you were in that situation and wanted to provide emergency care without first receiving written consent from the parents. And that option was the protection of the Good Samaritan Act. However, the Good Samaritan Act only protects you against civil prosecution. This bill and this legislation made it a criminal offense if you did provide treatment to a minor without receiving written consent. Because of that, the next year we went back and made a change to it. And so now we made a change to it in another section of the Florida statutes that deals with emergency medical care and the care that can be provided outside of a hospital. And so that now you can provide emergency care to a child that's hit by a vehicle that's riding a bicycle, kids on a bicycle, they get hit by a vehicle, you see it, you can provide care to that child without first receiving written consent from the parent. Anytime you're dealing with a minor child in your office setting, you want to make sure that you have received valid written consent from the parent or guardian. And you always want to make sure that that consent is tied to the person that's standing in front of you and not, you know, if a minor child presents with an aunt or an uncle, you want to make sure that you have that relationship established. You have consent from the parent or the guardian that that other adult should be privy to the medical information, because that all goes to HIPAA and dispersing HIPAA information to individuals that shouldn't receive that information. Another one, human trafficking. If you don't have this sign in your office by now, you should. Human trafficking, the legislature believes that you as healthcare practitioners are on the front line. So you post these human trafficking signs in your office, not for patients to see, but for your other healthcare practitioners and other people in your office to see. You can hang it right next to that sign or that poster of the arm for the workers' comp. That was a joke. All right, we'll keep moving on. We're going to get to some exciting stuff here in a minute, though. Don't worry. All right, non-opioid alternative. This is a pamphlet that must be given to a patient each and every time before providing anesthesia, prescribing, ordering, dispensing, or administering an opioid listed as a Schedule II controlled substance to treat pain. If you are prescribing, administering, ordering, dispensing anesthesia listed as a Schedule II controlled substance to treat pain, you must give them this pamphlet. The pamphlet explains to them that they can receive similar types of relief from other forms of homeopathic or other forms of therapeutic means like doing yoga. Good for some instances, but maybe not the best. However, the point of this is each and every time, if on Monday you prescribe and then on Friday you order for the same patient, you give them the pamphlet again. And that pamphlet now can be given through electronic means. Originally, the bill was passed and you had to give them a written pamphlet each and every time. You order it, give them a pamphlet. You dispense it, give them a pamphlet. You prescribe it, give them a pamphlet. Each and every time. All right, next one. Electronic prescribing requirements for those of you using EMR. You are electronically prescribing your scripts to the pharmacy. There are still ways that you can handwrite a prescription that is viable and valid. That does not mean the pharmacist has to fill it. A pharmacist is part of the healthcare team. They have the same rights and privileges as you not to fill a script if they don't feel it's appropriate. There is nothing you can do about that. Sits like a lead balloon. Unfortunately, or fortunately, they are part of the healthcare team. They are privy to the same HIPAA information that you are, and they can make a determination not to fill a script if they are not comfortable with it, period. They don't have to give you a reason. Sometimes they do, but they don't have to. Your best thing to do at that point is to have your patient go to another pharmacy. You can handwrite the prescription. If you look at the bottom in red, the practitioner determines that he believes that it is in his or her best interest, or the patient believes it is in his or her best interest to compare prescription drug prices among area pharmacies. Then you document the record and you handwrite the script. If you are not using an EMR, or you are using an EMR and you're not using e-scripts, then you've certainly already asked the department for a waiver of that requirement. And if you haven't, certainly go to the Board of Osteopathic Medicine website, go to their resources, or I think it's a resources link. And under there, it has an application that you can fill out. If you are not using EMR in your practice, you have to get the waiver. All right. Another change under 456, this is again for controlled substance prescribing. And of note here, when we looked at the slides earlier, that we mentioned Florida Statute 459 is the Osteopathic Medicine Practice Act. We'll get into 456 as well. 456 is the General Healthcare Practitioner Practice Act. It applies to all licensed healthcare practitioners. 456.44 says when you can prescribe controlled substances. It sets forth, let me see here, that the definition of acute pain, and then those for cancer and terminal condition that are the definitions that are used within the controlled substance prescribing. When you are prescribing for acute pain, here is the standard, and it goes to a board rule. that the board has promulgated a rule for the standards for the treatment of acute pain, the prescribing of controlled substances for acute pain, the prescription supply of 3 days for a limit or up to a 7-day if there's an exception. And again, if there's an exception, you must document the record, document the file. Make sure that you put into the record, the patient's record, why you are giving more than a 3-day supply or giving up to a 7-day supply. This is going to benefit you. It's the CYA to make sure that, I think my room's ready, my phone's ringing, to make sure that you cover yourself so that if there is an issue, that you have your notes and your medical chart to rely on as to the reason why you did it on that day for that patient. Further, the practice standards for telehealth, as you know, as a Florida licensee, that Florida license gives you the ability to practice telehealth and treat patients in Florida. Out-of-state practitioners can also treat patients in Florida through telehealth by receiving a telehealth certificate. It is not a license. They can only treat patients in Florida through telehealth. They cannot see patients in person. These are the practice standards for the use of telehealth to provide services. And if you look at the telehealth standard and when you can prescribe controlled substances through the use of telehealth, it only applies for the treatment of psychiatric disorder, inpatient treatment at a hospital licensed under 395, the treatment of a patient receiving hospice services, or the treatment of a resident of a nursing home facility. Other than those 4, you cannot prescribe controlled substances through the use of telemedicine. All right. It also last year, during the 2023 legislative session, they added the provision in telehealth that you can use audio only devices and it qualify for telehealth. I say that, however, I give a caveat of this. That doesn't mean you'll get paid for it. So oftentimes I would tell my members that would call me years before, hey, can I have a telephone conversation with my client or my patient, or is that telehealth? And the answer up until last year was that wasn't telehealth. It wasn't regulated. They added the use of audio only, I think, to help physicians attempt to get paid for it when they have those conversations with their patients. Just remember the standard of care applies and the use of audio only for certain circumstances in treating a patient may not be up to the standard of care. So audio only is now allowed, but it may not be the best way for you to proceed. This was SB 252 was protection from discrimination based on healthcare choices. This was one of the bills that came out after the COVID-19 world health pandemic. And so the legislature wanted to protect individuals' rights and not be discriminated against based upon choosing or not choosing to do certain vaccinations or requiring COVID tests to gain access to or entry upon or services. So there's protection for your patients against discrimination based on their healthcare choices. All right, and it keeps going. All right, another one, the physician certification for medical marijuana use. If you are a certified physician or certifying patients for the use of medical marijuana, you want to make sure that all of those visits are in person. There was an exception during COVID and the statewide and national declared health emergency. But that's over now. So you have to do everything in person. All right. And then here, goes back to answer one of the questions that I posed earlier about referral of patients. So it regulates the financial relationship between referring providers and other providers for designated services. And at the bottom, it says the bill allows self-referring healthcare providers to avoid the cost of having physician present while the healthcare services are provided. The change in law aligns with the federal Stark law provisions regarding self-referrals by a healthcare provider to another provider. So that was another change. They're looking at some more changes this year for healthcare providers when it comes to non-competes and restrictive covenants. They're looking at autonomous practice by APRNs and CRNAs. They're looking at what else? Psychiatric nurse autonomous practice, universal licensure, or Florida joining the compact with the other 37 states around the country, the District of Columbia and Guam, so that if you're licensed in one of those other states and you want to come to Florida, you can access licensure through the compact. So lots of fun things happening in Tallahassee over the next 60 days. This is week 2, week and a half in. So plenty to look out for. This was the change for the standards of treatment of sex reassignment. There was many discussions at the Board of Medicine and the Board of Osteopathic Medicine over the past, 2 years on sex change surgeries and its application to minors. This was the standards of treatment that set forth that it was only for adults, and then it had to be done by a physician. These are the rules that were promulgated by the Board of Medicine and the Board of Osteopathic Medicine in response to those statutes. We'll talk about in a minute. The Florida legislature passes laws. The governor signs them into, or passes a bill, the governor signs them into law, and then the boards then take those laws and write rules to declare the laws and set forth what the penalties are for violation of any of those statutes. These are the rules for the standards of practice for the treatment of gender dysphoria in minors. And they're still going on. They're continuing to meet. We were just, 6 weeks ago at another meeting. And so they have some final rules for adults. They do not have final rules for the treatment of minors, and they're continuing to work on those. Here is the change in the federal requirement for DEA registered physicians. I think you have to renew your DEA registration every 3 years. When you go to renew now, you must certify to them by checking a box that you have taken the 8-hour required course on continuing education for controlled substance prescribing. In Florida, there's a 2-hour course that you just took earlier today. Those 2 hours are applicable to this 8-hour requirement. You can also, if you're a member of the FOMA, go to the FOMA website and download or watch the other 6 hours for free. And those are all, you can use all 8 hours combined with the 6 online, the 2 you took earlier today, and those will give you the 8 hours you need for this new DEA requirement. It is required upon you prior to renewal. If you don't renew until 2025, then you need it between now and then. If you renew tomorrow, you need the 8 hours today. All right. And the way you know whether or not you need those hours is to figure out which group you're in and then determine that. Easiest way to do it, if you have a DEA certificate to prescribe controlled substances, the easiest way to comply is go take the 8 hours and then check the box. Don't worry about what group you're in, just take them and be done. So That's that. Now, the fun stuff. Who's who? These are all the players that you should know about when we talk about disciplinary cases or licensure cases or licensing requirements. You have the DOH, the Department of Health. They license all healthcare practitioners. The board, or as some people call it, BOOM, the Board of Osteopathic Medicine. They write all the rules and hear all the disciplinary licensure issues. The Attorney General's Office, the AG, they provide attorneys as board counsel. They also provide attorneys to prosecute licensees that are up for discipline. Then any appeals go to the DCA. Any final hearings go before DOA at the Division of Administrative Hearings. And that's in Tallahassee. If you're going there, call me. I'd love to come watch. All right, so that was a joke. All right, laws, it'll make more sense in a minute when we get to that slide. Laws and rules for osteopathic physicians, as we said before, your Practice Act is 459. All healthcare practitioners are under 456. You must look at 459 to know specifically about your Practice Act. You must look at 456 to know what the General Healthcare Practitioner Practice Act is. Not everything in 456 is applicable to you, but everything in 459 is. Remember, one of the statutes we looked at earlier was 45644. That's in the General Healthcare Practitioner Practice Act. It applies to you. Then we have Chapter 120, that's the Administrative Procedures Act, that affords you the rights that you have for any disciplinary licensure cases. It also affords you the rights to petition for variances or waivers or to ask for a declaratory statement. Then you have the Florida Administrative Code. Those are all of the rules promulgated by the Board of Osteopathic Medicine. Under 456, it starts at definitions, goes all the way through repeated medical malpractice. Here's one. This slide, sorry, goes to that earlier question. The other one for the Self-Referral Act didn't, but this one does. Disclosure of financial interest by production. If you are referring a patient to a facility that you own, you must inform them that you own it. You also must give them the names and addresses of at least 2 alternative sources where they can receive the same services or item. So if you own a facility and you're referring your patient to them, you must tell them that you own that facility. And then you provide them with 2 alternatives. You can also get it at Lab X or Smith Lab. If you don't, you're in violation of 456052, which is disclosure of financial interest by production. You will then be subject to disciplinary action. In 459, it is specific for you osteopathic physicians and any PAs that work for you or AAs that work for you. Physician assistants or anesthesiologist assistants. If a PA works for an MD, they fall under 458. If a PA works for a DO, they fall under 459. Both 458 and 459 have statutes within their sections that deal with physician assistants. So it all depends on where they are employed at the time. So if you employ a PA or an AA, make sure that you understand what their requirements are as well. Here's just one of the statutes in 459012 specialties. It basically says you cannot advertise that you're a specialist unless you've successfully completed the requirements for certification by the AOA or the ACGME and is certified as a specialist by a certifying agency approved by the board. So if you put out that you're board certified, make sure that that board is one that is recognized by the Board of Osteopathic Medicine, or else you're going to be hit for false advertising. When there are any violations, you look at the grounds for discipline for that type of action that's found in 459. You see these are the following acts that constitute grounds for denial of a license or disciplinary action. I've given you a few of them here. S, H, H, and EE. EE is my favorite. Pre-signing blank prescription forms is bad. It's not good. You shouldn't do it. If you do it, you will be, if you do it and are caught, then you will be disciplined for pre-signing blank prescription forms. And revocation is a possibility. Absolutely, they will discipline your license. I've seen it for pre-signing blank prescription forms. And the reasons I added EE into the slide presentation is because the board asked me to at a meeting. Because somebody went there and said, I went to a laws and rules course and I didn't know that you couldn't do that. And it was probably my lecture. So now you know it. You can't do that. Even if you have that tea time at 2 o'clock and the patient's coming at 3, you cannot pre-sign them and have them waiting there for the patient. All right. Another one under 459, physician records. The biggest question here is who's the records custodian? If you are an employee of a hospital, you are not the records custodian, I can guarantee you that. If you leave that practice or that hospital, they maintain the records. You just give notice that you are no longer seeing patients there and all of their records can be picked up at that hospital. If you are working in a private sector and you're an employee of another practitioner, then they are probably the records custodian. If you are a solo practitioner, you are the records custodian. If you close your practice, you must make those records available to your patient. If you are retiring, you must make those records available to your patient far past the time that you were going to retire. So that being the case, you have to give the records to an entity or an individual that can house them and then make them available to your patients after your retirement. So, all right, here are all the rules for under the Board of Osteopathic Medicine. The ones I'll point out, the first 2, PA assistant, these are all the rules for PAs and AAs. And you see there's 19 subparts there and 14 here. The ones you really look at are the continuing education requirements, the disciplinary guidelines. They're all relevant, but like resident internship, unless you're a resident, you're probably not that concerned about it. So these are all of them, or that's all of them. Here is just one of them within 64B 15-19. It's 19.007. It's the sections for citations. In lieu of disciplinary action by the board and taking you before a court at the Division of Administrative Hearings or before the board for disciplinary action, a case can be resolved through a citation. If it is a violation that does not endanger the health, safety, welfare of the community, then the board can issue a citation against you. They can also, and that citation, you pay a fine and the case is over. They can also go to mediation. The key is only the cases or only the actual discipline that's listed for a citation or listed for a mediation can be mediated. If you cut off the wrong arm, you're not going to get a citation and you won't go to mediation. You'll get a formal complaint. But some of the ones for mediation, negligently failing to file a report or a record, charging copying fees for patient records in violation of the rule, failing to pay the fines and costs imposed by the board. So these are the ones that don't endanger the health, safety, welfare of the community. They say, hey, Dr. Smith, we see you violated this statute. It's a minor violation or a citationable offense, or it's eligible for mediation. How would you like to proceed? You want to accept it? And in those cases, you would proceed to mediation. Unless the underlying charge is false. Do not ever accept a citation or go to mediation if you do not believe you violated the Practice Act. And here's another rule within the Board of Osteopathic Medicine, another example, and this is the standards for the treatment of gender dysphoria in minors. Again, those, when you're looking at what's applicable to you, you look at your Practice Act 459, you look at the General Healthcare Practitioner Practice Act in 456, and then you go look at the rules to determine what you can do. All right. So if you are ever in a situation where you have violated the Practice Act, there can be an investigation into your license. It can start by a patient complaining about you. It can start by an anonymous complaint, by a confidential informant. Some way, somehow, a complaint is sent to the department. They receive it and they begin an investigation. At that point, they will give you notice of the investigation unless it's a criminal charge or the department believes their notice will be detrimental to their investigation. If it's a criminal charge, they give you the bracelets to wear behind your back. Jail, right? All right, everyone's on the same page. Right? We're here? Everyone's with me? All right. However, when we talk about the criminal world and you get those handcuffs, in the civil world, they can't arrest you, but they still must provide you with your due process rights. You have a constitutional right to remain silent. You should always use that. I used to do criminal defense work. Once I hit the lottery, I will go back to that. My favorite is the 45-year-old, 5-time convicted felon who just got out of prison and gets arrested again. I would much rather represent them than to represent a 18-year-old who got arrested for the first time. Because the 45-year-old convict knows he has a constitutional right to be quiet, and he will, or she will. The 18-year-old will say, do you know who my dad is? You know, my uncle was a police officer. My granddad was the judge in this county. They will start talking. And once you start talking, you're waiving your right to remain silent. You have a constitutional right under the 5th Amendment and the 14th Amendment to remain silent. You should do it. All communications with the department should be through your lawyer. If you do waive your right to remain silent and you start communicating with them, they can use that against you. This was a case where a physician received a letter for improper advertising. They said, the physician got the letter and said, oh, it's a violation of the Practice Act, but I can explain it because the newspaper got the right information. They made a mistake. I can show all the proof that I sent them. The doctor puts it all on letterheads and sends it into the board. And what happens? The letterhead did not identify him as an osteopathic physician. So that communication back in violation of his right to remain silent was another admission that he is violating the Practice Act by not identifying himself as he is licensed. So in that situation, they responded and sent the physician a second complaint. So you have the right to remain silent. You also have the right to counsel. Make sure you always hire the right counsel. Let's see if this works.
Mr. Ponton, I believe you have a filter turned on in the video settings. You might want to
can you hear me, Judge?
I can hear you. I think it's a filter.
It is, and I don't know how to remove it. I've got my assistant here, she's trying to, but I'm prepared to go forward with it. I'm here live, I'm not a cat.
I'm not a cat. All right, so make sure you hire the right attorney if you ever get a complaint. So what's going to happen is they're going to send you a letter and say, Dr. So-and-so, we received this complaint. It says that you, when treating the patient, were wearing a Florida Gator tie, and that offended the patient. And so they submit the complaint and they send it to you. That type of complaint would never get to you because it's not a violation of your Practice Act. But they get a complaint that says the patient said that you cut off the wrong finger. You were supposed to cut off the left pinky finger, you cut off the right one. Here's your letter. We're doing an investigation. And then you have to send them a response within 45 days. They'll send you a copy of the complaint and they'll tell you they're doing the investigation. Anything you send them can be used against you. Anything your lawyer sends on your behalf cannot be used against you. One of the greatest things I always did, fun things, in criminal defense is turn to the prosecutor right before the jury walked in the first day of trial and say, my client did it. Well, they can't use that, right? But it makes their head spin for a minute. And then we zealously advocate on our client's behalf. But If you got a letter, you would respond within 45 days. During those 45 days, you would get a copy of the complaint. You would do your own investigation. Your attorney would do their own investigation. The department can do their own investigation. They can go out and take statements. They can do depositions. They can ask for subpoenas, duces tecum, for papers, documents, medical records, all of that to do their investigation. And then once the investigation's over, if, let's say it was that first case of the wrong tie, they would determine it's not a violation of your Practice Act, the case would be dismissed. If they determine that it is a violation of your Practice Act, but it's a citationable offense or a mediatable offense, they'll send you notice of that. Hey, this doesn't endanger the health, safety, welfare of the community. Here's a citationable offense, pay the $500 fine, the case is over, done. If it's not a citationable offense or a mediationable offense, then, and it is a violation of your Practice Act, the case goes to the probable cause panel. Here's a list of some of the citationable offenses. Failure to register as a dispensing practitioner. That registration fee is $100 a year. The fine's $500. Failure to timely provide medical records, $500 fine. So if they send you a citation and you accept it, it goes on your permanent record forever, so that they know in 10 or 20 or 30 years, if the same complaint arises again, they can't give you a citation the second time. You can get a citation for every one of these once. You cannot get a citation for any one of them twice. Is that well said? All right. Oh, yeah. Look at that. All right. My kids argue sometimes. I'm not. Well, never mind. Okay. So here's mediation. Again, all of the ones that are mediatable. If it's not listed there, if it's not listed in the citationable statutes, then in the citationable rules, then the case proceeds to a formal hearing, informal hearing, or a settlement agreement. That's after it goes before the probable cause panel, because the probable cause panel will take the investigative file, will take everything you and your attorney have submitted, they'll review it all, they'll discuss it, and they'll have a fruitful discussion about whether or not they believe you violated the Practice Act. And then they'll make a determination. There's usually 2 members. If it's split 1-to-1, that's an affirmative for discipline. If they vote 2-0 not to find that you violated, then the case is closed and it does not become public record. If they do determine that you violated the Practice Act and they make that determination through a probable cause finding, then 10 days after that finding, it becomes public record. Now, it's public record, the case is still pending. You still have all of your administrative rights and your constitutional rights. It's just now out in the public and it's known. Anyone can go to anyone else's practitioner profile, look at it and see whether or not they've ever been disciplined or have a complaint against them at this time. So at that probable cause panel hearing, they have a discussion. You don't have a right to be there. It's past and present members of the Board of Osteopathic Medicine. They know your Practice Act. They know whether or not you violated your Practice Act, and they make that determination. I once had a Board of Nursing case. They made a determination that my client had violated the Practice Act. We went to the nursing board and objected to that finding because they did not say one word other than let's vote. When my client's case came up before the probable cause panel, instead of having a fruitful discussion, they just said, let's take a vote. They voted 2-0 to find probable cause, and that was it. Now, my client had been convicted and was sitting in prison, but that's beside the point. The point was that they did not have a fruitful discussion. So we went to the Board of Nursing and asked them to send it back for another probable cause panel discussion. They had one. They made the same outcome or determination, and then eventually my client's license was revoked. But that was based upon the criminal charge, not my representation of the licensure, I would like to say. All right, so again, if there's no probable cause, case is dismissed. If they find it, they will send you a formal complaint. And once you get that formal complaint, it'll look like this: the administrative complaint and election of rights. It'll tell you, we've sent you notice of the investigation. We've done our investigation. The probable cause panel has met, and they've determined that there's probable cause to believe that you violated the Practice Act. Here's your complaint. Here's all of the information. And if you would like to settle it, here's your election of rights, and you can tell us how you want to settle it. You can go through the election of rights. You have 3 ways to proceed: a formal hearing, informal hearing, or a settlement agreement. Once you get that formal administrative complaint, you have 21 days to respond. Failure to respond is another violation of your Practice Act, and that's where the snowball effect begins. If you move offices, even across the street or down the hall, and don't update that information within 30 days of the department, and they send you a letter at your old address, that too is a violation of your Practice Act. You must update your practitioner profile within 30 days of any new addresses to make sure that if they send you documentation, you receive it. All right, so you have 3 ways to proceed: formal hearing, informal hearing, or a settlement agreement. Formal hearing is a full trial at the Division of Administrative Hearings in Tallahassee. If you're going there without a lawyer, let me know. It's not the smartest thing in the world, but I'll come watch. They'll give me some advice. It's very similar to a criminal court or a civil case court. You have a judge, you have the prosecutor, you have yourself and your attorney. There's really pretty carpet on the floor. There's mahogany wood. There's really nice desks. It's a full trial. If you're going there, make sure you've consulted an attorney before. If not, you have a fool for a client. All right, informal hearing is before the Board of Osteopathic Medicine. They will tell you, or you and your attorney will discover that the disciplinary guidelines set forth in the rule say for a violation of X, you can get probation or up to revocation. The second offense of violation of X, you can get revocation up to, or suspension up to revocation. There is a guideline that the board must stay within for any disciplinary case. So if you go to an informal hearing, you're going to an informal hearing without an agreement, without any sort of agreement for the outcome of the case, and you're going there to try to mitigate. You cannot go to an informal hearing at the Board of Osteopathic Medicine, sit down and say, I didn't do it. You can sit down and say, I did it, but here's why, and here's what I've done to change it to make sure it never happens again. And these are the steps we're taking to ensure future patient safety. Then the board hears all that and they say, well, that's great. This is all good. These are mitigating reasons that we can go below the guidelines and issue, they could even dismiss the case, or they could give you a penalty below the guidelines. In an informal hearing, you cannot dispute the facts. You did commit the offense, but here's why. And you give mitigating reasons as to why they should go below the guidelines. The other way is through a settlement agreement. It's just like criminal court. When you get a plea deal, the state will offer you a deal. It'll say, if you want to accept it, you pay a $1,000 fine, you take 2 hours of continuing education, and the case is over. You say, yep, that's a great deal. I committed the act. I want to accept it. You sign it. You go before the Board of Osteopathic Medicine, and they either accept it or reject it. If they reject it, then they'll make you a counteroffer. All of this is done with you understanding that your license has due process rights attached to it. Does anyone here have a driver's license? 1, 2 people. Great. So you have that license. The government can take that license away from you without affording you due process rights. The government cannot take away your property without affording you due process rights. Your license as an osteopathic physician is a piece of property, and the government must afford you those due process rights when they are trying to attack, discipline, or affect your license in any way. So these are some of the penalties for prosecution. You see here at the bottom, pre-signing blank prescription forms, first offense, reprimand or suspension, and a $5,000 fine, second offense, probation and revocation. If you were to be charged with pre-signing blank prescription forms for the first time and they send you a settlement agreement and they say, we want to settle it we're just going to revoke your license, you would say, wait a minute, that's way beyond what the guidelines call for. I'm not going to accept that. So then you would go to an informal hearing, and that's where you would try to mitigate the penalties against you. All right. Once it's over, one side's not going to be happy. It's either you or the state. If you're not happy and you don't have a license, then you're going to appeal that to the District Court of Appeal. If the state loses and you get to keep your license, they may pursue an appeal as well. But more likely, when you lose, you'll appeal, and all of those appeals go to the District Court of Appeals. Here's the slides on medical marijuana, all the new information on the consent forms and the documentation required, and the new practice standards related to the smoking of medical marijuana, and the requirement that you can no longer do it through telehealth. Oh, sorry. Last section, medical ethics. We got 4 minutes or an hour and 4 minutes. Why you should be concerned about medical ethics. It's not just your medical ethics, but the ethics of those around you. You have an obligation under 456 and under 459 to report another practitioner that you believe has violated the Practice Act. That is a encumbrance on you as a licensee, and it goes to the medical ethics and the AOA Code of Ethics. There are, I think, 19 that we'll get to. Here is a case of live interactive medical ethics, and you can make your own determination as to whether or not it's good.
Multitasking rose to a whole new level at a Sacramento Superior Court hearing last week.
Are you available for trial? It kind of looks like you're in an operating room right now.
I am, sir. I'm in an operating room. Yes, I'm available for trial. Go right ahead.
Do you
Board certified plastic surgeon Dr. Scott Green was sworn in for his live stream traffic court hearing and then appeared to continue working while waiting for the court commissioner to appear. Commissioner Gary Link stated his objection.
I do not feel comfortable for the welfare of a patient if you're in the process of operating that I would put on a trial.
Dr. Green tried to reassure him.
I have another surgeon right here who's doing the surgery with me, so I can stand here and allow them to do the surgery also.
Not at all. I don't think so. I don't think that's appropriate.
Commissioner Link immediately put the brakes on the hearing.
I apologize, Your Honor, to the court. Sometimes surgery doesn't always go as
you know, it happens. We want to keep people healthy. We want to keep them alive. That's important.
The Medical Board of California released a statement saying it expects physicians to follow the standard of care when treating their patients. The board is aware of this incident and will be looking into it. Dr. Green's office had no comment. Nichelle Medina.
All right. So medical ethics involves examining a specific problem, usually a clinical case, and using values, facts, and logic to decide what the best course of action should be. Some are very straightforward, some are very complex in choosing between two rights. Choosing between two rights, two values that are in conflict with each other, or deciding between two different value systems, such as the patients or their guardians versus the doctors. And here are some examples of medical ethics scenarios: covering up a mistake, cherry picking patients, prescribing a placebo, upcoding to get treatment covered, physician abuse of patient, inadequate record keeping, dishonesty, conviction of a felony, delegating the practice of medicine to an unlicensed individual. Those are all medical ethics issues. Here is a real life scenario of a medical ethics issue that was presented to the hospital staff in a hospital in South Beach, and it deals with tattoos. This is just a slide of all the cool tattoos. I don't have any, but if I did have one, it's going to be this one. They wrote their living will out tattooed, and then they all signed with tattoo ink. That's good. Then this guy said no CPR. CPR okay now, changed my mind. Oops, bad diagnosis, no CPR again. This guy, I don't think could be any more clear. Do not underline resuscitate. So the issue was there was a elderly patient, 70-year-old, with a do not resuscitate tattooed on his chest, presented to the hospital. No next of kin, no medical records, and they weren't sure what to do. The medical staff met, they talked with their ethics team, consulted their general counsel, and they determined in that situation for that patient, they were not going to provide any life-sustaining measures to that patient. The patient then, the condition soon deteriorated, and then he died without any CPR. The next day, they discovered all of the medical records, and within there was a valid do not resuscitate form. There's two of them up here. They're the exact same. Only one of them's valid. Anyone know which one? Yellow one. You get you a payday. All right, the yellow one, and I'll get that to you. The yellow one, it must be written and printed on yellow canary paper. At the time that they wrote the statute, yellow canary paper had a stronghold on the legislative body. And so they made a lot of money off of yellow canary paper, I bet. But so the one on the right is the one that they have to have. So in that, I'll give you one more example. Same scenario, 30-year-old man presents to a ER in Reno, Nevada, and had on his chest above his heart DNR tattooed. He presents to the hospital, not conscious, no next of kin, no medical records, and the staff wasn't sure what to do. Should they abide by the DNR wishes? They, in that case, decided not to. They provide life-sustaining measures to that individual. He then survived. They asked him about it afterwards, and he said he had lost a bet to his best friend, whose initials were DNR. So here, this is an example about impairment and what you can do. These are all medical ethics issues. Sexual misconduct in the practice of osteopathic medicine also is a violation of your ethical standards, and it's a violation of 456 and 459. And this case is about a patient that called the physician. The physician called the patient back, breathing heavily, offered them a job. He was breathing heavily and his tone of voice changed, stated inappropriate things to the patient. They were disciplined for that, and the action taken was revocation of that physician's license. Again, it's not only your ethics, but all of the practitioners around you and your obligation to report them. Here are some additional ethical violations under 456. Here are all 19 of the AOA Code of Ethics. If you don't like something I said, I apologize. If you don't like something in rule, you can ask the board for a variance or waiver. If you are not sure about what it says, you can ask them for a declaratory statement. And if you don't like something written in statute, we must go to the legislature and change that. Here are all the resources that you need. Again, call the FOMA office or my office or my cell phone if you have any questions. I appreciate you. Thank you for your time. And you can't leave. It's not over for you. It's over for me. Thank you.
All right, thank you, Jason Wynn. Our next speaker is going to be Dr. Katina Brown Burgess. I'm going to be speaking on domestic violence and issues and concerns. So Dr. Katina Brown Burgess has been practicing obstetric and gynecology since 2006. She graduated from Emory University with a Bachelor of Science degree in biology, received her medical degree from Nova Southeastern University, Kiran C. Patel College of Osteopathic Medicine. That has gotten really long since I got out. And she completed her OBGYN residency in Detroit, Michigan. It was during her residency that she realized service of patient and patient education would be a foundation of how she would practice. As a National Health Service Corps scholar, Dr. Brown Burgess began practicing obstetrics, serving patients in underserved communities in Milwaukee, Wisconsin. After completing commitment, she returned to Florida, where she continues to practice in the underserved communities of Broward and teach medical students. Currently, Dr. Brown Burgess serves as a clinical assistant professor at Nova Southeastern University, Kiran C. Patel College of Osteopathic Medicine, and the co-course director for the Human Sexuality Curriculum. She is also the faculty advisor for the Student Association of Obstetrics and Gynecology on both NSU Fort Lauderdale Davie campus and the NSU Tampa Clearwater campus. She is the former vice chair of the Obstetrics Gynecology Department of Broward Health Medical Center. Her department has implemented many state of Florida initiatives, including protocol for OBGYN hemorrhaging, as well as setting department standards and policies managing hypertensive disorders in the obstetric patients. When Dr. Brown Burgess is not busy taking care of her patients or teaching students, she is the mother of 2 boys and keeps her quiet, busy, and extracurricular activities. And yes, she does have free time for enjoy reading, scrapbooking, and working on crafty projects. Let's welcome Dr. Brown Burgess.
Okay, so I guess I'm using the mic on the podium, but I do have a quick question. Is this the control for my PowerPoint? Green is go. Now, what if I need to go back? Do I press green? Okay. All right, so let's begin. So good afternoon. My talk is about domestic violence. It's not really a lot of new information, but we're going to review some old information and some updates in regards to laws referring to domestic violence. Okay. All right. Okay. I have no disclosures, no financial disclosures, conflict of interest, or investigational use I will not be discussing during this presentation. Here are some of the objectives. So domestic violence. Domestic violence is an umbrella term. It includes intimate partner violence, which a lot of people will exchange domestic violence with intimate partner violence, or IPV, child abuse, and elder abuse. Here is the federal definition of domestic violence. No, I'm not going to read this whole entire slide. And this is the Florida state statute of domestic violence. The state of Florida actually broke down or made it more specific in regards to domestic violence. What's interesting about this definition is it doesn't talk about dating or either. So it's a little interesting, but this is what breaks down domestic violence in the state of Florida. Here are some updates. So recently in 2022, actually 2023, the Violence Against Women Act, it was first initially passed in 1994. And basically this act was to provide funding for investigational use and to investigate any violent crimes that were against women. Now, what has updated is the fact that now they include all victims, whether it's male, female, or gender nonconforming individuals. So the Gabby Petito Act is actually on the legislature floor as we speak. It was first proposed back in November 29th of 2023. So I don't know if everyone remembers Gabby Petito, but she was a young lady, 22 years old. She was actually a social media influencer, I think YouTube, I'm not quite sure. But in 2021, her and her boyfriend took a cross-country trip. And I don't know if you guys remember, but unfortunately, there was an altercation that occurred publicly. But that's not what that's not when the police got involved. Actually, what happened was her boyfriend was driving erratically and the officer pulled them over. Immediately, Gabby got out the car. She was crying hysterically. The officer noted that there were marks on her arms and on her face. And there was a slight smear of blood on her forehead. The officer suspected that there was some domestic violence issues going on, particularly with these two individuals. But when asked, Gabby said, "No, it's not a big deal. We just got into altercation. There was an argument." Well, the problem is, and I guess some of you guys have heard this story, she unfortunately lost her life. Her boyfriend, about 24 hours later, killed her, murdered her by strangulation. So Gabby's family came up with a law that they wanted to petition the state of Florida to pass. And basically, this law is mandating all police officers, when they do encounter a situation where they suspect that there's domestic violence, that they perform what they call a lethality assessment tool. This lethality assessment form actually is an 11-question questionnaire. If the individual answers yes to any of the questions, then the officer will move further to execute the situation, okay, whether they need to be referred to a center or they need to prosecute. Unfortunately, with Gabby Petito, with her case, in her situation, the officer did not call the incident a domestic violence incident. He put down mental health breakdown. So if it was a domestic violence, then there would have been an arrest. So unfortunately, with this case, Gabby Petito lost her life. So the Senate is basically enforcing law enforcement to make a written report whether or not there is arrest that is being made. And it's allegedly, if there's any type of incident of domestic violence, it needs to be in a narrative report. Now, if passed, this will take effect July 1st of 2024. So I'm hoping that this law will take in place. So when we talk about domestic violence, it could be a felony in a case where there's life-threatening injuries, or in the case of death, or a misdemeanor, depending on the assault on the victim. It could be anybody. It could be a current or former spouse or intimate partner of the victim. It could be a person who was situated or similarly situated as a spouse of the victim under the domestic or family violence law of jurisdiction in which the incident occurred. It could be a person who is cohabitating with or who has cohabitated with the victim in the past, or if they share a child. That will make them fall under the laws of domestic violence. So why is domestic violence a public health problem? Well, let me tell you, every 73 seconds in America, a person is sexually assaulted. The first one is actually 1 in 3 women. So excuse me for that typo. 1 in 3 women experience sexual violence in their lifetime, and 1 in 6 men experience sexual violence in their lifetime. 27% of women experience violence by an intimate partner, as opposed to 11% in men. So this is a public health problem. Now, let's look at the state of Florida. These are the most current stats that was put out in 2023. I'm still waiting for the annual report for 2022. But in 2020, we all know that that was the heart of the pandemic. 217 deaths were related to domestic violence that were reported to the state of Florida, okay? We all know that with domestic violence, a lot of the cases are underreported. Of that, account for 20% of the murders in the state in 2020, 64% of fatalities related to gun violence. We are now seeing more murders related to domestic violence with the use of firearms. Now, during 2021 and 2022, the Florida Domestic Violence Hotline received over 19,000 calls in regards to the incidents of domestic violence. There are currently 41 certified domestic violence centers that serve 67 counties in the state of Florida. They provide nights of emergency shelters in some cases, and they've done it for over 11,000 individuals. So there are domestic violence shelters all throughout the state of Florida. In 2021 and 2022, the perpetrator demographics gender was 97% male, 4% were women. The median age was 45, and there was a varied range. The perpetrator gender percent was male to female was 90%. From male to male was 6%, and female to male was 4%. I'm quite sure that number would be higher, but we all know that a lot of the incidents, like I said, are underreported, especially when you're talking about female to male victims. Now, I will tell you in 2020, there were the top 10 counties that had the most reported domestic violence cases. It was Leon County, Marion County, Duval County, Levy County, DeSoto, and so forth and so forth. So the most recent stats have not come out yet, but they should come out later on this year or beginning of 2025. So when we talk about domestic violence, it's a power and control, the victim and the perpetrator. There's a cycle of abuse and a cycle of violence. First, we have attention building, and that could be related to economics. It could be related to a number of things that would cause tension to build in the relationship, okay? It's a control, violence, and abuse. You have the incident. You also have the reconciliation where the abuser may apologize and give excuses or blame the victim for their action. And then eventually the incident is forgotten, or in some cases, they call it the honeymoon period. So it's a vicious cycle of control, violence, and abuse. And this is just example cycle of violence, which is similar to a cycle of abuse. It's tragic because over 43 million women and 38 million men have experienced some type of psychological aggression by an intimate partner in their lifetime. So here is our power and control. You got to forgive me. I'm going to go through the slides pretty quickly just to make up for time. Power and control over the victim. Intimate partner violence and elder abuse is where it's very common that you will see power and control over the victim. It could be anything with using intimidation, particularly in the public. It could be minimizing or blaming the victim. It could be using children as a tool of manipulation. It could be using their male privilege or female privilege, especially if there's economics involved. So physical and sexual violence. So the signs of physical abuse, you can obviously have intentional bodily injury. It could be bruises of various stages, unfortunately choking and strangulation, gagging or restraint. But a number of people, when the CDC did a survey, they noted that 71% of women, college and grad, as well as 58% of men have had some form of physical or sexual violence or encountered it before the age of 25. So here are some examples of sexual violence when it comes to domestic abuse. You have unwanted touching and fondling. You have other sexual contact, in particular sexting, meaning sending explicit text messages to an individual. It could be rape or sexual assault, any type of intentional exposure to sexually transmitted infections, as well as bruises near the genital areas, but also forced sexual acts. So in 2020, during the Florida Domestic Violence Annual Report, 2.5 million victims had some type of contact of sexual violence, and 1 million rapes were noted in the Domestic Violence Annual Reports. Along with sexual violence, you can also have reproductive abuse. That is when there is a decline of using contraception or manipulation of birth control, or a woman is forced to have an abortion. So these are a number of things that can exhibit the form of power and control. Psychological and emotional abuse is more common than physical abuse. You have the psychological aggression, where you have the use of verbal and nonverbal communication, where there's degrading, there's name calling, there's gaslighting, where you're questioning your reality, isolation from friends and family, withholding information or resources if necessary. Stalking is the most severe form of harassment, and it is considered a significant risk factor for major harm in future incidents. So when we talk about an abuser or a perpetrator, there's no typical personality of an abuser. There are specific characteristics, but it could be anybody. It could be a lawyer, it can be a pharmacist, it can be anybody on the street, it could be a physician. So there's a number of common characteristics. Usually in the case when there is abuse, there is either objectifying the victim, okay, also denying the existence or minimizing the seriousness of their violence. They, may say, oh, well, it's just a hit, or it's not a big deal. You get over it, you'll be fine. A lot of times they'll externalize the cause of their behavior. They may actually blame it on something else that, oh, well, this is the reason why I'm doing it. I didn't mean to do it. I'm so sorry. And you will believe 90% of abusers do not have criminal records. Okay. So why women say they rather stay in an abusive relationship? This could be men and women, okay? Man or woman, excuse me. It could be the source of income. Also, I don't want to make things worse, because what if he does not get prosecuted? Okay, or what if she does not get prosecuted? Then it makes the situation worse, because now they know that you have rebelled against them. Or when he's not being awful, he's kind, nurturing, and wonderful. That's that honeymoon phase once the tension has been released. So emotional findings in victims. Victims experience a wide array of emotions: anxiety, post-traumatic stress disorder. They become emotionally withdrawn. A lot of times, a lot of victims experience embarrassment or shame, simply because they may feel like people are judging them for being a part of a relationship that they are, unfortunately are experiencing domestic violence, feelings of isolation, like I said, or even dissociation of how to deal with the trauma of the abuse itself. Here are some identifying signs of domestic violence. So there's a lot of clinical presentation. It could be obstetrical. Also, psychological effects, the use of substance use or abuse, even the risk of depression that can lead to suicidal ideation. So a lot of times patients will present with general complaints, and that could be in the emergency room, that could be in the office. They may have recurrent visits of backaches or headaches or just vague GI symptoms. And also their explanations are inconsistent with injury. So what can we do as healthcare providers? So a lot of times it's very difficult to detect domestic violence, but so a lot of times we are the first encounter, especially if you work in an emergency department, or if you are OBGYN, you're seeing the patient quite often during their pregnancy. And so there's enough time, or there's plenty of time to encounter the patient. But sometimes domestic violence can be difficult to identify, but we're in a unique position. Because one, we have this trusting relationship with our patients. A lot of patients trust us. They trust us with their confidentiality and discussing some of their problems. And that's something when an individual, has an issue with domestic violence or has some concern, we have to assure her safety or his safety, simply because they are assuring that we are protecting them and protecting their information. Also, when it comes to confidentiality, it's a HIPAA laws, so we are not allowed to share unless it's mandatory reported. In the case of mandatory reporting, which I will talk about a little bit later on in this talk, you have to inform the patient that yes, you can disclose what's going on, but unfortunately there may be some information I might have to mandatorily report. So what is our responsibility? first and foremost, creating a safe space for disclosure. You need to know if the patient is safe. If she comes to you or he comes to you, make sure that they're safe. If they are safe, then you can say, okay, you can proceed with telling me whatever you want to tell me in regards to this incident. Separate the person or the victim from the perpetrator. Okay, get them in the room separately by themselves, or have them in a separate area to do your exam. Universal screening. It's always good to do universal screening because one, you don't want to make a person feel like they're being singled out. So you do a universal screening, incorporate screening for everyone, because there's no specific way a victim looks, or there's no specific way that a perpetrator looks as well. So incorporating screening for domestic violence should be a part of your routine medical history. Either you can do it as far as doing a form before they actually go into the office to see you, or you can do it on your EHR. In my office, I actually do have my staff to provide questionnaires prior to them actually coming in the room to see me, simply because studies have shown that women will self-report as opposed to being asked a question by the doctor, because they may feel embarrassed. They may feel ashamed. So if they're able to fill out a form prior to seeing the doctor, it makes it a little bit easier for you, because number one, you don't have to worry about what questions to ask, how the patient's going to respond. And then the patient can also disclose what she wants during the intake form. Okay, so normalize screening when it comes to domestic violence, because like I said, we don't know who is a victim. We don't know who is a perpetrator. Utilize professional language interpreters, particularly in South Florida. I definitely need language interpreters to help with either speaking Portuguese or Creole, so that I understand what the patient's talking about. Acknowledge the trauma. Acknowledge the trauma. What does that mean? Give a supportive response. Can definitely have a positive impact on the victim. What I mean by acknowledging the trauma, acknowledge that this person has been abused, or she or he or is in a domestic violence situation. Validate the response. And then they're willing to comply and seek out referrals because they know that you have acknowledged that, yes, I'm in a domestic violence situation. Thank you for acknowledging the trauma. Encourage the patient to create a safety plan. You know, where is she going to go for if there's an emergency? Where is he going to go when there's an emergency, or when there's an incident that might be life-threatening? Who does she call? Or make sure their important papers are in a safe place, so when that moment arises where they need to flee, they have that information. Also offer educational materials and resources. Put it in the bathroom. Okay, put it in the office, in the room where it's much more discreet, but they're able to pick up that information, okay? So when I talk about providing a safe space, definitely ensure the safety of the patient and our children. If there's an individual that has children, make sure that they're okay before you proceed on taking any formal report, okay? Patients need to feel respected and cared for, listened to, and encouraged to make decisions independently, meaning acknowledge or validate their response. Interview the patient without the presence of the perpetrator. When it comes to universal screening, questions, first you want to do a framing statement and just say, you know, we've started talking to all of our patients about safety and healthy relationships because it can have a significant impact on your health. You don't want to just single out people because you don't know who is an abuser, you don't know who's a perpetrator, okay? Some of the screening questions need to be open-ended and they need to be direct, and allow for the victim to expand or respond, on these questions. Oh, let's see, go back. Well, okay, so see if I can go back here, let's see. Maybe not. All right, so there's a number of screening and assessment tools that you can utilize. The HITS assessment tool is something that I use in my office. And it's usually something that's framed in the last 12 months of domestic violence. It's 4 simple questions. It's self-reported. And a lot of times the patients will come in, I will have already reviewed the questions, and I will ask questions based on their response, okay? It's a lot of time. So that's why I utilize my staff to provide the assessment tool, but it's only 4 questions. This is one of the most common ones that are used for domestic violence and screening for domestic violence. The women abuse screening tool is a little bit more comprehensive and it's a little bit more specific. The thing is that it's 7 questions. So patients, a lot of times it takes a little bit longer to fill out. But the women abuse screening tool and the HITS screening tool are 2 of the assessment tools that are commonly used in the office. HARC is the last one that is used. This is a little bit more, it takes a little bit more time. It's not used that often, but some of the educational centers in the state of Florida will use this. So what do you do when your patient says, you know, yes, I believe I'm in a domestic violence relationship, or yes, my partner does hit me and I'm just concerned, I'm worried, I'm concerned, I'm overwhelmed, I don't know what to do. Sometimes he's good, sometimes he's bad, but when he's bad, he's really bad, and I worry about the safety of my children. Or you may have a patient who you suspect are very suspicious that they may be in a domestic violence situation, and they may say no, it's okay. The fact that you're continually asking the question every time they come in allows them to know that, okay, maybe this patient, maybe this doctor really cares about what's going on. So your questions actually help the patient to move closer to disclosure, especially when they give the response of no. It also indicates your willingness to discuss the trauma, the abuse. And when I say discuss the trauma and abuse, it's not like this 20-minute talk. It could be simply, there is help out there for you. I can provide you with resources to help you through this situation, and that's it. Also, by responding to their response, it will let the patient know that, yes, we do have resources to help you, okay? But first and foremost, the patient has to choose to disclose, all right? So you must provide, and in the case of sexual assault, they need to provide some type of informed consent when it comes to physical exam, but you also have to discuss the terms of confidentiality. When it comes to certain things that need to be mandatorily reported by the state of Florida, you have to inform that patient of that. So acknowledging the trauma. Recognize the presence of trauma and acknowledge the role trauma plays in the victim's life. As we discussed before, attending to the patient's emotional as well as physical safety, make sure they're not in any acute danger. Particularly, this is more of an acute situation when a patient is showing up into the emergency room or in an urgent care facility. Also, just remind them that help is available, which is what I've been saying all along. Provide information to help advocate for the patient's well-being and mental health. And recognize that culture actually does play a role in trauma and resilience. You know, there's some cultures where, you know, a patient may be in a domestic violence relationship, and you know, they may have family members that may say, oh, well, you know, that's just how men are. You know, no, you can stick through it. You'll be strong enough. You'll be fine. It's not really a big deal because he's good and bad. He also provides for the family. So those are some of the things that you think about and you have to consider when you're talking about domestic violence in an individual. So this is just an example of acknowledging the trauma. First, you have to ensure their safety. Gain their trustworthiness and be transparent, okay? And they will be transparent to you. Offer support, meaning give them referrals that will offer peer support. Collaborate with other community advocates that may actually provide you with resources that you can provide resources to your patients. And remember, empowering the patients, respecting their voice and their choice. Okay. And just remember that cultural, historical, and gender issues do play a part when it comes to the interpretation of trauma, when it comes to domestic violence. So when you finally get her to disclose, or the patient, when they do disclose that they may be involved in a domestic violence situation, getting the history, describing current complaints using the patient's own words. Be accurate and very objective. Include the behavior and the mood of the patient, because you never know if this is going to be used legally, okay? Include health problems that may be related to the incident, and include the perpetrator's name, address, and relationship. Now, I will tell you that I normally don't include that in my medical records, but they do recommend you to do that, because a lot of times my patients will not tell me that. So, physical exam. The physical exam is a very vital part of the medical records. Once I always say she, that's because I'm OBGYN and all my patients are females. But when it comes to physical exam, that's the most important part of the records. You need to describe all the patient's injuries, bruises, and anything that may be concerning. You can document anatomical diagnoses. You can use photographs. I technically don't do photographs in my office, but I do describe in very much detail if there are any injuries that that she reports. Okay. Obviously, in the case of sexual assault or rape, you need to obtain the patient's consent and perform legally required notifications when it comes to rape and sexual assault, which means you have to report it to the state. So again, documentation. It needs to be as accurate as possible. Timely documentation, meaning that you need to finish that chart and sign off on it as soon as possible. Also, because you never know if it's going to be used in some type of forensic case or in some type of case or prosecution. Also, the history and physical exam findings, document objectively, using the patient's own words. Body map or photographs of any injuries should be included after patient's informed consent. Document if there was any type of firearms used or any psychological abuse. Complete documentation should include like a history. It should include a timeline as well as examination, and if there was any possible witnesses or any children that were involved in the incident. So when it comes to mandatory reporting, so we have child abuse and neglect is definitely something that needs to be reported to the state of Florida, as well as sexual assault or rape, serious bodily injury that might be life-threatening, any gunshot wounds, also vulnerable adults or elder abuse. When I say vulnerable adults, I mean patients that may have medical impairment or mental impairment, where they may take advantage of the individual. But those are your categories for mandatory reporting to the state of Florida. So Florida law, there's technically no reporting requirement for domestic violence except for what I discussed previously on the previous slide. If there's any life-threatening injuries, that must be reported to the state of Florida. A healthcare provider may not report domestic violence without informed consent, because you never know if you're going to put that patient in danger if you do report. If that individual does not have any life-threatening injuries, if there's no sexual assault or rape, it needs to be informed consent, okay? Because you never know who's going to be at harm or going to be in danger if reported without her consent or his consent. So making a report. Everyone, including a mandatory reporter, should call the Florida Abuse Hotline. There's 3 ways to report it. It's either through telephone, fax, or TDD. While a reporter may not know all the pertinent information, the following information can definitely help facilitate the investigation. Again, this is where it comes to your medical records and documenting any findings, specific descriptions of the incident, who was involved, what occurred, when and where it occurred and why it happened, the extent of their injuries that may be of concern. If you can also address all the subjects, including the current location where the occurrence occurred and potential risk as well as demographic findings. But most importantly is identifying the telephone number to report the incident. I'm almost done. Let's see, you guys get a little break. So how are we doing? So back in 2018, there was a study that was done amongst OBGYNs. 125 OBGYNs actually answered this survey. It was called Physician Readiness to Manage Intimate Partner Violence. 12% of the 125 OBGYNs that actually answered the survey said that they do not currently screen for IPV or intimate partner violence. 47% say, well, we only screen new patients. 46% said, well, we screen all patients, but only at annual visits, which is once a year. 39% say that screen all pregnant patients at specific times during their pregnancy. 64.8% were unsure as to whether they were practicing in a state where it's legally mandated to report IPV cases. And 36.8% agreed that they did not have sufficient training to assist individuals in addressing intimate partner violence. This is very interesting because when it comes to obstetricians and gynecologists, we usually see a woman more than once a year. So it's interesting that some 47% say, well, we only screen new patients. I understand that it can be time consuming, but we don't know when we don't know when someone is going through a domestic violence situation. And unfortunately, patients should be screened every time they come into the office because things do change personally and things may change in someone's relationship. So identifying the barriers. So some of the reasons why physicians do not consistently screen for domestic violence: insufficient training, meaning they're not quite sure whether or not they have the proper training, which everyone should have proper training when it comes to screening for domestic violence. Time constraints, totally get it. I'm an OBGYN, I have students, I have residents, and then I'm also trying to see the patient. That's where you have to utilize your staff to assist you in doing the screening for you. A lot of times doctors may not have enough personnel to actually do it. They have a discomfort with the role, like they may have a personal bias against screening for domestic violence because they may feel like they're offending the patient by even asking. And that's where it's key to have a framing statement to say, well, we're screening everyone because we know that domestic violence has an impact on someone's health. Also, privacy concerns and fear of legal involvement, particularly, a lot of doctors will say, well, intimate partner violence is a private matter. I really don't know when I should report it. I'm not quite sure, so I just leave it alone altogether. Or they're not familiar with some of the available resources. Hence is why, we go to conferences and try to get this information. Also, fear of disruption of the relationship with the patient. You might have a close relationship with a particular patient, and you may suspect, in the back of your mind, you may suspect that there may be something going on as far as psychological abuse in their relationship, but you don't really want to disrupt the relationship that you may have with this particular patient. So I'm almost done. So keep a list of resources and referrals in the office. And I mean, I've encountered doctors and they're like, well, what am I supposed to use? What am I supposed to keep in my office? Well, first and foremost, you need to have the hotline, domestic violence, the national domestic violence hotline phone number in the bathroom, in the restroom, because the perpetrator could actually accompany them to their visits. They may come into the room with them. So leave it in the bathroom or the restroom. You can also put it in the lab if they're getting a lab draw. And also educate your staff about domestic violence, meaning that if you suspect that there is a patient who may have issues with domestic violence, please come to me, or you can at least make a note in the chart saying, or put a star in the chart, or make some type of note to let me know that this patient may be coming in with some issues. Also, law enforcement, shelters, providing that information, local hotlines, child protective services. You also have domestic violence shelters, because we have 41 in the state of Florida. And these are just other things that you may have. Obviously, in my office, I don't have all of these, but I will tell you that I do have like the local hotline phone numbers, as well as phone numbers to shelters to assist me in the case when there is an issue where a patient may need a referral. So these are the hotline numbers. Sorry, it's a little bit offline, but the Florida Domestic Violence Hotline is 1-800-500-1119. The abuse hotline is 1-800-96-ABUSE, and elder abuse is 1-800-962-2873. So sorry about that slide, but just remember, we're almost towards the end. So just remember that domestic violence is a public health issue. It's underreported, and a lot of times it's underreported because victims may feel embarrassed. They may feel ashamed that they even have to disclose this information. But sometimes they need help in disclosing the information and saying, "Hey, I'm in a situation where I feel like I'm being abused." Our role as healthcare providers is, number one, to be an advocate for our patients, but also provide our patients with the resources to empower them to make that decision, to overcome the trauma, to move forward in getting the proper referrals, to getting the help that they need. So it's very important that we assist them in doing so. And by knowing the signs and symptoms of domestic violence and realizing that there are a number of characteristics that you will identify during your interaction with your patients that will help you to help them to advocate for their health and for their safety. Here is a slide of resources and support. I will tell you that the National Health Resource Center on Domestic Violence is a wonderful resource for healthcare providers. So the first time I encountered a patient who I knew that she was involved in an abusive relationship. She was an OB patient, and on occasion, I would see bruises on her hand. I would see bruises on her arm. Her boyfriend would actually call several times during the visit while I'm in the room trying to examine her. And so I knew it was domestic, but she always said, "No, I'm doing fine." But one day, it's postpartum, she came to me. It was a postpartum visit. And I asked her how she was doing. And she started to just wail and started to cry. And I said, okay, this is the moment. I felt a little nervous because I had never referred anyone to a shelter. I had never done this whole domestic violence thing. So all I knew was the hotline number. And, her boyfriend at the time he became physically abusive. So first it was psychological during her pregnancy. He would call her constantly during the visit. He would prevent her from getting help if they needed help with obtaining items for the newborn child. So I remember just saying, I didn't even know what to say. And I just remember saying, "You know what, it's okay. I have some information that can help you." And I immediately called the National Center for Domestic Violence. It's a 1-800 number. And I actually called on my private cell phone because at the time I was in shock because I was just like, oh my goodness, like this is what I talk about all the time, and this is actually happening. So I actually used my personal cell phone number and I called the 1-800 number. And I stepped out the room. I told her, I said, I'm going to step out the room. You can stay here as long as you can to disclose what you need to disclose. I will not, interfere with anything that you say. So I stepped out, came back about 8 minutes later, maybe 8 to 10 minutes later, and she got the information. She still went home to her perpetrator because, unfortunately, sometimes when you don't have finances and you need support, sometimes you have to go back to the perpetrator. And I tried to reach out to her, but her phone was disconnected. 6 weeks later, she shows back up in the office. This time she was smiling, and I said, how are you doing? I know we did the hotline a couple weeks ago, well, 6 weeks ago. And she said, you know what? Thank you, Dr. Brown Burgess, because yes, I did go back to my boyfriend that day. And I said, it's okay. I understand, because you have to make that move yourself and empower yourself to do that. And she said, but I have since left him. I was able to reach out to the people again from the hotline, and they were able to help facilitate and create a safety plan for me so that I was able to leave and not look back. So that was the day that I decided I was going to start talking about domestic violence a little bit more, because I didn't realize how much it really touched her life. We go through conferences and we study about domestic violence, or, we sit in lectures and listen about domestic violence, but it's not until you actually encounter a patient who in your heart that there's issues going on with their relationship that you actually step up and you actually help that patient. Because sometimes as doctors, we don't really know if we're really helping patients who are in an abusive relationship, but just that simple word that there is help for you can help them. So think about that when you guys go back to your office, your urgent care, back to the hospital, that you actually can make a difference. There are so many resources out there for physicians. You don't need to know everything except know when to mandatorily report a case. There are agencies, like I said, with the National Health Resource Center that help healthcare providers. They will walk you through any steps that you need, but make sure you understand that this is a team effort. It's not only you, it's law enforcement, the police officers, it's also the domestic violence centers. It's so many resources that we're not alone as physicians, because sometimes we encounter patients who are in abusive relationships, and we do not know how to even approach or say, or how to help these patients. So please, take note of some of the resources that I have here. Also, there's domestic violence resources for LGBTQ plus community. There's statistics that say that transgender individuals are the highest number of individuals that sexual abuse and physical abuse among all of the individuals in the country, simply because of the choices that they make. And so there are many resources, because a lot of times, a lot of the domestic violence centers may have specific rules. And unfortunately, transgender individuals cannot stay at some of these places. And so there are plenty of resources out in the country. I created this slide a little bit over a year ago, but there's so many more resources, but definitely you can start with this when it comes to helping out individuals in the LGBTQ plus community. And the most important slide is the 1-800-799-7233. All right, thank you. Here are my references. Thank you very much. Yes. Right. So when it comes to human trafficking and domestic violence, it's all based on federal law because human trafficking is not a consented, how can I say, it's consented type of relationship or interaction. So it's unlawful transferring of individuals across borders of states. It's unlawful laboring of individuals, including sex labor, which is not consented. Domestic violence, on the other hand, domestic violence is a little bit complicated because it involves an individual that either they're living with or not living with, or they may have a child together. And when that happens, then you worry about the economic status or economic support of that particular patient. It's a little bit more of an intimate setting because of because they know the perpetrator as opposed to human trafficking. It's the more unlawful act of employment or labor, I should say. And so those are the two differences. I don't know the exact federal law or the statute in the state of Florida. I do know that they are working on trying to make some changes in the Florida statute because a report just came out, I think about a month ago, in regards to the number of human trafficking has actually increased in the country. As far as in the state of Florida, the numbers have also increased. And so they are making some changes as far as statute, but it's much more difficult because you have transfer of individuals across borders. And so it becomes a federal offense, okay? Yes, one in the back first. So I've had an encounter as well. I always refer to the patient. I'll say, well, do you want to be examined by yourself? I prefer to examine you by yourself simply because I am a GYN. I do have an advantage because I'll say I'm a gynecologist and I'll say, well, I'm doing a female exam. I will call you back in after I'm done with my exam. So you kind of still keep them in the fold because there's a whole power and control, right? So, I mean, I have, like I said, I have an advantage because I'm an OBGYN and I'll say, I'm doing a gynecological exam. Give me about 5 minutes and I'll let you back in. Yes.
It is a 6-inch slicer. She picks up the slicer and shoves it into him. What happens to her?
Repeat the first part. I couldn't hear.
The woman is being beaten, choked, kicked, etc. Against the counter, she reaches out. There's a 6-inch slicer. She picks up the slicer and shoves it into him. What happens to her?
Well, I'm gonna tell you right now, I'm not a lawyer. Where's Jason? So of course that would have to go through the court of law. Yes, law enforcement will be called. It has to go through a court of law. It depends on if it's self-defense. It's all about the incident and what was the motive, what was the intent, I should say. So that is a law question that I suggest you ask Jason Nguyen, who is a wonderful criminal law defense attorney. Even though he's doing the other stuff now, he's a great criminal law defense attorney. But yeah, that has to fall into the court of law. Well, yeah, but was he at the time, was he assaulting her? Are you sure? No, I'm just kidding. So in that case, it'll be self-defense. Now, if they've had a history of abuse, it may fall under domestic violence because they will follow up on reports that have already been made with the police department. Someone else? Yes.
I'll change. I'll change.
Maybe it ran the battery out. There we go. Yeah.
Yes.
You do, of course, gynecology, and I'm at the opposite end of the spectrum. I do geriatrics. And the only time we see pregnant patient is the staff members, but anyway, at the nursing home or other facilities. But just to get the point across, just because most of the time it seems like it's younger or middle-aged people, but in geriatrics, we still see domestic violence. And sometimes it's been because the person's been trained not to say anything all those years. One time the sheriff's department called me, I work closely with them, and they said, we have a couple here and we're not sure if there's some cognitive issues, but she's claiming he hit her, and then he says, no, she pushed him, and this and that. So I got involved and contacted the family, and they said, yeah, there's been some issues going around for a while. So the family member removed the wife from the house. I think at that time she was 80, he was 80, 85, something like that. So just because they're older doesn't mean it doesn't happen. And even in the nursing home, sometimes people come in together, or assisted living, they're in the same room, and they find that there's either verbal or physical abuse that occurs. And then, of course, we still have to notify DCF, and then we've got to separate the individual. So it could happen in any age group, you know?
Right. So if it's elder abuse or child abuse, it has to be reported to the state. Domestic violence in regards to intimate partner violence is a little bit more complicated. But yes, elder abuse, because of, there could be cognitive delay, and they could be taking advantage of the individual, whether it's physical, sexual, or even financial, in the case of elder abuse. Yes, thank you. All right, any other questions? All right, well, you guys enjoy the rest of the conference. Stay warm. I have a cousin who's in Chicago, and she's like, it's minus 30 degrees. I'm like, I'm just freaking out over 59. So hey, enjoy the rest of the conference. Thank you.
Hey, we made it to 44. Thank you, Dr. Burgess Brown. Excellent talk. We've got a 30-minute break coming up, so we're going to reconvene at 4 o'clock. Dr. Cynthia Mayer is going to be talking on HIV, as she's an excellent speaker, so don't miss it. Don't forget to go visit our vendors, and don't forget to do your silent auction.
Why don't you own commercial real estate? Yes, you. Why don't you own commercial property? After all, just one commercial deal can dramatically impact your financial life forever. Just imagine one commercial deal paying all of your monthly expenses month after month after month. It can be done. Others are doing it, and so can you. So what's holding you back? Are you just not sure what to do or how to get started? Well, I can help you. Here's what I want you to do. Go ahead and get your free copy of my best-selling book, Commercial Real Estate for Beginners. The link will appear right here. Go ahead and click on it. No catches, no strings attached. The link will appear right here. And I'll also include free access to my video course, How to Buy Your First Commercial Property. Hi, I'm Peter Harris, and I've helped countless people become financially independent with commercial real estate investing. And I believe I can help you too. You see, commercial real estate has created more millionaires than any other investment vehicle out there. It has stood the test of time in all market cycles, regardless of where we are in the economy. And it is the most tried and true pathway to financial independence. So to get you started on your journey, go ahead and click on the link here, download my best-selling book, Commercial Real Estate for Beginners. Also, I give you free access to my course, my video course, How to Buy Your First Commercial Property. My hope for you is that the next time someone were to ask you, do you own commercial real estate? You can say yes.
Recordings just got better. Hey, it's Dana from StreamYard. I'm so excited to announce that local recordings are now available on StreamYard. Have you ever done a recording where your guest just had terrible internet issues? They were blurry, they were freezing, you could almost hardly hear them. Well, with local recordings from StreamYard, you'll be able to download a perfect quality video from your guest after the show. This means that no matter what you or your guest's internet connection is like, you'll be able to download the perfect high quality recording every single time. You can also download both a separate audio and a separate video file for the hosts and guests. Now with StreamYard, you can have freeze-free studio quality recordings on any connection, anywhere in the world. You can choose to download them, stream them later, or edit and repurpose them. It's your turn to test out local recordings.
I walk along the avenue. I never thought I'd meet a girl like you. Meet a girl like you. With auburn hair and stormy eyes. The kind of eyes that hypnotize me in the road. Hypnotize me in the road. And I rise. I am so I just run, I don't know why. Couldn't get away. A cloud appears above your head. A beam of light comes shining down on you. Shining down on you. The cloud is moving near the snow. Aurora get away. Reach out a hand, touch your face. Slowly disappearing from my view. Disappearing from my view. Reach out a hand to try again. I'm floating in a beam of light with you. A beam of light with you. And I ride. Just ride. I just ride. Gives a pass a slip. Step on the grid. Break your mama's back. When a problem comes along, you must whip it before the cream sets out too long. You must whip it when something's going wrong. You must whip it. Now whip it into shape. Shape it up. Get straight. Go forward. Move ahead. Try to detach it. It's not too late to whip it. Whip it good. When a good time turns around, you must whip it. You will never live it down. Unless you whip it, no one gets away until they whip it. I say whip it. Whip it good. I say whip it. Whip it good. Correct that whip. Give the pass a slip. Step on the grid. Break your mama's back. When a problem comes along, you must whip it before the cream sets out too long. You must whip it when something's going wrong. You must whip it. Now whip it into shape. Shape it up. Get straight. Go forward. Move ahead. Try to detach it. It's not too late to whip it into shape. Shape it up. Get straight. Go forward. Move ahead. Try to detach it. It's not too late to whip it. Whip it good. Tired or short enough to even try. Try a little harder. Something's wrong, you're not naive. You must be strong. Baby, try. Hey, girl, move a little closer. You're too shy, shy. Hush, hush, I do I. Too shy, shy. Hush, hush, I do I. Too shy, shy. Hush, hush, I do I. Too shy, shy. Hush, hush. Modern medicine for sure your complaints. Try a little harder. Moving in circles, won't you dilate? Baby, try. Hey, girl, move a little closer. 'Cause you're too shy, shy. Hush, hush, I do I. Too shy, shy. Hush, hush, I do I. Too shy, shy. Hush, hush, I do I. Too shy, shy. Hush, hush. To shine, shine, hush, hush, I do want to shine, shine, hush, hush, I do want to shine, shine, hush, hush, I do want to shine, shine, hush, hush, to shine, shine, hush, hush, I do want to shine, shine, hush, hush, I do want to shine, shine, hush, hush, I do want to shine, shine, hush, hush, to shine, shine, hush, hush, I do want to.
Beautiful girl, love your dress. High school smiles, oh yes. Beautiful girl, love your dress. Where she is now, I can only guess. Cause it's gone, daddy gone. Love is gone, it's gone, daddy gone. Love is gone, it's gone, daddy gone. Love is gone, it's gone, daddy gone. Love is gone away. I see you, eyes will turn blue. When I see you, clouds and eyes turning blue. Cause it's gone, daddy gone, the love is gone. It's gone, daddy gone. Yeah, it's gone, daddy gone. Yeah, it's gone, daddy gone. Love is gone away. Tell by the way that you switch and walk. I can see by the way that you baby talk. I can know by the way that you treat your man. I can love you, babe. There's a crying. Cause it's gone, daddy gone. Love is gone. Yes, it's gone, daddy gone. Love is gone. Gone, 15 smiles, oh yes. Beautiful girl, lovely dress. But where she is now, I can only guess. Cause it's gone, daddy gone. Yeah, it's gone, daddy gone. Say it's gone, daddy gone. It's gone, daddy gone. Love is gone.
Love is so confusing, there's no peace of mind. If I fear I'm losing you, it's just no good. You're cheesing like a river. Was that love? And it was again. Soon turned out a hard glass. Seems like the real thing wanted to fall. Nature is lost, lost all behind. Lost inside, a stumble confusion, and I cannot hide. From what you use and with some push inside. We could have made it through, yeah.
Tampa. Can you hear me? There, okay, sorry about that. All right, our last session, after this session, will be a reception for those of you that like to stay and mingle, some food and beverage. Our next speaker is Cynthia Mayer. Cynthia Mayer is a graduate of the University of Florida with a Bachelor of Science in Nutrition and Dietetics. She received her Doctor of Osteopathic Medicine from West Virginia College of Osteopathic Medicine. She served an internship here in Pinellas County at Suncoast Osteopathic Hospital, followed by her fellowship in infectious disease and tropical disease at the University of South Florida Morsani College of Medicine. She's boarded in internal medicine and infectious and tropical disease, is a fellow of the American College of Osteopathic Internists, recognized by Best Doctors in America, the recipient of the Morris O'Staten Outstanding Lecture Award on several occasions at Suncoast Hospital, serves as Associate Director of Tampa Care Clinic and the Pinellas Care Clinic, and the Medical Director, Tampa General Hospital Primary Care Unit in Tampa, Florida. She's also Medical Director of Comprehensive Research Institute at St. Joseph's Hospital in Tampa, Florida, from January 2007 to present. She has an academic appointment as Clinical Collaborative Professor, Department of Internal Medicine, University of South Florida. She is in practice in infectious disease and tropical disease with Infectious Disease Associate in Tampa. Please welcome Dr. Mayer.
Okay, well, I apologize for being late. I ran over here from Tampa. I thought I had tons of time, but as it is nowadays with the traffic, it's horrible. You can never predict. Thank you. So I appreciate everybody staying and bearing with me. It's a pleasure to be here. I appreciate the organizers for inviting me. And I have no financial disclosures. So today they asked me to talk about an update on HIV. So if I can advance with the green button. Green button. Okay, too far. So I thought I would talk about a little bit about like where we were and where we are today. And actually I started practice over 30 years ago and started taking care of HIV patients at that time. And back then, you know, HIV was kind of a death sentence. Everybody was really ill. They did really poorly. They had a lot of symptoms, both related to opportunistic infections, but also just from having HIV itself. And the treatment options were very poor. They weren't effective, and they had a lot of side effects, a lot of toxicities. So we've come a long way now in 2023, or I should have put 24. Now it's a chronic manageable disease, and people can live a near normal lifespan. Most people are healthy and basically asymptomatic. There's very, very few opportunistic infections anymore. And treatment options are very good. Drugs are very effective. They're very well tolerated with few side effects, and the regimens are very simple. But people are living longer, and now we're seeing a lot of comorbidity. So there's a lot of other medical conditions that people are getting, and they're getting them at a younger age. So just to review, like the most recent statistics that we have in 2021, there were 1.2 million cases of HIV in the US and about 117,000 in Florida. And about 13% of people were unaware of their diagnosis. But that's actually an improvement because in the past that number's been a lot higher. As far as new infections in 2021, there were 36,000 new infections in the US, but this is actually a decline. For a long time, there were about 40,000 new cases of HIV every year. And it wasn't until about 2015 that we finally started to see a decline in the numbers of new cases. So in 2021, the new cases were down about 12%. And then in Florida, there's about 4,000 people living with HIV. The demographics are still pretty much the same. In the US, the most common risk factor for acquiring HIV is men who have sex with men, and also patients who are African American are at disproportionate risk for acquiring HIV. Now, worldwide, HIV is really more common in heterosexual people, but in the US, it's MSMs. So data suggests that diagnosing people early and treating them early has a lot of benefits, both in terms of not progressing, their HIV not progressing, having less comorbidities, and then also decreasing transmission to their partners. So I think the role of the primary care physician really has expanded, because since most people are doing well, most of them have a primary care doctor, and also HIV doctors. It's really hard to keep up with, changes in diabetic management and heart disease and diabetes. So we used to pretty much manage these patients on our own, but nowadays, really, most of them are managed for these other medical conditions by their primary care physician, whether it's family practice or internal medicine or a subspecialist in internal medicine. So I think the primary care doctor's roles are to help co-manage these patients, also to screen patients, so doing testing, on patients who are high risk, who need to be tested. And then in some cases treating, some people feel comfortable starting treatment or referring to infectious disease. And then also identifying people who would benefit from preventive measures like pre-exposure prophylaxis. And we'll talk about that a little bit. So with that in mind, my goals today were to review these topics, reviewing the ending the HIV epidemic incentive that is going on in actually worldwide, discussing some about HIV pre-exposure prophylaxis, testing and treating both in patients who come for PrEP and also patients who are initially diagnosed with HIV. How do you follow those patients? What tests do you need to do? We'll talk a little bit about laboratory monitoring, including viral loads and CD4 counts, among other things. I'm just going to touch briefly on initiating treatment, because a lot of people will refer these patients to ID, but we'll talk a little bit about first-line therapy, not a lot of detail. And then opportunistic prophylaxis, immunizations, and a little bit about comorbidities. So the ending the HIV epidemic is actually a worldwide initiative. It was started by WHO, and it's also an initiative of the CDC. And they hope to decrease the number of new HIV infections by 90% in 2030. It should be HIV, not IV. You always see the typos after you get up here, right? After you start talking. So the pillars of that are to diagnose early, so to prevent, again, people from progressing and people from spreading the virus to others, to treat early. And there's even initiatives to test and treat, where people are tested and treated the same day if their test is positive. Prevention through PrEP and needle exchange programs, and then initiative by the public health departments to identify any outbreaks and to act on those quickly to reduce transmission. So pre-exposure prophylaxis. So this is the person who is not HIV infected, but they may be at high risk or at risk for acquiring HIV. And probably you see a lot of these patients in your practice. If you think about, if you have a population of men who have sex with men, their risk of acquiring HIV during their lifetime is 1 in 6. So that's pretty significant. If you compare that to women, their risk of breast cancer is 1 in 8. So if you have an MSN population, they have a high risk of acquiring HIV during their lifetime. And in the South, obviously where we are, we have 51% of all the new cases of HIV in the country. So we disproportionately have a lot of new HIV infections. The CDC, they actually recommend testing all sexually active adults and adolescents or I'm sorry, they recommend offering PrEP to all adults and adolescents who have risk factors. So you have to, talk to your patients about that, and you should at least discuss PrEP with them. So what can you use? There's actually multiple options. There's 2 oral options for PrEP, and then there's now an injectable long-acting antiviral that can be used for PrEP. So the first drug for PrEP that came along was Truvada, or tenofovir. And that drug was actually discovered or released in about 2012, and it's indicated for men and women with a creatinine clearance greater than 60. So Truvada was the first one that was used, and it has been very effective in reducing transmission of HIV. And then we, at about 2019, we got Descovy, which is just kind of a slightly different form of Truvada, where the tenofovir component is more renal and bone friendly than the original Truvada. And that one you can actually use in somebody who has a creatinine clearance down to as low as 30. So you could use that for people with chronic kidney disease. Descovy is not approved for women, mainly because there aren't studies yet, but it doesn't have the indication for women. And then cabotegravir, or Apretude, that was released in 2021, and that's a long-acting injectable antiviral. It's an integrase inhibitor, and patients have to get it every 2 months. You have like a 7-day window if they can't come exactly every 2 months. And it's IM, but it does have to be given at the provider's office. It's not a self-injection at home. It is something that is given in the doctor's office. The IPREC study was actually the first study that showed that PrEP was effective, and that was the study with Truvada versus placebo. And in that study, they found there was a 44% reduction in new cases of HIV in the group that took tenofovir. But when they looked at a subgroup of people who actually had detectable drug level, they found that the prevention rate was 92%. So it appears that if people are taking their PrEP, it is very effective. It has a significant reduction in transmission of HIV. So Truvada and Descovy are daily. Generally, they're once a day. There are some other strategies that some people use, like PrEP on demand, but currently the official approval is once a day. And then cabotegravir, like I said, is once every 2 months. So before you start somebody on PrEP, there is some testing that should be done. First of all, you want to make sure they don't have HIV, because if you give them Truvada or Descovy or cabotegravir, you're giving them suboptimal HIV treatment, so they can develop resistant virus. So they need to have a negative HIV test. Then you should also do like a basic metabolic panel, mainly to look at their creatinine. It's a good opportunity to screen for other STDs, syphilis, gonorrhea, chlamydia, and then serologies for hepatitis B and hepatitis C, basically other bloodborne pathogens. And just a word about syphilis testing. Now we have gone to what's called a reverse algorithm for syphilis testing. We used to do the RPR, and then if the RPR was positive, we would reflex to the treponema antibody. But that missed a lot of like very old cases of syphilis where people's RPR reverted to normal, but they had been exposed to syphilis, but they had never been treated. So now it's recommended that you do the treponema antibody first, the FTA, and then if that's positive, it reflexes to the RPR. So that's the current recommended algorithm for syphilis testing. Who should be screened for HIV? Well, these are the CDC recommendations. Basically all pregnant women, which I think that's done pretty routinely now. And then anybody between the age of 15 to 65 at least once should be screened for HIV. If somebody has risk factors like they're IV drug users, they're sex workers, men who have sex with men, they should be tested more often. And then the American Geriatric Society actually recommends now testing older people for HIV, because we're actually seeing an increase of HIV infection in the geriatric population. If they're on PrEP, they get tested every 3 months while they're on PrEP after their initial negative test. The preferred HIV test now is the 4th generation test. And I put this up here so we could sort of understand what that test is. So the first step of the test detects either HIV antibody or HIV antigen, the P24 antigen. If that is positive, then the next step is they detect HIV-1 or HIV-2 antibodies. If either of those is positive, then it's a positive HIV test. Most of the HIV in the US is HIV-1. We have very, very little HIV-2 in the US. If they're indeterminate, then you reflex to an HIV viral load. So that's a PCR for HIV. If that's positive, then they have HIV. If that's negative, then the test is considered negative, but you should really consider retesting people later. High-risk people, retest them in a few weeks, 3 to 4 weeks. Lower-risk people, you can retest them in a few months. But that's basically how the HIV test is done now. We used to have remember the old ELISA and the Western blot. Now we have what they call 4th generation HIV test. Then when you're seeing your patients, sometimes there's clues that they may have chronic HIV infection. First of all, if someone's asymptomatic, they can be, because people can go for long periods of time, 10 years, without having any symptom of HIV. So no symptoms does not rule out chronic HIV infection. So if they're high risk, no symptoms, they should still be tested. Then people who have like other bloodborne diseases like hepatitis B or C, people with tuberculosis. If you have a young healthy person who gets zoster at a young age, then shingles, basically, you should consider testing them. People with cervical cancer, thrush without antibiotic use, unexplained weight loss, unexplained ongoing, febrile illnesses, or just someone with diffuse adenopathy, unexplained apenias like thrombocytopenia, anemia, leukopenia, any of those other STDs, somebody presents with syphilis or gonorrhea, they should be tested for HIV. And then you also have to think about, sometimes people can have acute HIV and their tests might be negative very early on if they have acute HIV, because they may not have had time to make antibodies. And acute HIV can really look like any flu-like, mono-like, viral-like illness. So you would need to take into consideration, their risk. Do they have risk factors? So if they have, most people have fever, but not everybody. If they might have a combination of some of the things up here, rash. Rash is actually kind of common, fatigue, sometimes GI symptoms, diarrhea, lymphadenopathy, things, non-specific type of findings. Unexplained weight loss again. Acute HIV can present as an aseptic meningitis syndrome. So if you have someone who comes in with aseptic meningitis, think about testing for HIV. And then if they have a opportunistic infection that you wouldn't expect that person to have, then think about acute HIV. When people get acute HIV, their CD4 count will drop, so they could actually get an opportunistic infection early on, but then generally it recovers and that they, to back up to normal for very long periods of time. So if you do diagnose somebody in your office with HIV, what kind of initial evaluation should you do? So initially, you're going to get a good history and physical, find out their risk factors for HIV. Maybe they were diagnosed in the past and got some treatment. You would want to know what they've been treated with before, because they could have developed drug resistance. A good social history, especially addressing risk factors for HIV and other STDs. And then on exam, particular attention to skin, mucous membranes, lymph nodes, neurologic exam. That's all really important. You're going to get your basic labs, your CBC, CMP, your general medical labs that you always order. But then in addition, CD4 count, HIV viral load. And HIV viral load, when you order that, it should be an HIV PCR quantitative. That will tell you actually the amount of virus. There is a qualitative available, but that only tells you yes or no, but you want to get a quantitative so you'll actually know what the viral load is. We get an HIV genotype on all new patients just to make sure they don't have any transmitted resistance. The rate of transmitted resistance is a lot lower now than it used to be. It's around 5%. It used to be a lot higher, but we still get a genotype on everyone. And then in very special cases, depending if you're going to select certain drugs, you would get these other tests, the co-receptor tropism and the HLA, depending on if you were going to use other certain antivirals. And then check for hepatitis, B and C. I check for hepatitis A also because that's an opportunity to immunize people if they're not immune to hepatitis A, and then screen for other STDs. Viral load, like I was saying, it basically tells you the amount of virus. They'll give you the number of copies of virus in that ml of blood. We mainly use you want to get a baseline viral load, but we mainly use the viral load to monitor response to therapy. So you put somebody on antivirals and then you monitor their viral load. And then, you see, is the medication working or not working? Are they being adherent or not adherent? But the main use for viral loads is to monitor control of HIV, viral response. The lower limit of detection, that's the goal of, you want to get people's viral load down to as low as possible. And we have assays now that actually go down to as low as 20 copies. So it used to be like 400 and then 200 and 75, 50. Now we can go all the way down to 20 copies. So some labs use 20, some use 30, some still use 50, but the goal is to get them down to below that limit of detection on that test. Anytime you change therapy for either like side effects or you're going to simplify, you want to repeat the viral load in 4 to 8 weeks to make sure they're still staying suppressed. If they have a change in their antivirals because of failure, they're not being suppressed, so you put them on a new medication, you want to repeat their viral load in 3 to 4 weeks to make sure that their new regimen is working. And then if somebody's stable, I usually get their viral load, like after they are first diagnosed and I put them on antivirals, I'll get a viral load in like usually about 4 weeks. And then usually like about every 3 months until they become suppressed. And once they're suppressed for like 1 year, some people say 2 years, you can really do the viral load like every 6 months. So if somebody sustains viral suppression for a long period of time, you can go out to every 6 months. You don't have to do it every 3 months or every 4 months. If they don't respond, you need to think about drug interactions because some of the HIV drugs do have drug interactions, adherence, and any other issue, any other reason they might be not able to get their antivirals or take their antivirals. Maybe they're having side effects, diarrhea, they're not absorbing it. So they need to be, assessed clinically. The CD4 count, originally 30 years ago when I started in HIV, that's all we had. We only had the CD4 count. We didn't even have viral loads. So we were treating people and we were checking their CD4 count, but and thinking, well, maybe if their CD4 count's better, maybe they're, responding, but that probably wasn't true. So now really the CD4 count, the main reason to check CD4 count is it's a reflector of the person's immune status. So normal CD4 count is, do you know what normal CD4 count is? Anybody want to? Steve, you rotated with me a long time ago. You can't remember. Above 500. 500 to 1500 is a normal CD4 count. So you're going to check a baseline CD4 count basically to see like what is the current status of their immune system. Do they need to be on prophylaxis for various opportunistic infections? And then once they are stable, again, you can do the CD4 count every 6 months. Some guidelines have even gone to like a year. Like if you have a high CD4 count and you're on a stable regimen and you're virologically suppressed, some data even says you can do a CD4 count once a year, and some say you don't have to do it at all. I still tend to do a CD4 count at least every 6 months because patients, first of all, they want to know what their CD4 count is. They're very fixated, on that number. And so I think, every 6 months is reasonable. But again, you could go out longer than that. There is a fluctuation in CD4 counts from lab to lab. So, one time that might be 750, and then the next time maybe they're, 650. But there's a lot of variability, even from day to day or hour to hour, if you measure the CD4 count at various time points. So a 30% reduction in the absolute CD4 count or 3% in the percentage, the CD4 percentage would be considered significant. And I bring this up because a lot of people get worried, a lot of patients get worried because their CD4 count is maybe 800 and the next time it's 700 and they're like, oh, my CD4 count's going down, and they get really upset. But that actually is not, you have to educate them that that's not a significant drop in CD4 count. So again, early diagnosis and treatment is important, and some places even start, some places offer test and treat, other places, offer like get tested and then come back in a few days and start treatment. So we used to wait to treat people to make sure they were going to stay in care and to get all their labs back. But nowadays, the push is towards starting very early as possible. And again, this decreases the likelihood of transmission to their partners, but also people tend, and studies have shown that people tend to remain virologically suppressed and also tend to remain in care if they're started on treatment early. I was sort of like, in the old days, we used to test people and have them come back in a few weeks and see how they're doing, and then have them come back again, make sure they were gonna stay in care before we started treatment. So it took me a little while to kind of come over to this test and treat, theory, but it has been shown that testing and treating early does have many benefits besides virological suppression. They do better long-term, their HIV doesn't progress, they have less morbidities, and they stay in care and tend to stay suppressed longer. Some people even think it might decrease the size of viral reservoirs. So that's a theoretical possibility. So treatment has really changed. On the left is 30 years ago, where people had to take a ton of pills. They took, multiple HIV drugs. All the regimens were very complex. They were frequent. There were many pills. They had a lot of side effects. So you had to give them medication to try to offset their side effects. And then they had opportunistic infections. So you were giving them pills for their opportunistic infections. So people would have like handfuls of pills that they took a couple times a day. But now as far as treating HIV itself, we're down to one pill in a lot of cases, I would say the majority. And then now we have the injectable as well, where people only have to come in every 2 months to get an injection. So things are a lot simpler, and drugs are much more effective. Most people can be virologically suppressed, and they're very well tolerated. The side effects are really minimal. This is a timeline of kind of where we started. So HIV was first identified in 1981, and then in 1987, we got AZT. And AZT was very toxic. It was actually a chemo drug, and you had to take it 5 times a day. The people were already sick. They had very low CD4 counts. They had other, symptoms and opportunistic infections. So they did terribly on AZT, and it wasn't effective. We figured out that, one drug alone is not effective. And then other drugs came along like Zarid and DDI and DDC, and these also were very toxic to people. It really wasn't until about the mid-90s that we got the first non-nucleoside reverse transcriptase inhibitor, and also the first protease inhibitors. And they were kind of game changers because they really could, and we started to be able to measure viral loads. So those drugs really allowed a lot of people to at least be suppressed and really slowed down the progression of their HIV. But the regimens were still difficult. They still were a lot of pills and a lot of side effects. So newer non-nukes were developed, and also newer protease inhibitors that were better tolerated and didn't have to be taken as often came along. And then we started to have combinations of 2 drugs together like Truvada, and even a triplet, that was the first single tablet regimen. So that had 3 drugs in 1 pill. And then we had integrase inhibitors were developed. I think they're in here somewhere, right around here. And so that was another new class of drug that was very effective, also very well tolerated. And then they were able to combine like 2 nucleosides with a protease inhibitor, or 2 nucleosides with a non-nuke, or 2 nucleosides with an integrase inhibitor. So thus the 1 pill once a day came along. And like I said, now we have the injectable as well. So things have progressed quite a bit since the 80s. Who do we start on therapy? We used to wait till their CD4 count got to less than 200 or less than 350. There were a lot of studies that were done, and they really showed that waiting really was of no benefit. People had not only increased HIV morbidity and mortality, but also non-HIV related morbidity and mortality. So the current recommendations, and they've been that way for a while now, is to treat everybody regardless of their CD4 count, to start them on therapy. And there are even people that are what are called elite controllers, where they have HIV, they have a good CD4 count, but they don't have detectable virus, but they're HIV positive. And even those people should be treated with antivirals, because remember, HIV causes a chronic inflammatory state. And even if you're suppressed, you still have chronic inflammation from the virus. So treating that theoretically should help decrease the inflammatory state of the person. You need to counsel the patient, about adherence and also the benefits of therapy. The CDC has come up with this, U equals U, which is undetectable equals untransmissible or untransmittable. So basically, if someone has a viral load of less than 200, they can't transmit HIV to their sexual partner. This only applies to sexual transmission. So you can talk to the patient about, going on treatment and not only being the benefit of the HIV not progressing, but also reducing the risk of transmitting to other people. Now, I always tell people that being undetectable, you might not get HIV from somebody, but you can still get other STDs. So, some people think, oh, my HIV, I'm suppressed, I don't have to worry, but they can still get, syphilis, herpes, gonorrhea, chlamydia, all those things. So it's not really a free pass if you're undetectable. You still need to think about that people can get other STDs. This is a great, if you want a really, really good website for treatment options. This is from the Department of Health and Human Services, and they have HIV guidelines. They have multiple guidelines for treatment in adults, treatment in pediatrics, also guidelines on opportunistic infections in both adults and adolescents. They have perinatal guidelines. And then there's some other guidelines they have as well, like HIV and COVID, and I can't ever remember them all, but it's a really, really good website. It gives you the bottom line about like what to do. Like if you're wondering what drug should I use or what test should I run, if you go to the appropriate guideline, you can find all that information. And these are updated regularly. So they're very current and they change from time to time. So they're a great resource for any HIV information or treatment guidelines. So if you do decide to start treatment, I'm just going to cover this briefly. I don't know if anybody here, prescribes HIV drugs, but you probably have patients that are on them. So the recommended treatment regimen now is a drug. These are the choices in really no particular order. You can do Biktarvy, which is two nucleoside analogs plus an integrase inhibitor. You can do dolutegravir or bacavir 3-TC, which is called Triumec. That's the same thing, two nucleoside reverse transcriptase inhibitors and an integrase. If you do use that drug, there's a medication called abacavir in that combination, and that can cause a hypersensitivity reaction. So you have to do this test called an HLA-B5701 before you start them on that drug, because they can actually have an anaphylactic reaction, especially if they're re-challenged. Usually, the first time, if they have the HLA-B5701 and you give them abacavir, they may develop, like a febrile illness. If you stop it and re-challenge them, they can develop anaphylaxis. So do that test if you're going to use Triumec. Biktarvy and Triumec are both one pill once a day. And Biktarvy you can take with or without food. There's no food restriction with Biktarvy. And there's really few drug interactions with Biktarvy and Triumec. If you can't use one of those, you can go to 2 pills a day, which you can use like dolutegravir, which is dolutegravir with either Truvada or Descovy. So you can use that combination. Or there is a 2-drug combination now that's been out for a couple of years. It's called Dovato, and it's Epivir plus dolutegravir. So it's a one nucleoside reverse transcriptase inhibitor and an integrase. So it's 2 drugs a day in 1 pill instead of 3 drugs a day. You really shouldn't use that if somebody has a very high viral load. So if they have a viral load of greater than 500,000, you should avoid that drug. And also, if the patient's co-infected with hepatitis B, you don't want to use Dovato because it only has Epivir. And if patients have HIV and hepatitis B, chronic hepatitis B, not a history of it or have antibodies, but if they have chronic hepatitis B, they should be on a regimen that contains either tenofovir plus emtricitabine or tenofovir plus lamivudine. So they need 2 drugs against hepatitis B. So actually, bictegravir or Biktarvy would be preferred for that population. Any questions about that? Is it confusing or it's all in those guidelines if you want to. And then there's a lot of alternatives. There are a lot of alternative regimens listed in the guidelines, and they're kind of for special populations, but most people will start on one of these most of the time. So I didn't put in all the alternative regimens because there's so many drugs now for HIV that if somebody has a history of being on PrEP with cabotegravir, and then they develop HIV on cabotegravir, they should not start on an integrase-based regimen because cabotegravir is an integrase, so they could have developed integrase resistance. You need to do an integrase resistance test and put them on a protease inhibitor-based regimen like Prescobix, which is darunavir plus 2 nucleoside reverse transcriptase inhibitors. And if anybody wants more information, I'll be happy afterwards to go over it in more detail. During pregnancy, the current recommendation for women who want to become pregnant or are pregnant is either Truvada plus Descovy plus dolutegravir, which is Tivicay. So that's the recommended regimen. Descovy is preferred again because it's a little more renal and bone friendly than the old tenofovir formulation, which is in Truvada. There's some other alternatives as well if for some reason they can't take the preferred regimen. Now, if somebody's already on, like say Biktarvy, and they become pregnant and they're virologically suppressed and they're doing well, they're saying now that you can leave them on that regimen, even though there is not, a lot of data. They do keep a pregnancy registry, but you should talk to the patient, tell them, it's not the preferred regimen, but it is okay to leave them on a regimen that they're already doing well on and that they're suppressed on. So you're going to do the testing that we talked about. We talked about the viral load, the timeframes, the CD4 count, and then remember also yearly people should be screened for STDs, hepatitis C, yearly or at least on an as-needed basis if the person's not high risk. So a little bit about opportunistic infections. Like I said, we're not really seeing that many anymore, but you should still know like what people need to be on, which people need to be on prophylaxis for certain opportunistic infections. So for pneumocystis, we used to call it PCP, pneumocystis carinii. Now it's got a new name, not that new, but new to some of us, pneumocystis jirovecii, and it's a fungus that causes pneumonia in immunosuppressed patients. So in patients, people who have CD4 counts less than 200, we also see PJP in transplant patients, solid organ and bone marrow transplant patients. The primary prophylaxis is with Bactrim or Septra, 1 a day, double strength, or they can do it 3 times a week. They want to do like Monday, Wednesday, Friday, that's also effective. There are alternatives if someone is allergic to sulfa. Before we used to leave everybody on, if they had a CD4 count less than 200, we left them on prophylaxis. But now they're saying you can stop the PJP prophylaxis if they have a CD4 count greater than 200 for at least 3 months. And even people that have a CD4 count between 100 and 200, if they're virologically suppressed, you can stop their PJP prophylaxis. So that's kind of a newer recommendation. Before it was less than 200, you're always on it. But now if you're above 100 and you're doing well, you've been doing well for 6-12 months, then you can, and you're suppressed, you can stop PJP prophylaxis. Mycobacterium avium complex, that's an atypical mycobacterium. It's a non-tuberculous mycobacteria that causes disseminated infection in immunosuppressed patients. We used to see a lot of this. It was a devastating disease. People were very ill, fever, wasting, anemia, just did horribly. Really hardly see MAC anymore. But once in a while you do. Now, we used to prophylax everybody that had a CD4 count less than 50 with like azithromycin or clarithromycin. We would give them prophylaxis for MAC, but now they're saying if the person is suppressed and doing well and on an antiviral regimen, you don't necessarily have to give them MAC prophylaxis. So we don't routinely start that unless they're not taking their meds, have a very low CD4 count, their viruses, they're not virologically suppressed, then that group of people, we will give MAC prophylaxis. Toxoplasmosis is a parasitic disease, usually like from cat feces, and that can cause meningitis, among other things. The people that are at risk for toxoplasmosis are those that have a CD4 count less than 100, but also they have to have been exposed to toxoplasmosis in the past, because toxoplasmosis in this population is usually reactivation of prior infection. So they'll have a positive toxoplasmosis IgG. So if their IgG is positive for toxo and their CD4 counts less than 100, then you can give them toxo prophylaxis. If their toxo IgG is negative, they don't need prophylaxis, even if they have a low CD4 count. If they're already on Bactrim, then that's adequate for toxo, so you don't have to give them another drug. If they can't take Bactrim, then there are some alternatives. You can discontinue it if their CD4 count is greater than 200 for at least 3 months. And all these discontinuations are kind of new, not in the last year, but in the last maybe 5 years. Before, we would leave people on prophylaxis for much longer periods of time because we didn't have drugs that really controlled the virus. But now that we do, a lot of the prophylaxis that we used to use can be discontinued after a certain period of time. And then Cryptococcus is kind of something that people really don't think about. Cryptococcus is another fungus. It commonly causes cryptococcal meningitis, not only in HIV patients, but also in other immunosuppressed patients. But even immunocompetent people can get toxoplasmosis. So you can have a non-immunosuppressed person with cryptococcal meningitis. And it's caused by the yeast Cryptococcal neoformans, occasionally a kind of a new species, Gaddii. If somebody has a low CD4 count on screening, when you do their initial labs, you should screen them for serum cryptococcal antigen. And if that's positive, then they need to be worked up for any focus of cryptococcal disease, like in the lungs. Cryptococcus can cause pulmonary disease, or in the CSF. Even if they are totally asymptomatic, if they have a very low CD4 count and they have cryptococcus, a positive serum cryptococcal antigen, they should be treated for cryptococcus. And usually it's fluconazole, so it's not really too difficult to treat it. And eventually it can be discontinued once they're treated and then maintain their CD4 count, then it can be discontinued later. If their CD4 count remains low, they should probably just stay on lifelong prophylaxis. Because cryptococcus is another one that can be a devastating disease in people. They can get really sick. We have some transplant patients right now with disseminated cryptococcus in the bone marrow, the blood, the lungs, and it's really difficult. It's very difficult to treat. And don't forget about tuberculosis. You know, we kind of like, don't think about TB all the time as much as we should. TB can look like the typical cavitary, infiltrate, but TB can also look like just regular pneumonia, like community-acquired pneumonia. So all HIV patients should be screened for tuberculosis. And then you can do either the skin test, the TST, or you can use the quantiferon, which is the blood test. I kind of prefer the quantiferon because it's really easy. They don't have to come back and get, the skin test read. I think there's probably less false positives, although you can have a false positive quantiferon. It's just a blood draw instead of doing the skin test and then figuring out how to interpret it and then having them come back a week later. So I really pretty much go into just using the quantiferon. There's another one called T-spot. It's also a blood test. You could do that as well. The quantiferon's a little easier because the T-spot, when you draw it, there's certain things that have to be done. So they have to go to the lab, and only certain labs do it, whereas the quantiferon isn't as stringent. So I do that test. If they have a positive quantiferon, you want to rule out active TB. So you're going to screen them for any signs or symptoms, get a chest x-ray. And if that's all negative, you've ruled out active TB, they should be treated for latent tuberculosis infection. So they should all be treated regardless if they have any symptoms, even if they have like no risk factors, they were never around anybody with TB, they never lived in a foreign country. But if they have LTB, they should be treated because there's the risk of reactivation, especially as people age. There's multiple options now. You can use INH. Actually, INH should be 9 months, not 6 months. So that's wrong. Sorry. There's a rifampin for 4 months. That's also wrong. And I went over these slides so many times. I thought I caught everything. So INH is 9 months. Rifampin is 4 months, daily for 4 months. So that's kind of easy. It's a shorter course. Or there is a once a week INH with rifapentine weekly. It's recommended that it's done under directly observed therapy, and the health departments do treatment for latent TB with directly observed therapy. So that can be an option as well. So immunizations, I love to talk about immunizations. There's a lot of them now. And every day it seems like we're getting a new one, right? Now we have RSV, that's the latest one. But all HIV patients should have their immunizations brought up to date. So you want to immunize them against pneumococcal pneumonia, yearly flu shot, COVID. People with HIV should get the meningitis ACYW vaccine. And that's a 2-part, they get it, I think it's a month apart or 2 months apart, and then repeated every 5 years. They don't need the meningococcal B, but they should get the ACYW, which is 1 shot. It's not 4 shots, it's 1 shot. Tdap, MMR, if they were born after 1956, if their CD4 count's less than 200, so somewhat immunosuppressed, they shouldn't get MMR until their CD4 count is higher because it is a live vaccine. So that's not recommended in somebody who is more immunosuppressed. Shingrix, if they've reached the age for that. I immunize all my patients for hepatitis A and B. I get the serology and then figure out who needs to be immunized. Gardasil is really important in this population because the incidence of human papillomavirus is increasing, as is the risk of HPV-related cancers, both like oral, throat, rectal. So they should get Gardasil. And then Mpox if they're high risk. And comorbidities, I'm not going to go into a lot of detail because that could be like another whole talk, but just be aware that liver disease, heart disease, HIV-related cancers, osteoporosis, these are all increasing in people with HIV as they live longer. A lot of my patients are now aging into 60, 70, even 80s. I have patients in their 80s now. So it's not all young, gay guys nowadays. There's the older population, and they're getting these, and they're getting them at a younger age. So they're getting heart disease at a younger age and diabetes and things like that. And really, I mean, there's so much that's new in all of these fields. I think really they need a primary care doctor to help manage these comorbidities, because like diabetes has gotten like, I can't keep up with diabetes anymore. So I send all my diabetics to their primary or endocrine. So this is really an important place where the primary care physician can help co-manage these patients. They should get routine screening, just like the general population, for lung, colorectal, breast, all those cancers. Screen for hepatocellular cancer in people who have cirrhosis or chronic hepatitis B, cervical paps as per the GYN guidelines, and then anal paps to screen for HPV and also for any dysplasia, any anal dysplasia. And in my group, we do anal pap smears. And then if they're abnormal, we have a couple of doctors who do anoscopy, and they can actually treat the lesions. If they're more invasive, then they get sent to colorectal surgery. But that's really important. And then I think that's all the slides that I have. I'd be happy to answer any questions that anybody has. Yes.
Okay, what I was asking about in the normal population, not HIV.
right.
uh,
Tdap.
With the Tdap, you
Uh-huh.
know, years ago, we were taught in school, once you've had your childhood immunizations, oh, don't ever give them, just give them the tetanus immunization, don't give the others. Now we know differently.
Uh-huh.
But now, if someone has missed, let's say they've had their tetanus shot more than 10 years ago, should they just get one Tdap immunization, or do they have to get it periodically after that?
So they should get one Tdap because, that also covers acellular pertussis.
Right.
And then every 10 years, they can either get just tetanus or Tdap, either one.
Okay, so
Yeah,
so
every
if they've
10
missed,
years.
so let's say they didn't have one for 15 or 20 years, just give them a
Give
Tdap,
them a
and then after
Tdap.
that,
Either
go every
tetanus
10
or
years.
Tdap every 10 years. Or
Okay.
if they have, unless they have like an injury that, an open wound that gets contaminated, then it's every 5 years. And also in pregnancy, they give it a Tdap to a woman with every pregnancy to reduce the risk of pertussis in the newborn. And they actually recommend giving the Tdap to any close family members like parents and grandparents that are going to be around the child.
Okay, thank you.
Yes.
Update on immunization, HIV immunization research.
As far as
The research for
to cure HIV or
preventative immunization.
vaccines? So the vaccines for prevention haven't really been very good. There's none that are anywhere near, being available or being effective. There are some new strategies to try to control people, to control their HIV without antivirals, and they're immune-based. So one that I'm actually participating in is, it's two drugs. It's a checkpoint inhibitor, and then it's an integrin inhibitor. And the idea is that the integrin inhibitor forms antigen antibody complexes on the HIV, on the virus. And then the checkpoint inhibitor uninhibits the T cells because in HIV, they're exhausted. They don't function properly. So the T cells will become active and control HIV without antivirals. So they're off their antiviral meds. So that's kind of where the research is going, more towards trying to control it without antivirals by having the immune system wake up and kind of, control the virus itself. So that's kind of early. The study that I have is like a phase 2. So it's kind of, and there's others. I don't know the other ones. I just know about this one because we're participating in it. But that's kind of what's going on in that arena. Uh-huh. To give them COVID? No, we've given it to thousands of people without any problems. It's not a live vaccine. Excuse me? Do I think it's a vaccine? Well, it induces an immune response and you get production of antibodies. So in my mind, that would be a vaccine. The ones that are contraindicated are any live vaccines like measles, mumps, rubella, the primary chickenpox vaccine, Varivax, or yellow fever, but only if their CD4 counts less than 200. If it's above that, it can be given. Those can be given even. The rest of the vaccines are pretty much not live vaccines. Hepatitis A, B, influenza, all those other ones. Any other questions? Okay, well, thanks for your attention. Again, I'm
Thank
sorry
you.
I ran late.
Thank you, Dr. Mara. Excellent. There'll be some refreshments, and we'll see you tomorrow morning. Thank you.
Thank you.
And it's raining all day. She loves to be one of the girls. She lives in a place in the side of our lives where nothing is ever put straight. turns herself around and she smiles and she says, this is it, that's the end of the joke. Loses herself in a dreaming and sleep, and the lovers walk through in their coaches. Pretty is the shit. Pretty it's a shit. Was on top of the notes and the flow.